us to update our medical knowledge.
The conference committee has worked very hard to present a program of exceptionally high standards. We have a very impressive list of speakers who shall be enlightening us in their respective specialities. We are sure that there will be a feast of knowledge in the offing throughout the day.
Our souvenir committee has worked hard to bring out a beautiful and informative souvenir which will be released by the chief guest. You can try your luck in cracking the MediQuiz 2022 compiled by Dr. Rajendra Trivedi. Fabulous prizes await the winners. We thank Dr. Rajendra Trivedi and Dr. Suresh Doshi for their hard work.
We sincerely hope that all delegates and faculty will have a wonderful time and will cherish the scientific feast, not to forget the gourmet delight. We would like to inform you that there will be lucky draw at regular intervals, but only those present in the auditorium shall receive prizes.
At the end of the conference, there will be lucky late bird gift and mega lucky draw of mind-blowing prizes. So please be seated till the end.
And to conclude, it is our promise that there will be excitement galore throughout.
Thank you for your kind attention. Long live IMA.
Friends, we start our scientific session with the first speaker, Dr. Avinash Phadke. And to chair this session, I invite Dr. Anil Pachnekar and Dr. Salim Sachani on the dais. Dr. Anil Pachnekar is past president of IMA Mumbai branch and IMA Maharashtra state, and is past national vice president IMA headquarters and chairperson resource committee. And Dr. Salim Sachani is past president of IMA Mumbai branch and chairperson registration committee. I request Dr. Anil Pachnekar to introduce our esteemed speaker, Dr. Avinash Phadke. Over to Dr. Anil Pachnekar.
Hi friends, very good morning to all of you. Nice to see you after 2 years face to face. Great moment for all of us. Friends, today's opening batsman is none other than the great personality Dr. Avinash Phadke sir, my beloved personality. Dr. Avinash Phadke is a renowned pathologist with a brilliant academic distinction. He is the founder of the Phadke Labs as well as the president and the mentor of the SRL Diagnostic in Mumbai. He is the director of the India Venture Healthcare Fund. He is postgraduate teacher with the Mumbai University and a guest faculty of Tata Institute of Social Sciences and Bhabha Atomic Research Center. He has participated in more than 400 national and international conferences. He has many scientific publications to his credit in both national and international index journals. He has earned many laurels and awards over the years like Professional of the Year Award by Maharashtra Times, Distinguished Doctor Award by IIM Mumbai Branch, Professional Achievement Award by the Quality Council of India, Maharashtra Corporate Excellence Award by Maxwell Foundation. Today he will deliver Dr. B.S. Bhende, B.S. Pense Memorial Oration and on case-based approach to pathology investigation. Sir is very kind, courteous and very well known for the philanthropic work. Dr. Avinash Phadke sir, please.
Page down. Thank you, Dr. Anil, and thank you, dear friends. It's after a gap of 2 years we are physically meeting on the event of annual conference. This is the 51st annual conference of IMA Mumbai, and it's my pleasure to be amongst all of you on a Sunday morning, and I'm delighted to meet you after a long time. The today's topic I have chosen is what our patients teach us. You know, what each case teaches us, rather than going investigations wise and giving you various causes that so and so investigation tells you so and so information. It is important the patient comes to us as a patient, and it is not written that what is the cause, what is the etiology, or what is the management, and that is how we learn from each patient. Now look at this patient. This is a common presentation for all of you. Patient having mild obesity, marginally elevated SGOT and SGPT level. Now you know SGOT, SGPT, normal value is up to 40. Alkaline phosphatase is marginally elevated, normal value is up to 130. Total protein albumin normal, bilirubin normal. A fairly common presentation. Now all of us know that in India, about 30% of us have fatty liver disease. Out of those 30%, at least 5 to 10% have NASH, that is non-alcoholic steatohepatitis. The difference between the two, we are aware that fatty liver is just accumulation of fat without fibrosis or active inflammation. While when you say NASH, non-alcoholic steatohepatitis, it means that there is early fibrosis and there is destruction of liver cells and hepatitis. So both are not synonymous. Out of total fatty liver patients, out of 10 patients, not even 1 or 2 will eventually go for NASH. So 10% of fatty liver would eventually go for NASH, and some of them will develop cirrhosis. Now you look at this percentage, it is frightening, because if 30% are having fatty liver and 10% of those 30%, which is 2 to 3%, are going to have NASH, some of them will end up with cirrhosis, so that leads to a very high percentage of them which will end up with cirrhosis. Now, we know that the commonest cause is metabolic syndrome, whether it's impaired glucose tolerance, blood lipid abnormalities, part of insulin resistance syndrome, hypothyroidism, obesity, variety of causes. But what we must remember that each patient is different. Now, this particular patient had a history of, family history of cirrhosis in the family. So we would take it very aggressively. No history of alcoholism. Underwent usual treatment. You know that there is lifestyle modification is the mainstay of fatty liver disease management. One is supposed to reduce weight. One is supposed to take vitamin E. In spite of that, not many patients would improve. Then there are newer drugs. You know, some people say you can take SGLT2 inhibitors and it will shift the visceral fat to the periphery. We have drugs like saroglitazar, which is approved in India, trade name lipaglyn, dose is 4 milligram per day. You can take that, and there are papers published by very renowned gastroenterologists that there is reversal of fibrosis with saroglitazar. So a very promising molecule. And now phase 3 trials are going on, but until now not approved anywhere in the world excepting in India. India, saroglitazar is approved for diabetic dyslipidemia as well as for NASH. World over, not yet approved. So that is the current status. So always remember that non-alcoholic fatty liver disease is to be taken seriously. Marginal elevations of OTPT and alkaline phosphatase would mean either a drug-induced liver disease or non-alcoholic fatty liver, and we should ask for sonography. If there is a strong family history, we would go ahead with fibroscan and even a liver biopsy. Now we know that these are a variety of tests which are undertaken for the diagnosis of fatty liver disease. After talking about fatty liver disease, we change our track. A young couple is approaching a general practitioner, sometimes a gynecologist also, or occasionally urologist. Now look at the male partner. His count is 25 million per ml. As per new WHO guidelines 2021, anything more than 14 million per ml is adequate. But his sperm motility is on the lower side, subnormal. Sperm DNA fragmentation is 27, which is again borderline. Anything above 35 is poor, and anything less than 15% is good. So, though the count is normal, the sperm function assays are not normal, the motility is subnormal. When the female workup is done, the lady's age is 35 years, and the AMH, anti-Mullerian hormone, is 2.8. Now, what would you advise this patient? So, what is this AMH? AMH, we all know, is a test which tells us what is the ovarian reserve. Unlike your FSH-LH progestogen, this test doesn't need timing with menstrual cycle. So, you can do it on any day of the menstrual cycle. FSH-LH prolactin ideally should be done between 3 to 5 days of menstrual cycle. If you're doing progestogen, that has to be done on 21st day of the menstrual cycle. But AMH can be done on any day. Now you will see that if the values are less than 2, it is a matter of concern. This patient's value is what we call satisfactory, that is borderline, though on the lower side. Normal range is 2.2 to 4, patient was having a value of 2.5. This we are increasingly seeing because the girls are getting married at the age of 30. By the time they think of conception, they are 33, 34. And I have seen many of them having a low AMH at that age. And then the treatment has to be more aggressive. So your advice to this patient in view of this AMH value should be, and subfertility element in male factor infertility should be aggressive management, and the patient should be ideally referred, this couple should be ideally referred to IVF clinic. Now, what is the use of AMH? AMH tells us what is the time left with the couple, what is the ovarian reserve. If it's an early menopause situation, some patients at the age of 36, 37 tend to have a high AMH value. We can predict that this lady is likely to have very early menopause. A low level of AMH reflects a poor ovarian reserve. AMH is generally high in all young patients with polycystic ovarian disease. You will see values of 6 to 8. This is because of increased number of granulosa cells in polycystic ovarian disease. So that doesn't mean polycystic ovarian disease has a better fertility than normal. So this reasoning doesn't apply to PCOD patients who tend to have higher values of AMH. So when I ask this question, that AMH is used for what? To determine quality of eggs, ovulation timing, ovarian reserve, or diagnosis of polycystic ovarian disease. The correct answer is, of course, 3. It is used to determine the ovarian reserve and fertility potential, not the rest of it. Now, this is a third case, very interesting case. This patient is a 55-year-old man. He complains of mild ankle edema. He is on antihypertensive ARB plus amlodipine, but he has a prominent penile edema, huge swelling in the penis, not responding to diuretics. Patient is visiting urologist for past few months. Physician has advised stopping of amlodipine, but the edema of penis is not reducing. Undergoes various blood investigations. Most of them are normal, marginal elevation of OTPT, albumin on the lower side, protein electrophoresis normal, conventional ECG normal. In view of persistent penile edema, the cardiologist was asked to opine on this case, and because of low ejection fraction on echo, patient underwent NT-proBNP and ST2. Now you know NT-proBNP is a marker for determination of heart failure, a prognostic marker as well as diagnostic marker. If the patient is responding to treatment, the NT-proBNP values will drop by 15 to 20%. ST2 is a relatively new marker. Normal range is 35. If you do both, it is much better prognostic marker than doing a single test. In general, mortality is more closely related with ST2 values than NT-proBNP values. Now, this particular patient has marginal elevation of ST2, but a very high NT-proBNP value. Now, this I have already told you, a low risk patient with ST2 is less than 35. Unlike NT-proBNP, where we have issues regarding patient having a lower GFR than 60, and most of us, believe me, if we do our estimated GFR after age of 60, 65, will be probably what we call a CKD 3A stage, which we will be below 60. And in that case, NT-proBNP is not a very accurate marker because it is also dependent on your renal GFR. So you will get values like 400, 500 when somebody's GFR is low. But ST2 is not affected by renal GFR, so both should be used in conjunction for management of heart failure patient. And Dr. Dilip Krupalani will be talking to you after this talk on how to manage heart failure in diabetic kidney disease, so probably he would cover some of it. SGLT2 inhibitors, you know, are newer. All glyphosines have revolutionized not only management of heart failure, they have revolutionized end-stage renal disease prevention in cases of diabetic nephropathy. So these two are commonest indications, and we have their glucose lowering ability is a third byproduct. I would say their main indications now are in management of heart failure and prevention of chronic kidney disease from progressing. The incidental advantage is a glucose lowering effect. They were introduced as essentially anti-diabetic drug, but their anti-diabetic properties, especially with low GFR, is very low. So you will get a reduction of 0.6, 0.5 in glyco-HB, not very potent, but clinical endpoints in terms of prevention, whether it's a credence trial or whether it is a DAPA-CKD trial, huge advantages. I will just mention few changes with SGLT2 inhibitors. Apart from glycosuria in the urine, you will get increase in hemoglobin count, probably because of increase in, not because of, as we anticipate, because of hemoconcentration, but because of increase in erythropoietin level. You will get increase in magnesium level. Potassium is not altered. These are the usual biochemical change. The most frightening change for a general practitioner is elevation in creatinine. You may see 20-25% elevation in creatinine, but this is a short-term hemodynamic change, and over a period of 2 years, especially when you cross 1 year, the GFR loss is actually minimized compared to patients who are not on SGLT2 inhibitors, and the newer FDA indication, Dr. Krupalani will tell you, have approved these drugs in non-diabetic CKD. So even if you have hypertensive CKD, you are allowed to use SGLT2 inhibitor. Now this is another patient, 80-year-old female suffering from chronic diarrhea. You know that the management of diarrhea, we give usually Metrogyl or Ciproflox or Ofloxacin, but what we forget is these patients tend to have sometimes fungal infections, sometimes C. diff, sometimes inflammatory bowel disease. Now, if you do fecal calprotectin, does it tell you? It just tells you that the bowel is inflamed. So if fecal calprotectin is normal, it virtually rules out inflammatory bowel disease, and it will be very unlikely it will be normal in cases of infectious diarrhea. So it doesn't differentiate between infectious diarrhea and inflammatory bowel disease. In both, it will be high. Now, this particular patient, we ran a BioFire panel, and patient was having C. diff. Now, we underestimate the importance of C. diff. So that's why this slide, any patient who is having chronic diarrhea, who has a history of antibiotics, especially elderly, who has leukocytosis, rise in creatinine, rise in CRP, rise in lactate, these patients need to be investigated for C. diff, because otherwise you end up with really bad situation. The treatment is either with metronidazole, but we are seeing only 80% respond to metronidazole, 20% don't respond. So vancomycin is the treatment of choice. In our country, you have a drug which is 500 milligram oral tablet, only from one company, that is Cipla. The drug's name is Vanbid. The dose you are supposed to give is 250 milligram 4 times a day for 3 weeks and then taper off. That 250 tablet is not available. So you will have to manage with 500 three times a day or something like that. Why I'm telling you this? Because these are real world situations when you will face this. And if patient is having repeated episodes of C. diff with multiple recurrences, the fecal transplant success rates are to the tune of 80%. So one indication for fecal transplant is multiple recurrences of C. diff infection, and the results are outstanding. And there was one done in Fortis Mulund recently in a very acutely ill patient. The patient was heading for hemicolectomy and the patient recovered. So it's important to remember this. Now we come to case number 5. Now this patient has come for general checkup because the family history of cardiac illnesses. Now you look at his lipid profile is normal barring HDL cholesterol on the lower side. So normally we wouldn't pay attention, we will tell him everything is fine. But when you do his HSCRP, it is high, it is 5.4. Then he also has early diabetes, glyco-HB 6.6. So because of HSCRP and glyco-HB, he needs to be managed very aggressively. So you know that HSCRP, it is nothing but CRP which is high sensitive. So you have all used CRP as a marker for COVID cases, for acute inflammation, because the half-life of CRP is only 24. So it's the first marker to rise and first marker to fall in COVID patient. Now we are not talking about that CRP. We are talking about very low levels of CRP in non-infective situations. Patient is not having infection, but you want to do HSCRP as a cardiac risk marker. So value less than 1 is normal, 1 to 3 is borderline. Now this patient, as you know, was more than 3, so needs to be treated with statins, not for high lipids, but because his HSCRP is persistently high, and that forms an additional risk factor for his heart also. So this is the importance that you need to look at HSCRP. The new marker I will just briefly mention. All of us have used troponin in acute infarct situation. It's diagnostic. In fact, it's in the definition of myocardial infarction or acute coronary syndrome, defines it by ECG changes and elevations of troponin. But recent years, including Indian papers, there are a number of studies which have shown that troponin I marginal elevations are indicative of impending heart issues. So it also serves as a prognostic marker. Just remember that. Now this is important because many patients with normal lipid profile will still have elevation of HSCRP and have to be managed. So when you are evaluating a cardiac risk, all of us have concentrated on lipids, but we need to concentrate more on IGT, lipoprotein A, ultrasensitive CRPs, and if needed, troponin I also as additional risk factors. This I have already discussed. This I will just tell you, this patient has come with a semen volume. What is surprising is not azoospermia. Azoospermia, you know, can happen, but the semen volume of 0.3 means the possibilities are only this. Either he has not had he had an incomplete semen discharge, or there is a ejaculatory duct obstruction or congenital absence of vas, or he has a retrograde ejaculation. So when you come across this situation, the patient needs to go for IVF because you cannot manage this with what probably these patients require is a testicular biopsy, and if the sperms are there in the epididymis, you do a epididymal aspirate, use these sperms and achieve conception. These patients are not amenable to treatment by what we call as vasoepididymal anastomosis because the block is beyond the vas. The block is at the level of ejaculatory duct. Now this particular patient is a patient which is, we must remember, this patient has complained of chest discomfort, presents with fever, hematuria, weakness in limbs. So we are suspecting it's TB with hematuria. Patient undergoes a cystoscopy. Cystoscopy is normal. MRI brain shows small infarct. So whether it is TB with renal involvement or what we are dealing with. Now this patient continues to have urine analysis, but further investigations revealed his RA test is weakly positive. CBC shows normocytic anemia, mild leukocytosis, inflammatory markers are high. He undergoes an autoimmune panel, ANA is borderline, but look at his C-ANCA. C-ANCA is very specific against PR3 antigen, and it is diagnostic of what we used to call Wegener's granulomatosis. Now we call it as granulomatous polyangiitis or GPA. In cases of GPA, C-ANCA will be positive in 90%, P-ANCA only in 10-15%. These are only acute conditions which rheumatologist meets in his clinical practice. Generally, rheumatologists are seeing cold cases. There's no medical emergency. But this is one case where patient presents with vasculitis is an acute emergency. Now, the test ANCA can be performed by indirect immunofluorescence as well as ELISA. You need to combine both to get a sensitivity of 98.5%. These patients then undergo treatment with either steroids or steroids plus rituximab, as a result of which they are likely to have pneumocystis carinii infection in the lung, and they need preventive Septran. So this patient underwent all this course, but the prognosis has improved fantastically. 10 years back, 15 years back, these patients used to do very poorly. In the beginning of my practice, the mortality was almost 60%. And now the mortality is reduced to 15-20%. Most of them go into remission and do fine with intermittent rituximab. And this is the last slide. Always remember that patient with mild CKD on treatment with thiazide diuretics, also taking antacids, there is a likelihood, sometimes he presents with ectopic beats or palpitations. Think of magnesium deficiencies. We don't commonly do this test. This patient had a low magnesium of 1.3. Always keep it in mind, especially thiazide diuretics and patient taking proton pump inhibitors. Easily corrected. These patients with supplemental magnesium, the ventricular ectopics completely disappeared. So one of the commonest cause of ventricular ectopics which is treatable is undetected magnesium deficiency. Uncommon in general population, but in a hospitalized patient, 20% have magnesium deficiency. In ICU settings, 40 to 50% will have magnesium deficiency. So don't ignore. Thank you, and I hope I have finished on time. Thank you so much.
Thank you. Hello. Sir, thank you very much for a wonderful oration.
I now request our President, Dr. Jitesh Mehta, along with our chairpersons to felicitate our speaker, Dr. Avinash Phorke, for the B.S. Pense Memorial Oration. Dr. B.S. Pense was a leading family physician and a founder member of IMA Mumbai branch. He was the president of IMA Mumbai branch in the year 1971-72.
For lucky draw, coupon number. For lucky draw. Hello. For lucky draw, coupon number 221-24. RJ Rathod. Is it there? Please raise your hand. Coupon number 104. Dr.
I
Avinash
now request Dr.
Gate.
Dakshani to felicitate both the chairpersons, Dr. Salim Sachani and Dr. Anil Pachnekar.
Dr. Girish Raut, 218. Go ahead. Check it, yeah. Yeah, go to that list.
Hello, hello.
Our, hello. Our next speaker is Dr. Dilip Kriplani. I invite Dr. Surendra Shingnapurkar and Dr. Dinesh Prabhu on the dais to chair this session. I request Dr. Surendra Shingnapurkar. Dr. Surendra Shingnapurkar is the Honorary Treasurer of IMA Mumbai branch and convener of the Research Committee. Dr. Dinesh Prabhu is the co-chairperson, Exhibition Committee. I request Dr. Surendra Shingnapurkar to introduce our esteemed speaker, Dr. Dilip Kriplani.
Good morning all. Dr. Dilip Kriplani is a consultant nephrologist and kidney transplant physician and assistant professor of nephrology at Bombay Hospital Institute of Medical Sciences. After doing his MBBS, he did his MD in general medicine from Manipal University, followed by DM nephrology from Maharashtra University of Health Sciences. He is specialist in dialysis, kidney transplant, and hypertension. He has done fellowship in nephrology at University of Ottawa. He has received many awards during his academic year, such as V.K. Krishna Prakash Gold Medal for Best Outgoing Student in MD, P.J. Mehta Young Scientist Award for Best Paper Presentation and Original Research on Hypertension. He has several publications to his credit in his field of specialty. He is a certified specialist in clinical hypertension by American Society of Hypertension. Today he will be speaking on how to protect heart in diabetic kidney disease. Over to Dr.
Thank you, sir, for the kind introduction. Good morning, everyone, and it's lovely to be back here at IMA. Thank you very much to the organizers for giving me this opportunity. So I'd be speaking on how to protect the heart in diabetic kidney disease. So I'll start with this hypothetical case. Mr. Laddu Peda Singh, a 51-year-old gentleman, long-standing diabetic and hypertensive, complains of history of dyspnea on exertion since 1 month. He's clearly obese, 86 kilos with a BMI of nearly 31. He's on metformin, glimepiride, chlorthalidone and amlodipine. His office BP by mercury is about 180 by 100. And his AOBP, which I'll explain to you a little later in the talk what AOBP means, unobserved automated blood pressure is 160/95, which is an oscillometric technique. His heart rate is 96. His ankle jerks are absent, suggestive of peripheral diabetic neuropathy. He's got some edema, and he's got some hepatomegaly, which is probably suggestive of fatty liver. His labs show a urine 2+ protein and a UACR of 360 milligrams per gram of creatinine. So he's clearly in what we call the macro, not the micro, but the macro albuminuric stage of diabetic kidney disease. And his creatinine is also abnormal at 1.4. And when we calculate his eGFR, it's just below 60 mils per minute. So he's in CKD stage 3A. His echo shows a normal EF, but significant diastolic dysfunction and LVH. And his fundus shows non-proliferative diabetic retinopathy. So he's long-standing diabetic. He's also hypertensive since 5 years. He has retinopathy. He has proteinuria. And he has an elevated creatinine. So the diagnosis is simple. This is diabetic nephropathy, or that term is now redundant today, so we call it diabetic kidney disease. He's in stage 3A of CKD, and he's got heart failure symptoms, but we'll put it as heart failure with preserved ejection fraction because his EF is normal. So we must remember, and I say this in a lot of my talks, that in the hierarchy of CKD care, the kidney is not the king, it's the heart which is the most important. So the heart is the king. Because as we know, the heart is the most important organ in all of our human bodies. It's not just for the CKD patient. For any of us, if the heart fails, the person is dead. So this is an old article from NEGM, and it doesn't even apply to CKD, but it shows how with advancing or rising glycosylated hemoglobin, the risk of getting coronary artery disease exponentially rises in direct proportion. And this was a big study on more than 11,000 patients who are just diabetic, and it shows that with poorer glycemic control, you get a higher risk of developing coronary heart disease. Now, there is a bidirectional pathophysiological interaction between the kidneys and heart in type 2 diabetes. And this is a slightly busy slide, but I'll try and make it simple. So what happens in type 2 diabetes? At the kidney level, you get increased renin-angiotensin-aldosterone system activation locally, even at the kidney level. You get, because of that increased RAS activity, you get rise in glomerular pressure, and that causes proteinuria, and that's the start of diabetic kidney disease. You also importantly get enhanced sodium reabsorption at the tubular level. What does diabetes do to the circulation? It causes vasoconstriction, and it also elevates blood pressure. And what does diabetes directly do to the heart? It increases both preload as well as afterload. And all this actually, when it goes through, ultimately pushes the diabetic patient in an advanced stage to both heart failure and progressive kidney disease. So you can see here the vicious cycle continues. The sodium reabsorption and renin-angiotensin activation at the kidney level causes more rise in systolic blood pressure because of volume expansion and vasoconstriction. The increased blood pressure and volume expansion causes increased cardiac preload and increased cardiac afterload, which ultimately starts to reduce cardiac efficiency, and that causes the cardiac complications and the renal complications. And the worsening heart failure then worsens the kidney disease, and this goes on like a loop, a vicious loop or a vicious cycle. So we nephrologists have become half cardiologists, I would say, or we would call it cardio-nephrologists, because as you can see, in a diabetic patient who's got hypertension, as the disease progresses, the kidney disease and the cardiac disease progress simultaneously. And as you can see, the base of the pyramid is the largest, and as we go from the bottom of the pyramid to the top, you can see the number of patients reducing in each phase, and at the end you got a very small apex of the pyramid, and this is because patients are dying along the way. And why are patients with diabetes and kidney disease dying? They're not dying of kidney failure, they're dying of heart disease, they're dying of coronary artery disease. In fact, I paradoxically tell some of my patients who reach dialysis or who need transplant that you are lucky. You are the lucky 5 or 7% who have reached the stage of end-stage kidney disease, or you need a transplant, because you have not died in the earlier stages. About 80% of CKD patients will die in much earlier stages of CKD because of vascular events, primarily heart disease and of course strokes. So the damage starts with proteinuria at the kidney level and simultaneously with LVH at the heart level. As the disease progresses, you get decreased GFR and more coronary artery events. And it's been shown in multiple studies that today the biggest risk factor of to get a heart attack is a low GFR. And this is in the absence of diabetes. So just an independent of diabetes, if you have a low GFR, you have a very high risk of getting a coronary event. So as the diseases progress, heart and kidney simultaneously, ultimately they go on to CKD stage 5. That's the ones who survive. And a lot of these patients with end-stage kidney disease will also be in heart failure. So in diabetic kidney disease, my cardiac target is threefold. Reduce the blood pressure to target, prevent worsening of coronary artery disease, and prevent and treat heart failure. And what is my approach to protect the heart in diabetic kidney disease? Achieve glucose control, but most importantly, without causing hypoglycemia. Reduce proteinuria with RAS blockers, control BP to target, but at the same time, avoid what we call the J-shaped curve. Avoid too much hypotension. So balance it out, because hypotension itself, when it's very severe, can be bad and worsen mortality. And I'll allude to this J-shaped curve towards the last part of my talk. Also, of course, lifestyle modification, dietary changes, weight reduction, And very important, as I've already mentioned, avoid iatrogenic or minimize iatrogenic complications. So treat the blood pressure and the sugar to target, but try your best to avoid overdoing it and causing iatrogenic problems. So the KDIGO, which is the Kidney Disease Improving Global Outcomes, this is the organization from the US which gives us nephrologists all the guidelines for our kidney patients. So this KDIGO is like our Bible, Gita, Quran. And it says that patients with diabetes and chronic kidney disease should be treated with a comprehensive strategy to reduce risks of kidney disease progression as well as reducing cardiovascular disease progression. So patients with diabetes and CKD should undergo what we call the cardio-kidney treatment. The cornerstone of this is blood pressure control, which is with the help of renin-angiotensin-aldosterone system blockade. But the other important thing in this is also glycemic control. And the new kid on the block here is SGLT2 inhibitors, which Dr. Phadke sir has already beautifully alluded to. And I'll give you a little more in detail on this molecule. So these are the two things which we need to work on the most, the blood pressure control and the glycemic control. And then, of course, lipid management, physical activity, lifestyle changes, smoking cessation, and aspirin are amongst the other things in this cardio-kidney treatment. So now I'll be talking primarily for the next 10 to 15 minutes on the blood pressure control, and before that on the glycemic control. So firstly, the sugars. Glycemic control practice points say that use the HbA1c to monitor glycemic control in diabetes with CKD. So use an individualized HbA1c target ranging from 6.5 to 7.5% in patients with diabetes and non-dialysis dependent CKD. So if the person is in pre-dialysis stage and is diabetic and he's young, you want to target an HbA1c as low as possible, around 6.5. But if the patient has already gone to a more advanced stage of CKD and is closer to dialysis, then the propensity to hypoglycemia is actually more. So in those patients, you may not want to be so stringent. So you will relax your target from 6.5 slightly upwards to about 7, 7.2. And in a very older patient, a much age-wise older patient, say in a 65-year-old, 70-year-old, where anyway the hypoglycemia tendency is higher, you may even relax the target to about 7.4, 7.5% HbA1c. So one size does not fit all, you individualize. Now, ongoing and completed cardiovascular outcome trials have shown that there are 3 groups of newer anti-diabetic drugs which have very good pleiotropic renoprotective as well as cardioprotective effects. One is the DPP4 inhibitors, which are the gliptins, which we are all aware of, which have been around for a long time. And then the 2 new kids on the block, the SGLT2 inhibitors and the GLP-1 receptor agonists. And this is a busy slide on what the American Diabetes Association recommends for CKD with diabetes. But this part is shown here in this black oval. And in the next slide, I've just magnified it, and I'll only dwell on this part because this applies to diabetes with predominant CKD or heart failure. So what it says, what the American Diabetes Association is saying, is that if a diabetic patient has heart failure or has chronic kidney disease, then the preferable drug today is an SGLT2 inhibitor, provided the eGFR is adequate. That means if the eGFR is more than 30 ml per minute per 1.73 meter square body surface area. Now, if the SGLT2 inhibitor is not tolerated by the patient or is contraindicated because the eGFR is already below 30, then you can you can use a GLP-1 receptor agonist with proven CVD benefit. And after using one of these 2 drugs, if the HbA1c is still above target, then you may use a DPP4 inhibitor except saxagliptin in the setting of heart failure. You may have to use or some other drug like a basal insulin. But very importantly, it says avoid the pioglitazone type of drugs, the glitazones, because they cause fluid retention. So the thiazolidinidones should be avoided in the setting of heart failure. And you can see here the sulfonylurea is lowest in the hierarchy. So the sulfonylurea is not a preferred drug because they are generally long acting, and if they cause hypoglycemia, the hypoglycemia goes on for a longer time. So sulfonylurea, not a preferred drug. So a simple glycemic treatment algorithm for patients with type 2 diabetes and CKD start with lifestyle therapy with physical activity, nutrition, and weight loss. Once you have that, go on to the two primary drugs like metformin and SGLT2 inhibitor. So what it's trying to tell us is metformin and SGLT2 inhibitor are the first line drugs provided in diabetes with CKD, provided the GFR is more than 30. Very important to remember that if the GFR becomes less than 30, whilst the patient is on metformin, you may have to reduce the dose or even stop the metformin. And very important to remember, SGLT2 inhibitor should not be initiated in someone who's already in CKD stage 4 or 5. That means if the GFR is below 30, do not start with SGLT2 inhibitor. Now, if the patient is already on metformin and SGLT2 inhibitor and you still need more glycemic control, then you need to obviously add further drugs. So the DPP4 inhibitors are preferred, certain insulins are preferred, and as I've said, if the SGLT2 inhibitor is not tolerated or contraindicated, then it can be replaced by the GLP-1 receptor agonist. And as you can see here, the sulfonylurea and the thiazolidinenones are not preferred in CKD because thiazolidinenones cause fluid retention and sulfonylureas can cause prolonged hypoglycemia in CKD. So what is the KDIGO recommendation for SGLT2 inhibitors? Sodium glucose cotransport 2 inhibitors. This is a 1A recommendation that in patients with type 2 diabetes, CKD and GFR more than 30, we recommend including an SGLT2 inhibitor in the anti-hyperglycemic treatment regimen. Notice the word, it's not hypoglycemic treatment. It is anti-hyperglycemic treatment regimen. So these drugs by and large do not cause hypoglycemia, which is one huge advantage. So this is importantly a 1A recommendation. And why is it a 1A recommendation? Because we have trials that these drugs are damn good. So empagliflozin from the EMPA-REG trial showed that compared to placebo, the death from cardiovascular causes was significantly less in the empagliflozin group, and the death, the hospitalization for heart failure in the EMPA group compared to placebo was significantly less. And you can see the placebo is shown in gray, the red lines are the empagliflozin. You can see how much separation it is between the gray and the red in both these panels, and both the p-values are significant. So this is a damn good drug. And then after EMPA-REG, along with that came the dapagliflozin trials. DECLARE was the first of the dapagliflozin trial, but this was not designed primarily for CKD, but it showed excellent cardiac endpoints. Then came the landmark DAPA-HF, which applied to heart failure patients with or without diabetes, and there were a lot of benefits, including renal and cardiac benefits. And then the landmark DAPA-CKD trial, which is the most recent, which again extended the role of SGLT2 inhibitors to beyond diabetes. So it looked at more than 4,000 patients with CKD and with much lower GFRs. You can see here the mean GFR in DAPA-CKD was in these patients was as low as 43 ml per minute, and it looked at patients with diabetes and without diabetes, and it looked at a primary renal endpoint which is shown here, which is more than 50% eGFR decline, end-stage kidney disease, renal or cardiovascular death, and you can see the relative risk or the odds ratio is as low as 0.6. This p-value is very highly significant. You can see after the decimal point there are 7 zeros and 28. So it's a very highly statistically significant. Dapagliflozin was compared to placebo. And then it looked at a secondary endpoint which was cardiac. Cardiovascular death or hospitalization for heart failure was also much less in the dapagliflozin group compared to placebo. This odds ratio is as low as 0.7. And again, this p-value is very significant, 0.0089. So both these trials, EMPA-REG and DAPA CKD showed lot of cardiac, and the DAPA CKD of course showed a huge renal benefit with the SGLT2 inhibitors. So it's been shown as the first drug to be used in these patients. Now, the KDIGO also says that the glucagon-like peptide 1 receptor agonist, or the GLP-1 RA, what does it say on this? It says that in patients with type 2 diabetes and CKD who have not achieved individualized glycemic targets despite use of metformin and or SGLT2 inhibitor, or are unable to use these medications for whatever reason, we recommend a long-acting glucagon-like peptide 1 receptor agonist. And this is again a strong recommendation. It's a 1B recommendation. So that's it for the glucose part. Now I'll dwell briefly on blood pressure. We know today that blood pressure, single or 2 readings taken in the office is not enough. And we also know that although we are using the mercury manometer still, in the Western world, the mercury manometer is hardly being used. In fact, it's been done away with in many countries. And what we go by is more oscillometric. So the triad of perfect 24-hour blood pressure control is shown here. That it's not just 1 or 2 readings, but you need a strict 24-hour average BP of less than 130/80. You need a reduced BP variability, which means that the morning BP surge should be absent or minimal, and you need a 10% minimum nocturnal fall in blood pressure, what is called the nocturnal dip. So you need all these 3, this triad, to have optimum cardiovascular protection. And in CKD, compared to patients without CKD, the incidence of the following patterns of blood pressure is very high: white coat hypertension, non-dipper, night rising of BP. What is night rising? It is a paradoxical rise in BP during sleep, or a reverse dip. And these are the patients who are at the highest risk of getting a heart attack early in the morning, because the BP doesn't remain same, it doesn't drop, but it actually goes up during sleep. Then of course masked hypertension, which is the opposite of white coat hypertension, is very common in CKD. So masked hypertension means that the office BP is normal or close to normal, but the home blood pressures are higher.
Sir, 3
And
minutes.
these patients are again missed by office readings. And of course early morning BP surge. So all these are more common in CKD with and without diabetes compared to non-CKD. So because you want to see all these,
3
you
minutes,
need
sir.
gold standard, which is ambulatory 24-hour ambulatory BP monitoring. But this is not routinely possible for various logistical and cost reasons
3 minutes
in every
remaining.
patient. So how do you do out of
3
office BP? You do home blood pressure. For
Hello.
home blood pressure has its advantages, and I prescribe it to a lot of patients, all my patients in fact. But again, home blood pressure also has certain limitations. It cannot detect the non-dipper, because the patient can't take his own blood pressure while he's sleeping. It does not detect night rising of blood pressure. It does not detect nocturnal hypertension, and it does not detect that early morning surge. So there are limitations of home BP. So we use automated, unobserved office BP. This is what I was talking about, the AOBP, which is a good surrogate for standardized office BP. So which is what we call the SOBP. So I'm really getting disturbed here. Everyone is talking here. So what is the method used for AOBP? We used to use the BP True from Canada, which I've spoken about you must have heard in some of my previous talks. But now we are using more and more of this machine, which is the Omron 907, which was used in the landmark sprint trial, which, what does this machine do? It gives you an average of 3 readings, and it shows you that average. And how do we use this machine? The doctor should not go into the patient's room. The patient is kept separate. The nurse or the trained ward boy or secretary goes and attaches this and leaves the patient unobserved. The patient is left alone, and over a period of time, 3 readings are taken in about 6 minutes, and then it gives us that average. And this was used in the landmark sprint trial. And remember, these are all oscillometric techniques. So what does the KDIGO guideline tell us on blood pressure management in patients with CKD, with or without diabetes, who are not yet on dialysis?
Last one.
We suggest that adults with high blood pressure and CKD be treated with a target systolic blood pressure of less than 120, provided the patient can tolerate this low BP, and when tolerated, using the standardized office BP technique, which I've shown in my previous slide. So remember, it depends on which technique you're using. If you are using mercury, then this is not the target. Then the target is still 130 or below. But if you're using the oscillometric and you're using it correctly, then you target this BP. So this is very important to remember in this guideline. So whether you have diabetes or no,
1 minute, sir.
you target this blood pressure of less than 120 by oscillometric technique, provided the patient is not on dialysis. So this applies to all CKD pre-dialysis patients. And remember, SOBP or standardized office BP does not mean your routine office BP, which I've already mentioned. So there are strict and difficult SOPs to be followed. And it has been shown that in many studies that AOBP or unobserved automated office BP is a good surrogate for standardized office BP. And then at the same time, we need to make sure we don't overdo it, because there is something called the resurgence of the J-shaped curve, which means that if we go too low, we will get side effects and we'll get increased mortality. And this has been shown from trials like the ON-Target and the INVEST, that the resurgence of the J-shaped curve is now back for on-treatment low blood pressure values below 110 systolic. So you want to target low, but you don't want to go so low that systolic and diastolic goes too low. And remember, during diastole is when your coronary perfusion occurs. So if you're, even when your diastolic goes below 55 or below 50, that is also dangerous. So you need to balance it out. And the first choice drug is the ACE inhibitor or ARB to be initiated in patients with diabetes, hypertension, and albuminuria. And these medicines should be titrated to the highest approved dose that is well tolerated. So there are a few practice points in these next couple of slides, and then I'll summarize on how to use the renin-angiotensin system blockers. You monitor changes in blood pressure, creatinine, and potassium within 2 to 4 weeks of initiation of a dose or increase in the dose of the ACE or the ARB. You continue the RAS blocker unless serum creatinine rises by more than 20% within 4 weeks following initiation of treatment or an increase in the dose. And very importantly, if a patient becomes pregnant whilst on these drugs, you have to stop the ACE inhibitor or the ARB, because these drugs are contraindicated in pregnancy. Hyperkalemia associated with the use of a renin-angiotensin system blocker is often managed by measures to reduce potassium levels rather than decreasing the dose or stopping the RAS blocker completely. But if the hyperkalemia is very difficult to manage, despite using newer binders, aside of K-bind, now there are newer binders like patiromer available. Now, if you have bad hyperkalemia despite these, then you will have to stop the ACE inhibitor or the ARB. Or if you have too much hypotension, you'll have to stop it. And remember, the ON-Target trial showed us that the combination of the two agents is dangerous. Don't use them together. Use one. Either use the ARB or the ACE inhibitor. And also a word on mineralocorticoid receptor antagonists. These are effective for the management of refractory hypertension, but can cause hyperkalemia, particularly when used in CKD stage 3B and in stage 4. So you have to use them with a lot of caution and very frequent monitoring of renal function and electrolytes. So dear friends, I'd like to conclude these last 2 slides. How to protect the heart in diabetic kidney disease. Glucose control using cardioprotective agents like either the SGLT2 inhibitor or the GLP-1 receptor agonist, or cardioneutral agents like the DPP4 inhibitors, because these have a lot of pleiotropic effects. Control the BP to target, but don't just use office readings. Use ambulatory BP, use out-of-office measurements like home BP, use the AOBP in your office. And most important, avoid iatrogenesis by properly selecting patients. So what do I mean by proper selection? Don't start a renin-angiotensin blocker in somebody whose serum potassium is already more than 4.8 baseline, because then you're likely to end up with potassiums of 5.7 and 5.8. Don't use an SGLT2 inhibitor in type 1 diabetes. It's contraindicated, clearly. Don't use an SGLT2 inhibitor in somebody who's prone to urinary tract infection, like enlarged prostate in a male or senile vaginitis in a female. And watch for side effects by frequently calling the patient to your clinic. Look for episodes of dehydration. We always tell our patients, if you get diarrhea or vomiting, stop your SGLT2 inhibitor temporarily, stop your ACE inhibitor or ARB temporarily, because in a dehydrated setting, these drugs are counterproductive. Monitor the potassium, monitor the kidney function, watch for UTI, ask for symptoms of UTI, and where the symptoms and the side effects are very severe, stop the drug well in time and inform the patient about expected rise in creatinine and what to do next. Thank you very much.
Thank you, Dr. Kripalani, for your excellent presentation.
Thank you.
Hello.
I request the chairperson. I request the chairpersons to felicitate Dr. Dilip Kripalani.
Hello. The lucky draw. The lucky draw results, the first person is Dr.
I
P.S.
also
Vaza.
request Dr. Usha Shah to felicitate the chairpersons, Dr. Surendra Shinglapurkar and Dr. Dinesh Prabhu.
Dr. Roth S.G. Our next,
I thank the chairpersons, sir.
our next speaker is Dr. Anil De Cruz. And to chair this session, I invite Dr. Girish Lal and Dr. Aspir Remalwala on the dais. Dr. Girish Lal is Honorary Secretary of IMA Mumbai branch, and Dr. Aspir Remalwala is Chairperson, Family Planning and Vasectomy Center, and Chairperson, Press and Publicity Subcommittee. I request Dr. Girish Lal to introduce our esteemed speaker, Dr. Anil De Cruz.
Dr. Anil De Cruz is Director, Oncology Services at Apollo Cancer Centers. He is a well-recognized global leader, clinician, researcher, and teacher in head and neck oncology. He has served as Director and Chief of the Department of Head and Neck Surgery at the Tata Memorial Hospital, Mumbai. He has undergone special training for head and neck surgery at the Sloan Kettering Cancer Center, New York, laser surgery at Vanderbilt University, USA, and speech rehabilitation at Indianapolis, USA. Dr. De Cruz is the first Indian to hold the position of President 2020-2022 of the Union International for Cancer Control, Geneva, Switzerland, comprising of 1,121 member organizations across 171 countries. His landmark contribution in management of next nodes is oral cancers was awarded the plenary of the American Society of Clinical Oncology. With more than 350 peer-reviewed publications and chapters to his name, Dr. De Cruz is on the editorial board of many reputed national and international journals. Today he will speak on addressing the cancer conundrum.
Good morning, everybody. Girish, thank you for the kind words. Jitesh, Girish, the other organizers, thank you for giving me the chance to share my thoughts today. I stand before you all both as a clinician, someone who's treated cancer for 30 years. I continue to treat. Head and neck is my specialty. But I also have a very interesting and a keen role in cancer control, both when I was director at the Tata Memorial Hospital and now as president of the Union International for Cancer Control. I'm not going to make it too specific. I realize that everybody is from a different background, but something key about cancer, which I believe every doctor must know. Jitesh gave me a very fancy title, conundrum, so I had to go to the dictionary and find out what it meant. But basically, it's a puzzle. It's something, but cancer isn't such a problem. So why should we know about cancer? What was cardiology in the 80s and 90s is cancer today. Here are world figures telling us that cancer incidence is increasing. 12 million in 2012, 18 million in 2018, and 19.3 million in November of 20. 1 in 5 men and 1 in 6 women will develop cancer in their lifetime. And at any given time, there are over 50 million people with a recent diagnosis of cancer. So it's a disease that's increasing year by year. But what's worrisome for us in India is that the incidence is increasing, but WHO projections tell us that it's going to be more in less developed countries. So at present, 2/3 of the cancer burden is in the Western developed world, 1/3 in our parts of the world. But by 2030, the pendulum is going to swing, and we are going to have 2/3 in our part of the world and 1/3 there, predominantly because of increasing longevity of our people as well as changing lifestyles. It's not only the incidence, but the mortality is also troublesome. Cancer is the #1 cause of mortality globally. 1 in 8 men and 1 in 11 women will succumb of cancer. And in our country, 2/3 of people succumb before the age of 70 in their productive years of life. So we see that cancer is increasing. It's a cause of mortality and it's a cause of concern in our country. And that's why it's very, very important for us to know about cancer. How do we outsmart this problem? There are 2 ways of doing it. One, could we decrease this increasing incidence of cancer? And second, how do we improve the outcomes of our patients with cancer? So we'll first look at what we as physicians can do to decrease the incidence of cancer. Now here is data from our country, from population-based registries as well as hospital-based registries, looking at more than 60,000 patients. There is a trend towards increasing incidence. So what I showed you earlier, global statistics, applies to our country as well. And the 5 leading sites of cancer are breast, lung, mouth, cervix, uteri, and the tongue. Of these 5 sites, 4 are preventable cancers. The incidence of cancer in urban India is double rural India. So truly telling us that cancer is a lifestyle disease in the majority of people who get it. So getting cancer to a large extent depends on our own habits and on guidance from physicians such as each one of us. And the most important lifestyle issue is tobacco. 40 to 50% of all cancers are tobacco related. Controlled tobacco and you wouldn't have these cancers. In our country, tobacco is socially accepted. You see it at every corner and it's something that people just believe is a lifestyle and there's nothing wrong in doing tobacco. That little kiosk photograph of the pawn shop that I've put up is bang opposite the Tata Memorial Hospital, the biggest cancer hospital in the country, and it's sandwiched between 2 chemist shops, just to show you that tobacco is so easily accepted in our country. Now, here are some figures about tobacco consumption in our country. 266 million of our countrymen take tobacco. Focus to the panel on the left. The blue bar in the center shows you that 42% of people will consume tobacco in our country. The figures in children between 13 and 15, and that's the middle panel, is close to 20%. And then again, if you look at the right-hand panel, people who are exposed to second-hand smoke, again at the risk of cancer, is 20%. Truly worrisome in our country. Majority of them take to the tobacco habit by 19. It's 18.7. This is a global adult tobacco survey in our country. So again, as physicians, if you focus your effort on those before 20 in your homes, among patients who come to you and they don't take tobacco, the chances that they will take is very, very minimal. 90% of people take to tobacco before the age of 20. Look at the panel on the left bottom. About 40% of people want to give up the habit. And then focus on the extreme right hand. Of people who want to give up, the success isn't high. But 16.8% of them are smokers. But among our smokeless tobacco users, only 5% can give up. So my third message to you all, when you commit or when you counsel your patients to quit, you need to put more efforts on those who chew tobacco rather than smoke. Generally, people who smoke are more willing to give up because the effects on your respiratory, cardiac tree are more. So people are more motivated to give up. But among the chewed tobacco, it's very, very low. And remember, head and neck cancers, the area of my specialty, is 1 in 3 in our country. It's only 4% in the Western world, primarily because of chewed tobacco. So again, it is us physicians who have a very key role. The second cause of cancer, and again something that we can do, are the 5 infections. They cause 20% of cancer. Epstein-Barr virus, which is seen in the northeast of our country for nasopharyngeal cancer, Helicobacter pylori, which are stomach cancer, the hepatitis, and the human papilloma virus. Together, these cause 20% of our cancers. Immunize your patients, keep your patients clean, we will decrease 20% of infection-released cancers. Again, as physicians, we must know in WHO in 2018 have said that they want to eradicate cervical cancer. One third of the global cervical cancer burden is seen in our country. And the WHO Director General in 2018 called for action that they want to relegate cervical cancer, a purely preventable cancer caused by the human papilloma virus, to history books. And what do we do as physicians? It is the 90-70-90 mantra. So 90% of girls should be vaccinated against HPV. And I'm sure in your practice, many people would come to you asking whether their daughters should be. It is a WHO recommendation, 2 doses of HPV vaccine. 70% of women should be screened. So ladies who come into your practice for other causes should be encouraged to have a simple pap smear. And if there's anything abnormal, 90% of them should be treated. And if we have this 90-70-90 mantra, we will have the incidence of cervical cancer 4 by 100,000, which is a rare cancer. And the third important part of cancer which we can prevent, and that's obesity. Everybody feels malnutrition is bad, but obesity, if you are obese, higher than the weight, your BMI is more, 10% of cancers are caused by that. It's linked to 13 cancers. There are various theories. It's more seen in females. So you have breast cancer, uterine cancer, esophageal cancer, kidney, pancreas, everything is weight related. So there are various theories. Basically, visceral fat leads to inflammation. cell multiplication. Some people postulate insulin resistance for that. And if you advise your patients to diet control, weight reduction, and exercise, it will help reduce 10% of cancers. Now, many physicians write multivitamins indiscriminately to their patients. And the belief is that vitamins are good for our patients. And yes, there are over 300 epidemiological studies that if you have a very good diet, rich in vitamin A, C, and E, what I call the ACE vitamins, it protects against cancer. So you must encourage your patients to have a rich diet in bright colored fruits and vegetables. But when you give them tablets, and here are 3 randomized trials more than 2 decades back, giving beta carotene, retinol, alpha tocopherol, and a non-steroidal anti-inflammatory aspirin. If you remember your biochemistry, beta carotene is a pro-vitamin A, retinol is vitamin A. Vitamin A was important for differentiation of cells. So people gave it in the artificial form. Absolutely no effect, and these are landmark publications with a large number of patients, close to 20,000. So indiscriminate vitamins not recommended. If a patient needs it because they're vitamin depleted, please write it. But otherwise, it should be in the natural form, and you will not have a high incidence. It will prevent against cancer. So briefly, please remember these figures: 4, 4, and 80. 4 modifiable shared risk factors help against 4 non-communicable diseases and prevent 80% of all non-communicable disease and deaths. So it's not only cancer. So if you protect against tobacco, unhealthy habits, you have physical activity, and not too much of alcohol, you would have a beneficial effects on these 4 non-communicable diseases. So briefly, I've finished the preventive aspect. I'll quickly shift gears in the second half of my talk on how do we improve outcomes of our patients who do get cancer. Look at these figures, and it's distressing. Abroad, if 3 people are diagnosed with cancer, only 1 succumbs. In India, the mortality to incidence ratio is 0.66, close to 0.7. That means for every 3 who are diagnosed, 2 die. So the number of people dying in our country are much more. Here is data a decade back looking at 9 Asian countries. We had the lowest survival figures. Look at breast cancer. We were 52 versus 82% in China. And if you look at the countries among these 9, I'm sure some of them have a lower GDP than us. I don't want to name the countries, but we have a highest mortality. Why does this happen? It's probably because of 2 things. One is diagnosis, and the second is whether we give our patients appropriate treatment, and quickly we'll go over this. 60 to 80% of our patients present like this, locally advanced. This is for oral cancer. Such a shame. As physicians, we should be able to guide our patients quickly to the doctor when it is stage 1. And I come back to the registry data from our country published last year. You can see for the commonest cancers, everybody, 2/3 is coming with advanced disease or metastatic disease. And this is 6 lakhs patients across 4 years from 28 population-based registries and 58 hospital-based registries. So it's uniform across our country that you'll get over 2/3 of our patients late. When I did a study twice in my career, at the beginning of my career and sometime in 2014 when I was at Tata Hospital, 50% of patients came late because of delay in the primary care physician diagnosis. Treating lymph nodes with tuberculosis without a diagnosis, hoarseness of voice, not sending to the doctor, treating with just anti-inflammatories and antibiotics. So I think as physicians, we need to be very, very vigilant. And they're very simple tests that we do. You don't need fancy PET scans to treat or diagnose most of the cancers. Oral cancer, you just need a torch to look into the mouth. Lung, a chest x-ray. GI tract, a stool examination for occult blood. Prostate, PSA, ultrasound. Breast, mammogram. Cervix, pap smear. Leukemia is just a CBC or a peripheral smear. Simple test, a couple of ₹100, but we must be vigilant. And I think what we need to be vigilant is what we call opportunistic screening. Don't screen everybody who comes into your clinic, but those who have tobacco, alcohol habits, those with a family history of cancer, those that have sign and symptoms, and the acronym for that is caution, and I'll show it to you in the next slide. It's not cost effective to send every patient for screening for cancer. So history, people who have tobacco, people who have sign and symptoms will get screened. And here are the warning signs for cancer. This is from the American Cancer Society. It's a free download. It's available on Google. Put the acronym called caution and you'll get it. So C stands for a change in bladder or bowel habits, a sore that does not heal, unusual bleeding from any orifice. If a person has unilateral epistaxis, has to go for a CT scan. 9 times out of 10, if the patient is above 40, will have a cancer. A lady with a lump in the breast, she'll just tell you, I don't feel my breast is good. Please send for a mammogram. Don't wait. It's become so common. In urban India, 1 in 20 women now have a breast lump. Indigestion, difficulty in swallowing. Khana hazam nahi hota hai. Please do an ultrasound and a stool examination. You will get our cancers in stage 1 and 2 with a 90% cure rate and simple treatment. So I think the onus is on us as physicians, on us, on each one of us to look at these warning signs and send our patients for appropriate treatment. We'll move to what is appropriate treatment. 50% of work I do as a referral surgeon is redo surgery. Someone has done something outside, it's half, and then the patient comes to us. Remember, in cancer, the first chance is the best chance. It gives you the best chance at control. It saves the patient psychological, emotional, and financial stress. So please direct your patients to the right specialist upfront. And here is a landmark NEJM publication that shows that outcomes depend on the volume of work a surgeon does. So we've shifted from general surgical oncologists to site-specific oncologists. So if you have someone who has a head and neck cancer, must be treated by a head and neck specialist. I do maybe 20 thyroids a month, which is one of the highest in the country for cancer. They come from all over. I see a lot of my patients who have been operated. Thyroid, anybody can take out, but they might fix the cord, give the patient parathyroid insufficiency, and most importantly, not clear all the disease. So please choose your referral base very, very clearly and send to site-specific. And here is data to show you that patients do better. There are a lot of advances. Surgery, we have the laser, endoscopy, robotic, microvascular. Radiotherapy, you have finer methods of treatment. Chemotherapy, we have targeted, precision medicine, immunotherapy, and imaging, we have MR, PET. One good thing about our country is all this is available. But is it available to all? And should patients benefit? The majority of them help in improving outcomes or the quality of life of your patient. And I'll only share 1 or 2 examples of what's latest and what you all should know. Proton, it's a fine form of radiotherapy. The Apollo group have it for the first time. I'm not here marketing, but just to tell you, Tata Hospital is getting it and it should start by the end of the year. When you give conventional radiotherapy, the entry beam and the exit beam, everything in the path gets radiated and there are side effects. Proton is a heavy ion. We give conventional radiotherapy with photons. This is a heavy ion. So you can see the cartoon with the tumor. The moment the beam comes, it decays in the tumor and there's a rapid fall off, as opposed to the blue curve that shows you what conventional treatment does. So there's absolutely no side effects in surrounding tissues. This physics phenomenon is known as the Bragg-Peak effect, and it's only seen in heavy ions. Protons, therefore, can be given to patients on all subsites with less side effects. You radiate a prostate, you're saving the bladder and the rectum behind. You radiate the head and neck. Between the two eyes, nothing falls on the eyes. Even if it falls, there's no damage done. So on and so forth across the various subsites in the body. Here is a patient of mine treated with proton, 70-year-old male. That's the dosimetry to show you that the dose is only falling on the tumor. 18 days into treatment, absolutely no burns in the mouth. And that's because you can do directed treatment. So that's something new, and that's something everybody should be aware. So if patients can and are willing to take this treatment, and it will be in our city very soon, it is something that should be kept in mind. There's something called personalized or precision medicine. We give a lot of new drugs to our patients, but an emerging school in giving drugs is called precision medicine, where we look at the genes, the environment, and the lifestyle. It's not about giving the same cancer treatment to every patient. One size doesn't fit all. So we take a biopsy from the tumor, look at actionable mutations, and then give a targeted drug. And I've just put some examples in lung EGFR mutation. So we can give an EGFR agent which acts. PD-L1, then we can direct our immunotherapy. So too for HER2 in breast, you can give trastuzumab. So today we are shifting, instead of giving the same chemotherapy to all, to directed chemotherapy. Some methods by which we treat our patients with advances in laser and the robot. And here is a patient of mine, and I'm doing something at the same place, excising a supraglottic larynx. We don't have to make a cutout, so some of the patients can benefit from this kind. It's very quick. It's a day care procedure, and you can send your patients home practically on the same day. We push the boundaries also of treatment. And here is a patient who's had a hemifacial resection, and you can see the flap that has been harvested from the leg. The fibula bone, 4 struts are made. We reconstruct the palate, the orbital floor, the zygoma, and the facial bone, and you can see a fairly good cosmetic result for someone who's had such massive surgery and excisions. I'm going to end with this slide of two very, very prominent global leaders. The one on the left, many of you all will recognize, is Richard Nixon. He was US President in 1971, and he at that time declared a war against cancer. He called what is called the National Cancer Act. 40 years later, Joe Biden renewed this war on cancer when his son got a brain tumor and died. So in 40 years, there has been progress, but mortality continues. And I think the cornerstone is prevention, early detection, appropriate treatment, and good palliation for our patients, something that I've shared with you in the last 20 minutes. So thank you for your attention. And I think in our country, tobacco is something that we need to work on. As I say, that lady is not mixing tobacco, but rubbing on a lifeline each time she takes tobacco. So thank you once again for the privilege to present to you.
Hello. Thank you very much. Thank you very much, Dr. De Cruz, for giving a detailed inside the cancer's conundrum. It's our irony of fate that most of the central and state revenue comes from alcohol and tobacco. And I think indirectly even the government contributes to your cancer causing so much of it. A small request from me that at IMA Mumbai branch we have started a vasectomy center at Haji Ali, which is working from Monday to Friday 9 to 5. There are two standees put at the information counter, registration counter. Please kindly go through that and try to refer your patient to us for our own program. Thank you very much.
I request our chairpersons to felicitate our speaker, Dr. Anil De Cruz.
Coupon number 039, Dr. Anil Patnekar. No name, coupon number 213. Coupon number 213. Anybody is there, 213, please raise your hand.
I request Dr. Sachin Patarkar to come and felicitate both our chairpersons, Dr. Girish Lal and Dr. Aspi Remalwala.
Coupon number 125, Dr. Vijay Karanjkar.
Friends, the next speaker is Dr. Farooq Udwadia. I request Dr. Hozi Kapadia and Dr. T. Rajgopal to be on the dais to chair this session. Dr. T. Rajgopal is the Chief Operation Officer of Breach Candy Hospital, Mumbai. Dr. Hozi Kapadia is the past president of IMA Maharashtra State as well as IMA Mumbai branch and is the chairperson of the exhibition committee. I request both the chairperson to escort Dr. Farooq Udwadia on the dais. I request Dr. T. Rajgopal to introduce Dr. Farooq Udwadia. This is a Dr. Dara Kapadia oration. Dr. Dara Kapadia was a very senior founder member of IMA Mumbai branch. He has passed his MBBS from Grant Medical College in 1928. He is the father of Dr. Hozi Kapadia.
So good morning, ladies and gentlemen. It's indeed my pleasure and privilege to introduce to you Dr. Farooq Udwadia. I think actually there must hardly be anybody in this audience who hasn't heard of or knows Dr. Udwadia, but nevertheless, I consider it an honor to introduce you, sir. Dr. Udwadia is a consultant physician and in charge of the intensive care unit at Breach Candy Hospital, and this position is held actually since 1964, training in the way hundreds of youngsters who are now clinical masters tutored under his able guidance. He graduated with a distinction in both MBBS and MD examinations at the University of Mumbai and practically won all the medals which were on offer at that time. He was awarded the Prince of Wales Gold Medal and the Dr. C.S. Patel Gold Medal in the MD examinations. He completed his advanced training at the Brompton Hospital and Middlesex Hospital in London. He's an eminent physician, author of many books, and one of the important chapters which he has written is on tetanus in the Oxford Textbook of Medicine. He was awarded the Padma Bhushan Award for his contribution in the field of medicine in 1987, and also the Dr. B.C. Roy Award later on. Dr. Udwadia was awarded the Master Fellow of the American College of Chest Physicians in 1997, and this distinction has been given only to 12 individuals across the globe. He received the third Claris International Critical Care Advancement Achievement Award. He is an elected fellow of the Royal College of Physicians of London and also of the American College of Physicians. In fact, he's the youngest fellow to have been awarded the fellowship from the Royal College of Edinburgh, and this distinction stands that he got it probably at the age of 37 or 38 years, if I'm not mistaken. And today he's going to deliver the Dr. Dara Kapadia oration on pyrexia of unknown origin. Before I mention about the oration, a point which I want to add here is that many of us have been really benefited by his long-standing mentorship, and he epitomizes the old values of ethics and integrity at any cost. The Dr. Dara Kapadia oration has been given in the honor of Dr. Dara Kapadia, who was a very senior founder member of the IMA Mumbai branch, who has passed his MBBS from Grant Medical College in 28, and He's the father of our own Dr. Hosi Kapadia. So Dr. Udvadia, it's over to you. Thank you.
Dr. Rajgopal, members of this dais, friends, colleagues, ladies and gentlemen. Before I start, I thought I'd like to thank Dr. De Cruz for a very illuminating lecture. The gene is going to be increasingly important in medicine and surgery today. I'm going to speak on pyrexia of unknown origin. I don't know if many of you know that the word pyrexia is derived from the Greek word pyrexis, which means burning or hot. And when we speak of pyrexia of unknown origin, we speak of a prolonged febrile illness which remains undiagnosed in spite of fairly careful assessment. Now, there are 200 and more causes of pyrexia of unknown origin, but it is worthwhile remembering that it is the common and perhaps not that common cause or causes which present in an atypical manner that are responsible for fevers of unknown origin. Now, it's been divided into 4 groups. In fact, a little more too, I'll just tell you. The classic PO, that is PO occurring in a previously healthy individual, that's called classic PO. PO in nosocomial patients, or in patients who are exposed to nosocomial infection. PO in neutropenic patients, HIV-associated PO, and recently they've also added PUO in solid organ transplants and hematological transplants like bone marrow transplants. The reason being that the causes in each of these subdivisions are a little often different, and you look at it in a different light. I'm going to talk to you on classic PO. Defined today, or not today, but say 10 years ago, as a fever of 3 weeks duration, more than 38.3 degrees Celsius on at least 3 occasions with no established diagnosis after a week in hospital. Now, when you say 38.3 degrees Celsius, it comes to about 100 degrees, a little more, 100.2 degrees Fahrenheit. So this is a description, or rather a definition, which was given about 10 years ago, and this is the current definition. Illness more than 3 weeks. Temperature again, 38.3 Celsius or 100.2 or so Fahrenheit. Or the fever can be lower than that, but you have laboratory signs of inflammation, and when we say that, we generally mean the erythrocyte sedimentation rate, CPR, and the procalcitonin. Yet no reasonable diagnostic hypothesis after initial diagnostic evaluation. It's worthwhile remembering that you don't need to get a temperature of 100 or more. You could very often get a temperature of 99 even degrees Fahrenheit or 99.5 degrees Fahrenheit. But if this fever, low fever, is associated with a rise in the ESR and the inflammatory markers, any other inflammatory marker, the C-reactive protein or the procal, it amounts to a pyrexia of unknown origin. And when you say initial diagnostic evaluation, now that's really important. In my day and time, when I was a registrar, the initial diagnostic evaluation was just a count, the ESR, an X-ray of the chest, and perhaps a barium study if needs be, and perhaps some small minor culture of the blood and culture of the urine. But nowadays, when we speak of initial investigation, diagnostic evaluation, it amounts to a great deal more. But if all these have been done, and very often they have been done before the patient is sent to us in the hospital, then they say, you define it as a pyrexia of unknown origin. Now, what do you mean by a minimum diagnostic evaluation? The first is the history. In my opinion, the clue of many an unsolved problem lies in the history. Unfortunately, a good history, a proper history taking, is a forgotten art or even a lost art. I shall tell you in a moment what I mean by that. And a meticulous physical examination. That too, I think, today, in view of the vast technology that you have, the vast number of investigations that machines can do, is also, to my mind, a lost art. Let me tell you how important a history can be. A patient comes to you with fever of unknown origin. He has nothing else to tell you. Have you taken a proper history? Have you asked him, has he had fever before? When did he last have fever? For example, a patient like this may have pain in the right iliac fossa 3 weeks back, or pain generally in the abdomen. The practitioner has given the patient antibiotics. The fever goes away in 4 days. The pain more or less subsides. He comes 3 weeks to you later with fever. What could he have had? If you had taken this history, you would have suspected, could he have had an acute infection in the abdomen, which was neutralized and treated by an antibiotic, but not properly so? And later, if he had, say, an appendicitis, if there was a small leak from that appendicitis, it would have tracked perhaps in the pelvis, and it could have caused a pelvic abscess. If you had taken that past history, you would have thought of that. You would have directed your attention to the possibility of an acute abdomen or a mildly inflamed viscous in the abdomen, ultimately leading to a small abscess. You would save the patient a lot of unnecessary investigations if you looked at it. Similarly, an acute cholecystitis, treated, everything fine. But then he comes to you after 3 or 4 weeks with pyrexia of unknown origin. He might well have a subphrenic abscess, or a patient with a severe urinary infection gets well, and 3 weeks later comes to you with fever. He could have a prostatic abscess. A patient with pneumonia, the pneumonia gets well. He had a small pleural effusion. That gets well, but then he comes running with fever again after some time, after some weeks. He might be having an empyema, a paravertebral empyema, which you can't see on a plain X-ray. The same with a diverticular abscess. Weight loss is important. If weight loss occurs because the patient says, I just cannot eat, it is extremely important that you investigate and make sure that he doesn't have a long, prolonged infective lesion, like just one example, tubercle, or perhaps, a pathology within the GI tract. The investigations now are many. These are the so-called minimal diagnostic evaluation that people say should be done before you say that there is a pyrexia of unknown origin. Almost always, by the time you do all these tests, the nature of the fever is usually apparent. Besides the inflammatory markers and the ANA and the ANCA and the markers for all autoimmune diseases and blood cultures, it's very important to do a blood culture before you start an antibiotic, because otherwise the blood culture is not that important. Urine cultures, chest X-ray, scans, USG abdomen, etc., etc. My best advice to you is your history and physical examination, besides the basic investigations. Your history and physical investigation should direct which line of approach you are going to take. What is the most likely possibility in a particular patient? And here, as I was telling from the history, you can see, for example, a pelvic abscess there, right down there. Is this the one? You can see this pelvic abscess here, for example, in a patient who had an acute appendix some weeks ago. And you see, for example, a perinephric abscess. Look at this large abscess which has pushed the kidney down after a severe nephritis or pyelonephritis everything all right, urine culture fine, and he comes back a month later with a pyrexia of unknown origin with a large perinephric abscess. And here is a subphrenic abscess resulting from a small leak from a gallbladder. Again, not at that point in time. The patient doesn't come with this at that point in time, but he comes some weeks later. And then there is a diverticular abscess here, as you can see, in a patient who had a diverticulitis. And this is a very interesting need. A plain, simple, ordinary pneumonia cured within 5 days of an antibiotic given just for 5 days, had a small pleural effusion which seemed to have gone completely, and he comes a month later with a pyrexia of unknown origin. Sorry, where did I go now? No. This is all. I must go back. Back. What have we done? This is the one I was telling you. This is an empyema, a small empyema in the paravertebral space, which can easily be missed. You wouldn't see it on a very good X-ray also. You would require a scan to see this particular thing. Now, a very important investigation is the ESR and the CRPs, the C-reactive protein. You must always do both of these because they don't necessarily run simultaneously. In other words, you may have a high ESR and a reasonably normal CRP, or you may have a very high ESR, a CRP, and you may have an ESR which is not that great. Both are very important inflammatory markers, and whichever is the highest is the one that you should take. When you have an ESR which is well over 100, you have a very, very good idea as what this particular individual or patient would have. He could have an abscess anywhere. He could have a chronic infection like, for example, tubercle. Most important, which is often missed, he could have a bacterial endocarditis. Tuberculosis is always on the list. Any cancer, malignant tumor, either a solid organ tumor or even otherwise, a lymphoma perhaps. He could have widespread metastatic disease, and that's the sad part of cancer. The patient sometimes comes with widespread metastatic disease for the first time with symptoms, not realizing that he has a primary which has metastasized. He could have an autoimmune disease, the classic example being systemic lupus erythematosus. There are many other autoimmune diseases. He could have a vasculitis. He could have a multiple myeloma, except that a multiple myeloma, remember, never gives rise to high fever unless there is a secondary infection. It's always a low-grade fever. He could have a thyroiditis, and he could have an entity called polymyalgia rheumatica. Now you see how a very, very simple laboratory test can guide you and tell you where to search for, what to look out for. You would be saving the patient, therefore, a lot of unnecessary tests and a lot of unnecessary investigations. So if you are stuck and say, I have looked at everything, I can't seem to find what the cause of the fever is, you must categorize the main headings in which pyrexia can occur. Infections, of course, and of these in our part of the world, tuberculosis. Tuberculosis is a remarkable disease. It can manifest in many ways, in many subtle ways, which really can escape your attention. It can cause a low-grade fever. It can cause intermittent fever. It can cause high-grade fever. And most important of all, while people don't realize, it is one of the causes of what they call a Pell-Epstein fever, which, as you know, classically occurs with a lymphoma. But I've seen it occurring in tubercle. Don't ask me why. You have a tuberculous lesion in the abdomen anywhere, and the patient runs fever, very often fairly good fever, and suddenly the fever goes away and come back again. So it's not just a lymphoma. It's not just a lymphoma that can give rise to a Pell-Epstein fever. You have tubercle which does that. Sometimes even ordinary infections do that. Pyelonephritis, for example, does that. For some reason or the other, after a period of 2 or 3 weeks, the fever goes away or almost goes away, only to come back. It's probably something related to the bacterium and the relationship between the bacterium and the immune processes within the human being. So it's worth remembering that. You can have protozoal infections, bacterial infections, you can have viral infections. Viral infections particularly, must remember, do not last generally for more than a month. You can't go on diagnosing a viral infection if the patient is running fever for a long time. The main viral infection which can last for a length of time, sometimes for as long as a month, is the EB virus, the Epstein-Barr virus. Sometimes the hepatitis B virus can give rise to a low-grade fever with joint pains, and the clinical features of a hepatitis may come 2 or 3 weeks later. But otherwise, all viral infections generally disappear within 10 to 15 days at the outside. Are we missing out on a lymphoma? And for that, you need to do imaging. But please do remember that a simple clinical examination which is thorough, for example, very often I have found 1 or 2 glands in the neck which look quite innocuous, nothing else found. You do a biopsy and you say, my gosh, he has a B-cell lymphoma, or he has tubercle, or he has a leukemia, an leukemic leukemia. So this is the importance of remembering that you use your eyes, your ears, and your hands in a thorough physical examination before jumping to unnecessary tests. Metastatic, I told you, metastatic lesions sometimes may be the presenting manifestation. And it's amazing, it's one of the important things in cancer that by the time the patient has a first symptom of cancer, the disease has spread widespread, and it is impossible to cure or even to do very, very much for the person concerned. You have multi-system inflammatory disorders. I'm sure everyone or every physician considers those and does these tests. Vasculitic syndrome. One important vasculitic syndrome, which I have seen perhaps more frequently these days, is an aortitis. An aortitis, which is typically characterized by inflammation around the wall of the aorta, sometimes on a segment of the aorta and sometimes for the greater part of the aorta. Takayuchi's disease, Kawasaki disease, and many others of those, and many others of unknown origin, perhaps connective tissue diseases also sometimes presenting with a non-specific aortitis, which is only picked up on a good MRI and on a good scan, PET scan. Granulomatous diseases, remember, tubercle is not the only granulomatous disease. You have sarcoid, it's a very important granulomatous disease. You have fungal infections, which are granulomatous disease. In some parts of our country, you have leprosy, which is also a granulomatous disease, and also can present with pyrexia of unknown origin. And when you examine the patient for lymph glands, it's worth recalling, I mean, I'm talking from past experience, you normally would examine the glands in the neck and the glands in the axilla, but you forget the glands in the groin. I shall never forget the time when I made a big faux pas, when in my student days I was asked to examine a patient. I examined the patient. I found nothing. I said, sir, I can't find anything at all in him. And he asked me, have you seen the groin? I looked at the groin, and the patient had large glands in the groin, and there lay the diagnosis. So the thorough physical examination, again, is so important. Then you have miscellaneous causes of fever. Factitious fever, habitual hypothermia, drug fever, venous thromboembolism, and a hematoma anywhere within the body can produce fever. What is factitious fever? This is important. The patient may want to have fever either to draw attention or for whatever reason. And he might be very clever. He might put the thermometer just at the time when the nurse is coming to examine the fever. If you think that he might be just looking, you're taking the mouth temperature, he might take something warm at that time. You need to be a really good detective to determine that. These are not at all uncommon. These are quite common. Habitual hypothermia. This is interesting. There are any number of patients who come to me saying that I have a temperature of 99 degrees every time in the evening, and they have been investigated from outside, from top to toe, and nothing has been found. Remember the definition of fever, of pyrexia of unknown origin. 3 weeks with at least on 3 occasions a temperature which is close to 100 degrees. And most important, if you have such a patient who has inflammatory markers which are normal, an ESR which is normal, a CRP which is normal, and there is nothing else, has not lost weight, there's no question that such a person has probably nothing at all. And particularly in the summer months when people take the temperature in the mouth, the temperature is always going to be 99. So in these months particularly, you must always insist that the temperature is taken in the armpit. Habitual drug fever, that's very important. Patients with drug fever can sometimes be very ill. And always at the back of your mind, you must put that there and say, may I perhaps cause, would this drug perhaps be causing fever? Almost any drug can cause fever, but some drugs more often than others. And in the ICU, the cause of sometimes a low-grade fever all the time is pulmonary thromboembolism. Small emboli thrown from deep vein thrombosis can give rise to a low-grade fever which may last for a long time. There's a rare cause of fever called periodic fever. It's a rare cause, but it's an interesting cause where a person runs fever for 15, 20 days, the fever goes away. It comes back after a time, goes away, comes back after 3 months. It's a recently described entity. It is related to a disturbance in the innate immune response of the body. And there are a number of reasons for that. But what does it produce besides fever? It affects organ systems. It's an inflammatory disorder, not an infective disorder. It can affect the eye. It can cause the liver and the spleen, which is enlarged. It can involve other organ systems in the body. And it is always associated with a rise in the ESR and the CRP. So it's a point which is worth remembering, one of the rare causes of pyrexia of unknown origin. And this is, of course, a classic picture of miliary tuberculosis. If you take an X-ray in a patient with miliary tuberculosis and the exposure is not just right, you will not see the miliary tuberculosis. And this is another picture of disseminated tuberculosis occurring all over the place, in the kidney, in the prostate. And this is another one with a large thing in the spleen and in other parts of the body. Look at the spleen studded with tuberculomas. And here again, another picture with a large adrenal neoplasm, and it looked like a neoplasm, which is really related to tubercle. And then you do, of course, selective testings. You might need endoscopies. You might need CT-guided biopsies. No examination of a PUO is complete without a bone marrow biopsy. Why? Because you may get granulomas only in the bone marrow, or you may get METs only in the marrow, or you may get a hemopoietic disorder like an leukemic leukemia only in the marrow. And no investigation of a PO is complete unless you have always also done a liver biopsy. These will be done last, not first. And a lumbar puncture. Remember a cardinal rule. If a patient comes to you with pyrexia of unknown origin for 3 weeks for which no cause has been discovered, never, never forget to do a lumbar puncture. A TB meningitis may be manifest with a pyrexia of unknown origin without any headache or vomiting, without anything else. So if you fail to a lumbar puncture, you will find that you will have missed the diagnosis. And lastly, the PET scan. Inflammatory disorders can be made out sometimes from a PET scan. In about 30 to 40% of cases, you're successful. Uncommon manifestations of common disease are extremely more important than uncommon. Disseminated tubercle is the most important. You may not see miliary lesions. You may not see tubercle anywhere in the body, but yet a disseminated tubercle may be there, and that can prove that only when the patient responds to anti-TB drug. Bacterial endocarditis, patients with culture-negative bacteria, or caused by fastidious organisms, or an aleukemic leukemia, where the blood, peripheral blood is normal, but the marrow is not. Giant cell arteritis, chronic meningitis. There are other conditions causing chronic meningitis. Remember drug fever, habitual hypothermia, and factitious fever. Thank you very much, ladies and gentlemen.
Thank you, sir. It was an excellent lecture, and you have enlightened us a lot regarding the causes of pyrexia. Thank you, sir.
I request our President, Dr. Jitesh Mehta, along with the chairpersons, to felicitate our speaker, Dr. Farooq Udwadia.
Hello. The first prize goes to Dr. Shedge RS. The lucky draw prize, Dr. Shedge RS. Second, Dr. Rajesh Kaku. The Dr. Shedge RS is number 62.
I request Dr. Usha Shah to felicitate the chairpersons, Dr. Rajgopal and Dr. Hosi Kapadia.
Our next speaker is Dr. Chetan Bhatt, and I request Dr. Girish Radhaksha and Dr. Kajal Ahuja to be on the dais to chair this session. Dr. Kajal Ahuja is Assistant Secretary, IMACG Mumbai Subfaculty and Chairperson Stage Managing Committee, and Dr. Girish Radhaksha is Vice President of IMA Mumbai Branch, Co-Chairperson Scientific Committee. I request Dr. Kajal Ahuja to introduce our esteemed speaker, Dr. Chetan Bhatt.
Dr. Chetan Bhatt is the Director, Department of Gastroenterology and Hepatobiliary Sciences at Sir H.N. Reliance Foundation Hospital and Research Center. He is the chairperson of IBS Task Force of Indian Society of Gastroenterology. He is a core committee member of IBD Research Group and Task Force of Crohn's and Colitis Foundation of India. He has been organizing committee member of International Neurogastrointestinal Motility Disorder and Indian Society of Gastroenterology Conference 2013-14. He has special interest in motility disorders and inflammatory bowel diseases and has started patients education group. He has won numerous scholarships, notably the Dr. A.J. Kohiyar Prize from Research Society, J.J. Group of Hospitals and Grand Medical College, and the Glaxo Merit Scholarship. He has several publications and presentations to his credit in the area of gastroenterology and has authored chapters in API Textbook of Medicine on diseases of peritoneum, liver and systemic diseases, and alcoholic liver disease. Today he'll deliver the lecture on Today he'll deliver Dr. Menda Salaskar oration on Update 2022, What's New in Refractory GERD. Over to Dr. Chetan.
At the outset, I would like to thank Dr. Jitesh, Dr. Girish, Dr. Attar, and Dr. Anil for giving me this opportunity, and thank you, members on the dais. I'm going to take you to the journey of GERD, which we all have treated for more than 3 decades, 4 decades, and still a given patient troubles us and is not better. If you see, these are all the differential diagnoses of refractory GERD. And if you go through the various nomenclature of GERD, non-acid reflux, weakly acidic reflux, weakly alkaline reflux, esophageal hypersensitivity, PPI resistant GERD, irritable esophagus, esophageal hyperalgesia, functional heartburn, and residual acid reflux. Each of these conditions means one and the same. But before that, we should know that reflux is not a disease to start with. It's a physiological phenomenon. Something called as TLESR. There's a lower esophageal sphincter, which normally relaxes when you take the food, and it closes again. And that is food-related relaxation of lower esophageal sphincter. Sometimes, when without food, the lower sphincter relaxes and there's a mild reflux which may not go up in the esophagus, but it becomes pathological when the patient complains of symptoms and there are troublesome complications with that. What is the real world scenario? In the real world, in the practice, you see something called as the NERD, that is non-erosive reflux disease. For common laymen, it is normal endoscopy reflux disease. Severe retrosternal burning, severe symptoms, endoscopy is normal. You report to a gastroenterology friend, he does the endoscopy, mild reflux, normal esophageal mucosa, no ulcers, nothing. And patients have excruciating symptoms. You wonder whether endoscopy is done rightly or not, which is almost 65% of cases. 30% of cases is erosive. You may find grade 1, grade 2, grade 3, grade 4 esophagitis. And in about 5% of cases, you may find complicated GERD. And before we go on to the refractory GERD, the common esophageal and extraesophageal symptoms and syndromes. Typical, you have esophageal reflux syndrome, reflux chest pain syndrome, reflux esophagitis, reflux strictures, Barrett's, malignancy, and you have extraesophageal symptoms like reflux cough, something called as a laryngopharyngeal reflux, asthma-related reflux, dental erosions, pharyngitis, otitis media, and pulmonary fibrosis. But you must remember one thing, that anything and everything in esophagus, the symptom is only one, heartburn. It is not necessarily acid. It's not the acid in the esophagus that is producing burning. If I complain of burning now, it may not be the acid, it may be the bile, it may be the volume, it may be the very transient micro drops of the acids. So, minute pH changes, motor events, non-acidic, that is bile, pepsin, and alkaline reflex, and you have a classical severe reflex. So this slide denotes everything. You have almost 30% of cases, which is primarily, which is related to here, acid exposure. And these are the people who do very well. You give one tablet of any PPI, they are better, they thank you, and they are fine. You stop after 2-3 months, and they are all right. Then there's another 30% of cases here. You give them a treatment, they're better initially, but not better later on. You have to add something else, or maybe liquid antacids, or maybe something else. These cases here, 20% of cases, they are not better with your treatment. You have to refer them to a consultant. He changes your prescription from one PPI to another PPI. He adds H2 blockers, he adds prokinetic, he adds antacids. Patient is better for some time. And last 20%, no matter what you do, they are not better, and you think these are psychiatric cases or this is psychological disease. So that brings us to a case scenario. You have given a PPI to the patient for a long time, significant period of time, and patient is not better. Or there is PPI failure. So how many percentage of the daily practice you have PPI failure? You will not see that much. I will see more because I see all referred cases which are high-end cases. So what we see is almost 40% of cases have PPI resistance and they do not respond to the PPI. And we'll find out the causes for that. So what is refractory GERD? If you ask somebody, you ask 10 gastroenterologists, what is a refractory GERD? Patient who has not responded to PPI at all, or patient who responded initially but now is not responding, there's a partial response. Patient has not responded to twice a day PPI, or patient has not responded at all to any medications. So now there is no clear-cut definitions. The wide variety of symptoms and wide variety of patient's presentation. So severity of symptoms, frequency, character of the disease is most important. But what is accepted now, one good PPI, which is like S-omeprazole for 3 months, or other PPI, twice a day for 3 months, and patient still has symptoms that is called as a PPI failure. So, how common is refractory GID? Refractory GID is almost 40% in your practice. And we see this refractory GID because these PPIs are not acting for one reason or another, or there is something else which was misdiagnosed as GID. So, what are the risk factors for GID and that to refractory GID? Obesity is the most important risk factor. A large hiatus hernia. How will a hiatus hernia produce resistant refractory disease? Large hiatus hernia controls the acid. When you lie down, there's a large amount of pulling of acid in the hiatal pouch. And when you lie down, this acid trickles into the esophagus at night time, and that is called as a pulling of acid in the hiatus pouch, and that produces reflux disease. Ineffective PPI-induced control, pepsin and bile. People forget that along with acid, bile and pepsin can also enter into the esophagus, and all these bile acids produces severe erosive esophagitis. Low esophageal sphincter tone or TLESRs, most commonly low post-reflux episodes of esophageal contractions. Moment you have reflux disease, the esophagus starts contracting and clears the acid in 2 or 3 contractions. If your contractions are very weak and acid is not cleared, you develop the resistant refractory GRD. Ineffective esophageal peristaltic contractions, esophageal hypersensitivity, and structural changes. So what should we approach in a refractory disease? First, alarming symptoms. Is there any dysphagia? If there is a dysphagia in reflux disease, it is not a normal reflux disease. If there is odynophagia, pain while deglutating, is not normal. If there is a bleeding, anemia, unexplained weight loss, persistent nausea and vomiting, and new onset symptoms in elderly person, or a very strong family history of malignancy, at least do one OJD before you start your treatment. So when you have refractory GID, besides your GID group which is not responding, what else are you missing? The differential diagnosis. So the differential diagnosis of refractory GID, this is my entire lecture slide. My entire lecture is this slide. So what happens? You have GID-related refractory disease on non-GID-related reflux disease. GID-related reflux disease, you have a normal esophageal acid, but still there are a lot of symptoms, or there is an abnormal acid and person is complaining. Or there is no GID, something else, but patient is presenting as a burning in the esophagus. So most important first one, that is functional heartburn. This is a very interesting condition. This terminology has been removed now and called as now in a Rome 4. We have Rome 1, Rome 2, Rome 3, Rome 4. Now the Rome 5 is coming in 2 years' time. So Rome 4 said that please remove functional. Functional means it is psychological. Replace this by idiopathic heartburn. So this is idiopathic heartburn now. The very interesting thing that person complains of severe symptoms, does not respond to your PPI. There is a very poor correlation with a reflux disease and normal esophageal manometry, no achalasia cardia, no diffuse esophageal spasm, and no other secondary causes. It's very poorly understood. I will tell you here one thing. In these cases where the endoscopy is normal, all other tests are normal, please do IgE, and food intolerance test IgG, not IgE. Most of these cases which were labeled as psychogenic or functional, that turn out to be nothing but a food allergy and food allergy related symptoms. And how will you identify this? This occurs mainly at evening time or night time. The waves of acid coming into the chest right up to the throat, and the severe burning in the upper part of the esophagus and not in the epigastric area. And this comes intermittently, only at night time, wakes the patient up from the sleep. Patient cannot sleep and patient remains awake at night time and is miserable next day. This is food intolerance, number 1. So what you do, along with your standard treatment and everything, patient is still not better, you may have to use SSRI or SNRI. Second is reflux hypersensitive esophagus. This is what we call it a NERD. NERD is a condition where endoscopy is normal, patient has severe symptoms. And what is this due to? This is nothing like an irritable bowel syndrome of the esophagus. With the slightest of change in a pH, normal pH if you say is between 4 to 7, even a 3.9 or 3.8, a micro drop of acid in the esophagus, patient has a very serious symptoms and he has a cough. So these kind of cases are basically non-cardiac chest pain, functional dyspepsia, and it's a non-acidic reflux. And basically it is a IBS of the esophagus. So here, one new therapy that is TLESR therapy you have to give, and this TLESR therapy is nothing new, it is a baclofen. Baclofen you give along with your standard PPI therapy, and the person has tremendous improvement in his symptoms. Next is, we know the standard classical reflux, but something is called as a residual acid reflux. What is residual acid reflux? Residual acid reflux, even with your PPI, even with your twice a day of PPI, or two different PPI or H2 blockers, person still has acid breakthrough at night time. This person complains of burning at night time. So what is happening? Most of your PPI work for 16 hours, 8 hours patient is without the PPI. And second, there is a cytochrome P40 metabolism of the PPI. There's various kind of pathways in that. So some of your PPI are getting fast metabolized and it is getting over in 8 hours rather than 16 hours. So that is important. So what are the causes? Number one is the metabolism of the PPI. So the bioavailability of the drug directly decreases, the efficacy decreases, and there is a drug mutation of hydrogen ATPase pump. So this proton pump gene mutation is uncommon, but we do see in a practice. So next is most important for you to identify, because this is most rewarding group. In this group, if you can identify these diseases, you have done the best part of your medical practice. And what is that? The causes, all these are secondary causes that present at refractory GERD, which people miss. And the most common of that is eosinophilic esophagitis. Eosinophilic esophagitis is a condition where the chronic immune-mediated inflammation of the esophagus, and this is mainly due to the allergen, food allergen or environmental allergen. It's mainly in adult and pediatric, and it presents around 30 to 40 years of age group, and the symptoms on average persist for 5 to 7 years before the good diagnosis is made, and it's very common nowadays we see. So how do they present? The most important part, only one simple guide I will give you. If your patient with resistant or refractory GERD says, Doctor, khana atakta hai, I have difficulty in swallowing, and that too intermittent. The first dysphagia, intermittent dysphagia to any food bolus, solid or liquid, in a person with a chronic GERD is your eosinophilic esophagitis. So only one question you must ask. First, do your food get stuck? Answer is yes. Second question, do you have allergic rhinitis? Do you have allergic dermatitis? Do you have eczema? Do you have any other allergic bronchitis or atopic dermatitis? If the answer is yes, probably it's the eosinophilic esophagitis. And this is what is missed by the endoscopists most of the time. This is a classical picture of eosinophilic esophagitis. You won't see this every time. So there is a strong association with the food allergies, environmental allergies, asthma, atopic dermatitis, celiac disease. Some of these cases you may have to do celiac disease. So what do you see on an endoscopy? You see normal in 5% of cases, but circular rings you see, linear furrows you see, and you see white papules you see, strictures you can see, or a small caliber. So this is one picture, and these are linear furrows if you see in esophagus. This is reflux esophagitis. And this is missed by young endoscopists or a non-gastroenterologist endoscopist. This is missed many times. And diagnosis, how it is done? You have to take a biopsy of the esophagus 4 centimeters above the GE line. Why above the GE junction? Because the mild reflux itself can initiate the eosinophilic response. So you have to take the biopsy 4 centimeters above the GE line, and more than 15 eosinophil in a biopsy is diagnosed as eosinophilic esophagitis. Next is gastroparesis. If your patient has got postprandial distress syndrome, epigastric dyspepsia, divided into 2 types. Initially we used to have 4 types, now 2 types. One is predominant epigastric pain syndrome and postprandial distress syndrome. Pain syndrome complains of recurrent severe pain. Distress syndrome, after food is very uncomfortable and he cannot lie down. So this is a gastroparesis or postprandial distress syndrome. Mainly you see in the diabetic conditions. Sorry. So you see this in pseudo-obstruction syndrome, Parkinsonism, you see in a diabetes, alcoholic, person on a various drugs you see. But what is important here, when a surgeon does, or a physician does an endoscopy, there's a large volume of food residue in the stomach. And you ask him, when did you eat your food last? Most of the people sometimes eat food late nowadays, youngsters. This gentleman says, I had a food at 8 o'clock in the evening, and we are doing endoscopy at 10 o'clock. Even after 12 to 14 hours, the food is still lying in the stomach. It's the gastroparesis. Most important, esophageal candidiasis. My almost 10 to 15% of refractory GERD is esophageal candidiasis because of diabetes, alcohol, steroids, autoimmune disorders, malignancy, chemotherapy, distal obstruction, CS stomach, and the grade 1, grade 2, grade 3, grade 4, esophageal candidiasis. This is a very important part, pill esophagitis. This is missed commonly. Why do you get a pill esophagitis? You get a pill esophagitis for 2-3 reasons. Number one, some people, they just pop the pill and don't drink the water. Arey, doctor, I don't need water. I can just take the pill like that. Or second, because of cardiac conditions, renal conditions, or cirrhosis of liver with ascites, you have restricted the fluid. So it should take only few sips of water. So it takes only 1 sip of water with 5 pills. So this pill remains stuck in the esophagus, it opens up, and most of these pills are acidic pH pills. The classical example is doxycycline. You have 2 types of doxycycline available in practice. One is a water-soluble doxycycline, which is pH 7, which is costing 10 rupees per tablet. And second, acidic doxycycline, which is costing you 10 paisa to 1 rupee, which is very cheap to get. So most of the chemists try to sell the cheap doxycycline, which is acidic pH. And if you've not taken a good amount of water, it remains stuck in the esophagus, it opens up, and the acidic pH drug produces erosive esophagitis. NSAIDs, potassium-containing drugs, even a simple Voveran, what tablet diclofenac you have diclofenac sodium, diclofenac potassium, correct? Diclofenac potassium will produce severe epigastric burning and retrosternal burning. Olendronic acid, steroids, Rydol, Ciplox, ofloxacin, all these drugs, any drug can produce if it remains stuck in the esophagus. This is achalasia cardia. Achalasia cardia is missed many times. There are 3 types of achalasia cardia. This is spastic variety, this is the classical variety of achalasia cardia, and the 3 types. Type 1 is the classical variety, dilated esophagus, tight G junction. Type 3, very spastic esophagus, but tight G junction. And type 2 is a spastic esophagus, but very tight G junction. So the 3 types, you don't have to miss this. Why people miss this? There's a very subtle give-way at G junction. If you miss that subtle give-way, the dilated esophagus, you miss the diagnosis of achalasia cardia. Various motility disorders, which present as a refractory. This diffuse esophageal spasm, now called as a distal esophageal spasm, which is mainly dysphagia to the food, while eating food, mainly dry foods, idli or dosa or dokla or something, you get stuck. And the manometry is very classical. Jackhammer esophagus, nutcracker esophagus, severe recurrent chest pain. Patient goes to cardiology OPD multiple times, ECG. You can diagnose this on a manometry. This is a jackhammer nutcracker esophagus. Viral esophagitis. I see this in 5 to 10% of cases. Why do I see this? All organ transplant, kidney transplant, liver transplant, bone marrow transplant, steroids, autoimmune disorders, cytomegalovirus infection, herpes virus infections. So if there is a history of chemotherapy or steroids or transplant, think of cytomegalovirus or herpes esophagitis. Peptic strictures. If you get a peptic strictures, it will present as a non-response to PPI and refractory GERD. And lastly, in the case of GERD, over a period of time, there is a change to the malignancy, and this malignant part presents the refractory GERD. I just had a gentleman coming from out of Bombay, reflux for many years, but now not responding to routine treatment. Somehow, he wanted to go that evening back. I said, no, I would like to do endoscopy. And I insisted that day. Next day morning, I did endoscopy. There was a lower esophageal malignancy. No symptoms, no weight loss, nothing, no loss of appetite. Just mild little burning in the chest. So malignancy can present like this. And lastly, volume reflux. Volume reflux is what? Volume reflux is basically in an elderly person, there is hardly any acid, but the food, bile, and non-acidic volume comes up. So once you rule out all these causes, what are the causes of PPI failure? Is it the poor compliance? The most common poor compliance is the cost, one. Change in the symptom. He feels better, he doesn't want to take the medicine, he is too smart. Side effects of the, नहीं डॉक्टर साहब मुझे लूज मोशन हो गया, I was not comfortable. डॉक्टर साहब कितना दवाई लेता हूँ, हार्ट का है, किडनी का है, ब्लड प्रेशर, डायबिटीज का है, I don't want to take too many medicines. And lastly, doctor, I want to control my disease with the Ayurvedic treatment or allopathy, homeopathy treatment. I don't want allopathy drugs. You don't take PPI. That is one. Second, is the patient taking PPI correctly? Some people take whenever they want to take, 1 hour, 2 hours before the food. Some people take after the food. Ideally, it should be taken 30 minutes before the food. Breakfast or a dinner, whatever you are taking twice a day. And it should not be taken with the milk or antacids. And more than twice a day, there is very little experience that it helps, except for the dexlansoprazole, which has got a twice layered tablet. One releases in the duodenum, second releases in the small intestine. That can be taken with the food. Escalation of the medicine. When do you escalate your drug? Number one, patient is not better with single day PPI. Change the PPI, number one. Still not better, make it twice a day. Still not better, 2 PPI with 1 H2 blocker at night time. You can do 30 minutes before the food. But more than twice a day PPI is not very beneficial. Switch to another PPI. Why do you switch to another PPI? Because esomeprazole is better than omeprazole or a pantoprazole or rabeprazole. Cytochrome P450 metabolism, CYP2C19 is the major pathway of all omeprazole, lansoprazole, pantoprazole. And another one, CYP3A4, that is for the elaprazole. And if you have rapid metabolizer, you will not have any response. So dose escalation, give H2 blocker at night time to control the variable symptoms. Why H2 blocker is important? H2 blocker is important because PPI controls only basal acid output. H2 blocker controls the meal-related acid output. So you have to give the H2 blocker at night time. And lastly, if the patient is still not better, give your alginic acid combinations. Why you give this? Because above the level of food at night time, there's an acid layer which is 1 to 1.5 pH, and that nighttime reflexes, you get a severe symptoms. So you give that, and in future you will get potassium competitive acid blockers, like various drugs you can read, and these are going to be the future of this. Thank you very much. Thank you.
Thank you so much, Dr. Chetan Bhatt, for a superb presentation. Friends, you all will agree, Dr. Bhatt is an excellent gastroenterologist, and more than that, he's a very good teacher, and that's why a very, very common topic like heartburn, he has covered every aspect, okay, from various presentations and how to manage this particular condition. So thank you very much, Dr. Bhatt. Thank you.
I request our President, Dr. Jitesh Mehta, along with our chairpersons, to felicitate our speaker, Dr. Chetan Bhatt.
Winners of the lucky draw, Dr. Reshamwala Siraj, number 252. Dr. Mandulkar, number 217.
Friends, the next speaker is Dr. Anirudh Kohli, and I invite Dr. Arjun Ahuja and Dr. Kezer Barot on the dais to chair this session. Dr. Arjun Ahuja is Chairman, IMA-MS Mumbai Chapter and Convener, Scientific Committee. Dr. Kezer Barot is a past President of IMA Mumbai Branch and the chairperson of catering committee. I request Dr. Arjun Ahuja to introduce our esteemed speaker, Dr. Anirudh Kohli.
Good afternoon, everyone. Dr. Anirudh Kohli has done MD, DNB, DMRD in radiology and is head of the Department of Radiology at Bridge Candy Hospital, Mumbai. Dr. Kohli has done his post-graduation from Garand Medical College, Mumbai. Dr. Kohli joined Bridge Candy Hospital in 1989 in MRI department and became head of the imaging department in 1993. Today we will speak on preventive imaging. Over to Dr. Kohli.
Thank you. Good afternoon. If you can have the lights slightly down, that'll help for the images. But that's fine, we'll move ahead. So my basic talk is going to be on preventive imaging. And I'm really going to start off with, I think, one of the most important aspects that we've seen over the last decade for preventive imaging, and that's coronary artery disease. This is the largest epidemic which is sweeping across our subcontinent. And where we are different from the West is that coronary artery disease hits us at least about 10 years earlier than Westerners. And when it hits early, it's more extensive, severe, and usually it is fatal if collaterals have not developed. So if one survives acute episode, there's usually significant compromised function. So younger people, and it really, we have this as a real epidemic with us. One of the important points is that nearly about 75% of patients who go for invasive coronary angio actually have a negative angiogram done. And a large number of individuals who have coronary artery disease are asymptomatic, and naturally they're not keen to get a relatively invasive test like an invasive coronary angiogram. So there was always a need for a reliable, non-invasive imaging tool, and the ideal screening tool would be what is non-invasive, which doesn't stress the heart because there are complications which may occur either doing mechanical or chemical stressing of the heart to demonstrate perfusion defects with other non-invasive techniques. So very important, any ideal screening test should not produce complications. We've had CT angio, which is really accepted as one of the most reliable non-invasive study of the vasculature, is because it's based on the same principle of catheter angio, direct visualization of the contrast in vessel. One of the issues that we've had over a period of time is that there have been technology-related issues. So you have had CT angios done which may not have had that great sensitivity to invasive coronary angio. And the reason why is a pure technological reason, because you have two types of CTs for CT angio. You have the single source and the dual source. The single source have issues regarding heart rate. You can't scan high heart rate. You need to beta block, bring down the heart rate. If the heart rate varies during the scan, the image quality is not great. With ectopic arrhythmias, they have problems. And then there are issues with calcium, and these are the things which really contribute to a lower temporal resolution with cath angio. So dual source CT today is the accepted norm. If you want a good quality CT angio which mirrors invasive catheter angiography non-invasively, you get a dual source CT, which is a CT which actually has two CTs inside it because it has two tubes and they rotate around together, and that's how they give better image quality and a lower radiation dose. And just to demonstrate to you, one of the important reasons we have also, compared to the West, we have a native higher heart rate. So these are just to show you CT angio images where you can see very, very nicely normal coronary arteries beautifully demonstrated at high heart rates. And I'll keep going up with higher and higher heart rates. Here 96 to 100, and you see a focal lesion here, very well demonstrated and very good image quality. 96 to 107, again, immaculate image quality. And then you move to 100 to 109, getting into higher heart rates, and still the image quality stays unchanged. 107 to 117, again, excellent image quality of the coronary arteries, all RCA, LAD, and the circumflex OM territory. Again, 109 to 115, and as I said, no beta blockers are required because heart rate is not an issue. Even high heart rates like 115 to 120 or even 125 to 136, you get excellent image quality. So heart rate is not an issue. Even with heart rate variation, like you see in this case, with this heart rate varying from 78 to 136, you get still pristine image quality available. Also with ectopics and arrhythmias, you see multiple ectopics during the scan happening, but if you see the image quality, it is really good. Even one area which was always considered no for CT angio was atrial fibrillation. Here you can see a patient with atrial fibrillation, and you still see very, very good image quality. So if we have very good image quality, we can scan any types of patients with a dual source CT. The real proof is how does it correlate with cath angio. So I'll just run over a few cases to show you how well we correlate with dual source CT with cath angio. You can see here a significant stenosis in the LAD here and seen very well on the cath angio similarly. Similarly here you have a plaque causing significant stenosis in the LAD, singular plaque here and poor distal flow, and that's exactly what you see on the cath angio, exactly mirroring exactly what you're seeing. Here's the VRT image of the CT angio, that's the cath image, and you can see this exactly the narrowing and the poor flow extending down. Again, another case out here where you have a subtle plaque out here. This is and you can see it quite nicely also on the cath angio, mirroring. I seem to have, okay. Yeah, sorry. Okay, and here again, a CT angio where you have a focal lesion in the LAD, very, very nicely seen on the VRT images, and similarly very nicely seen on the invasive cath angio, again mirroring it, and just showing the difference because post-plasty you can see the vessel opened up beautifully here. And here with multiple lesions, a soft plaque here, a more significant plaque slightly distally, and that's exactly what you see on the cath angio, small plaque there, but a significant distal plaque, again mirroring the non-invasive CT angio. Very good for bypass grafts. I do understand that that won't be in preventive imaging because you'd already have detected coronary artery disease, but since we're here just to show you that we get excellent pictures, a Lima graft, a normal Lima graft, but here's a SVG graft where you see a plaque in the mid-segment of the SVG graft. You can see that very nicely on the VRT images. So you're able to evaluate. Here's an SVG graft which you see coming off the aorta, and then it's totally occluded out here, and you don't see any distal flow here. And that's similar what you see on the VRT images. As far as stents go, more stents, CT angio is also good because you can see the stent here, but you can see within the lumen very well here. You have multiple stents out here in the RCA, but you can see in the invasive cath angio as well as on the CT angio that the lumen is patent. Here's an example with a CT angio where you have a focal lesion within the stent, in-stent stenosis, and that is mirrored beautifully on the cath angio also. Similarly here, we have in-stent stenosis within the stent out here. That's seen on the cath angio, and post-plasty, the vessel has been opened up very well. We do have certain limitations, and basically the two important limitations are calcium, which is much less with dual source CT, which is an issue, and then later I'll talk to you about how a new invention into a dual source CT is sorting the calcium problem out, and especially if sometimes thin stents, we may be not able to look inside the lumen. Calcium is a problem, especially when it is eccentric and luminal, when a short segment cannot be seen. Generally, it's been said that if you have a calcium score above 800, don't do a CT angio. That's really not true because you could have a calcium score, like I say, of 2000 here, where the calcium is all just along the wall and not within the lumen. Here's another one with calcium score of a 3000. You see the calcium, it's all along the wall and not within the lumen, and the lumen is patent. And this patient went on to have a cath angio, which showed the lumen to be patent. But this is the times when we do have problems. When you have a small eccentric calcium blob here, what happens on CT angio is the calcium actually looks bigger than what it is on CT. So it blooms and obscures visualization of short segments of the coronary artery. We have techniques where we can reduce the calcium bloom with software, and we managed to reduce the bloom there where we were able to see this plaque, a soft plaque out here, which was confirmed on cath angio here. But occasionally, we do still have problems with calcium. Like, for example, here, where there is calcium plaque here, obscuring lumen, but fortunately in another coronary, we could see that there was also calcific plaque with soft plaque here, and that was good enough for us to recommend that the patient needed further evaluation, which was seen on the cath angio. So, but then you have times like this where we have calcium obscuring the lumen out here. We can't look within the vessel at all, and in these times we need further help. And the main help that we usually do is doing a cath angio, and you can see that there's dense calcium here obscuring the lumen, but the cath angio is normal. So this is one limitation, and I'll come to you how we sort this out. This is a thin stent with multiple struts where we're not able to look inside its lumen. A very important point to remember about CT angio, since it's not a dynamic study, we hear a lot of physicians say the flow is very good below, so it's fine. Not at all. This is not a dynamic study. So by seeing the vessel below and contrast in the vessel doesn't mean that there is no focal stenosis here. And that's an important point to remember. So invasive coronary angiography has long been considered the reference standard technique for diagnosing coronary artery disease. And the essential way a decision is made for revascularization is based on what we call the oculostenotic index. The cath angio is looked at, the cardiologist says, I see it's a 70% lesion, it's a 80% lesion, a 90% lesion, and intervention is done. They take a cutoff of 70%, below 70%, they don't intervene. But there are limitations of this visual interpretation between two cardiologists. They may observe a variability. Also, technically, that there are a lot of factors which influence flow dynamics in a vessel. They may be because it's a focal narrowing, maybe a diffuse narrowing, maybe if it's of single or multiple sides, the lesion length, shape, eccentricity, and what is the state of the collateral circulation. So for that has been devised what is the technique known as fraction flow reserve. This is basically the maximum achievable blood flow if there is a stenosis. So beyond the stenosis, how much is the blood flow? Because that's important, because is the myocardium getting adequate blood flow or not? And based on that, an FFR above 0.8 is considered hemodynamically significant, whereas below that is considered to be hemodynamically significant and do require revascularization. So FFR measurements are very, very important. And for that, the studies have been done, and the famous study is the FAME study, which looked at fractional flow reserve versus the oculostenotic index for angiography in deciding percutaneous intervention. And what they found in that, which is a huge study, that 70 to 90% of the patients who would naturally get stented because of the oculostenotic index, actually 20% of the lesions had an FFR greater than 0.8. That means they would not benefit by a stenting procedure. What they further found was that 50 to 69% of oculostenotic index, where it would be said below 70, we can medically manage, we'll hold on. 65% of lesions had FFR greater than 0.8. That means 35% actually would have benefited from stenting. So this has led to a paradigm shift towards using functional significance of coronary lesion rather than anatomic severity of a coronary stenosis in making the decision for revascularization. And this, and this has further been, in the further FAME study, they found that angiographically guided PCI versus FFR guided PCI with a threshold of 0.8, that there was a 72% risk reduction of the composite endpoint, which was either myocardial infarction, death, or need for a repeat vascularization at 1 year follow-up. So this is a dramatic shift when you use FFR to make the decision rather than just the oculostenotic index. And of course, long-term follow-ups have confirmed this. FAME2 was where they used medical therapy and stenting FFR positive lesions versus medical therapy only. And in fact, this was stopped prematurely because there was a significant difference in the primary endpoint. So confirming that stenting helps, but very important, stenting helps when you use FFR. And there were further studies like the DEFER and COURAGE, which really showed, the DEFER showed that non-flow limiting lesions do not require intervention. Outcomes with optimal medical therapy had an annual myocardial infarction rate or mortality of only 1%. And COURAGE study looked at the clinical outcomes utilizing revascularization and aggressive drug evaluation. Therefore, the flow limiting benefit, and non-flow limiting had little benefit or harm. So in conclusion, the current guidelines stipulate that the decision to revascularize should be governed by hemodynamic significance of a lesion rather than angiographic severity. And for that, it's important to have this decision before you do a cath angio, because you've anyway gone on to do an invasive cath angio. So for that, now we have a great new advantage with the dual source CT of CT-FFR. So non-invasively, it can be computed, the whole fluid dynamic structure of the coronary artery tree. It's non-invasive, no adenosine is required, and all this is based on that. It has excellent correlation with invasive FFR, and even studies here have shown, and the Ripcord study was quite dramatic, where it showed that there was a change in clinical management in 36%, decreased need of ICA by 44%. That means 50% of the patients, based on CT-FFR, did not need to actually undergo an invasive cath angio. And here are examples of CT angios with CT-FFR. Here's an obvious lesion, which you can see, osteostenotic lesion seen on the VRT, and you can see the FFR, CT-FFR, non-invasive, showing it to be totally red. Here's one where it really helped us, where there was a focal stenosis in the OM, seen on the VRT's images, seen on the cath angio here, but the CT-FFR actually had shown that the values were above 0.8. It was not red, which is below 0.8. And here's the invasive FFR, which was done for confirmation, showing it to be 0.86, so correlating beautifully. Here is where really CT-FFR helps us. We have a calcific lesion out here. We can't see the vessel. There's blooming of calcium. You can't look inside the vessel. And when you see the CT-FFR, you can see that there's a tight stenosis here, and there's a considerable drop in flow, and it's red. And that's exactly what we saw on the cath angio, and then post-plasty, the vessel opened up beautifully. Again, examples to show you the similar features. So it's very useful when you have a plaque like this, moderate stenosis, approximately 50% stenosis, what to do next, cath angio, you do the FFR, and you can see that there's hardly any flow limitation. Of course, the cardiologist did a cath angio, and he found that the FFR was similar to the CT of 0.84, so not requiring any form of intervention. And this is an example to show us where, again, where it really helps us in reading CT angios and moving further. You have a soft plaque here, again considered to be about a 50% narrowing, not looking that significant, but the FFR was significant, and patient benefited significantly from stenting. So as far as CT-FFR goes, it's a very valuable non-invasive tool in addition to the anatomical CT angio, because it provides important functional information. And that's really, it helps us to decide whether to cath or not to cath, and it's helping as a problem-solving technique. Moving off coronary, which is a big area, I think, for preventive imaging, breast cancer has been one of the initial ones which came into preventive imaging, because it was found that breast cancers detected before they become symptomatic or palpable, there's a 50%, they can have a 50% reduction in death rate. So which you have screening mammography, which uses a low-dose X-ray examination of the breast to detect breast cancer, and 70 to 80% of non-palpable cancers can be detected by mammography. So there has been a considerable improvement in the technology helping us detect, improve our detection rate, and this has been with digital mammography, with a tomosynthesis. And one of the arguments against mammography has been that it uses radiation, so the techniques have come in to reduce the radiation, what's known as a C-view. And we have techniques to characterize the lesion, elastography and biopsy techniques. Here's an example, a mammogram, and the problem that we face as radiologists on mammogram is that cancers are white and glandular parenchyma is white on a mammogram. So it's difficult to differentiate, and that's where tomography has helped us. Tomography, like CT, gives us thin slices, and very nicely you can see uncovered with the slices a spiculated mass lesion here and a small cancer detected beautifully. So tomosynthesis is very, very important today in the evaluation. The problem is that with a tomosynthesis, you also need to do the 2D, and they add up to radiation, and that's where you have what we call a C-view helps us, where the C-view is actually only a tomo, so only the radiation of the tomo happens, and that is added up to produce a synthesized 2D view, and that's helping reduce the radiation. Another example to just show you how TOMO helps us, where we're picking up a mass lesion here, which was not visible on the routine mammography. And elastography of the breast is useful, sonography, elastography, to tell us how hard the lesion is, and that sometimes is the indicator towards malignancy. And we have biopsy techniques like wire localization. When you have microcalcifications here, which can't be seen by the breast surgeon, how does he get to them? Once you detect them on a screening mammography, you need to follow it up to prove the diagnosis. And under mammo, we can put in a wire directly to the microcalcification, so the surgeon just follows the wire and he can get the tissue out. Breast MR is also very useful because higher sensitivity than mammography, because sometimes mammography, the lesions are occult, and they can be very nicely seen on breast MR. We have also contrast kinetics, which can tell us and give us an idea whether it's malignant or benign. And another advantage of breast MR is, especially if lesions are multicentric. Prostate CA, 1 in 6 men will develop prostate CA in their lifetime. PSA screening is very useful, but can be non-specific, and that's why multiparametric MRI has become very useful for detection, staging, and multicentricity. Prostate CA has also a wide spectrum of aggressiveness. Some men may actually, the cancer will outlive them, and maybe they didn't require treatment. So MRI is also evolving as a non-invasive Gleason score. And just to show you multiparametric MRI, multicentric area of involvement, MRI is very sensitive at picking up. This is a very small prostate cancer, tiny lesion, but picked up really well. And also, MR is useful to tell whether it's gone out of the gland for the staging as what needs to be done. And finally, I want to talk about another very important area coming into preventive imaging, and that's fatty liver disease. You have alcoholic fatty liver disease, and very important now, thanks to insulin resistance, metabolic syndrome, you have non-alcoholic fatty liver disease, which is a global pandemic considered to be nearly 25 to 30% of the population. The issue about non-alcoholic fatty liver disease is that it is a broad spectrum disease. You could have mild hepatosteatosis, you can have severe hepatosteatosis, you can have it progressing to cirrhosis, and as soon as it progresses to cirrhosis, there's an increased incidence of hepatocellular carcinomas. Also, you get rising incidence of atherosclerosis, cardiovascular disease with metabolic syndrome. Of course, the gold standard is liver biopsy, but you can't do it all the time, and often you don't want to do it because it's invasive. It samples a small portion of the liver, so it's not representative because fatty infiltration may be heterogeneous and cannot be repeated. So the role of imaging is, one, to detect fatty liver disease, quantify the fat content because it's important, because we will want to monitor the fat content and see how treatment is helping and whether fat content is going down. Second, very importantly, we want to detect fibrosis because early stage fibrosis can be reversed, reducing the incidence of cirrhosis and hepatocellular carcinoma. MRI is the most accurate and sensitive means for detecting fat and fibrosis in the liver. Fat content, we use chemical shift imaging and MR spectroscopy, and for fibrosis, we use MR elastography. So we can use chemical shift imaging where we see a drop in the signal, and this can be actually quantified, and we can get the actual signal fraction of it. Here it's 22%. Normal fat liver, 5%. This is 22% severe fatty infiltration. MR spectroscopy does a similar job. We get the water peak and the fat peak separated and get the exact quantification of the amount of percentage of fat in the liver. MR elastography is very useful because it detects fibrosis. External applicator applies a mechanical stress and we measure the strain, and it's non-invasive. We get color map pictures. Red is bad because that is showing significant fibrosis, and you get a standard deviation. This is 5.9. And when we look at the entire spectrum, this is the classification. And here are just examples to show you one with 2 kilopascals normal, 4.3 stage 3, 4 fibrosis, 5 which is cirrhosis.
Sir, one more
and this
minute.
is just to show you when we follow up the lesions as to, you can see from 2019 starting with 4.4 going to 3.4 and 3.1 and improving with time. So I will conclude here as to just that coronary artery disease, I didn't talk about carotid stenosis, intracranial vascular malformations, important, breast CA, prostate CA, of course, oncology, looking for tumors, especially in, like, say, lung CA in smokers, fatty liver disease, a very, very important component today. Thank you very much.
Thank you very much, Dr. Anil Kohli. You have given us a very good intensive explanation as to how the angiography results, CT angiography results can be compared with the invasive angiography, and also the various others this thing in diagnosis of cancer and breast cancer, prostate cancer was very good. Thank you very much.
I request the chairpersons to felicitate Dr. Anil Kohli.
Come, sir. Stand here. Chalo.
I request Dr. Kohli to do of all IMA doctors CT angio at a discounted rate.
Lucky draw number 116, Dr. Rajesh Gayakwad. There, please raise your hand.
Our next speaker is
Request-
Dr. Bhavesh Popat, and I invite Dr.
Lucky draw
Arvind
number
Patel and Dr.
243.
Usha Shah
I
to be on the
Dr.
dais to
Kajal,
chair
I
the
request
session.
you to felicitate Dr. Arjun Ahuja and Dr. Kejar Barot.
I request Dr. Arvind Patel to introduce our speaker, Dr. Bhavesh Popat.
Lucky draw number 278, Nikam Lalit.
Good afternoon, everyone. Dr. Bhavesh Popat is an experienced vascular and endovascular
Lucky
specialist.
draw number 49. Sucheta.
Dr. Bhavesh Arun Popat is an experienced vascular and endovascular specialist, a KM Hospital alumni with multiple publications to his credit. He is well recognized all over India for his work in vascular diseases like varicose vein, DVT, aneurysms. He is a postgraduate teacher of MUHS and currently practicing in almost all the corporate hospitals of Mumbai. He is a proctor for Boston Scientific and Bard. He travels across the country operating complex vascular cases. He has started a fellowship program for peripheral vascular diseases. Today, we will hear from him Dr. G.V. Deshmukh oration on recent advances in vascular and interventional radiology.
Yeah, thank you, sir. So, yeah, please.
Dr. G.V. Deshmukh oration. Dr. G.V. Deshmukh was the first president of Indian Medical Association headquarters in the year 1928-29. Dr. Bhavesh Prasad.
Yeah, thank you, sir. Just wanted to add, as a part of our commitment to developing and enhancing the vascular treatment portfolio across the city, I have now started Mumbai Vascular Foundation. This foundation is going to do two things: teach. So we're going to give travel fellowships to people, budding intervention guys who are coming out of KEM, big institutes. We will be sending them one student a year to Europe for training and coming back, as well as we'll be doing more teaching programs and some service aspect related to that. Thank you. So coming back to my talk on recent advances, and I know a lot of you have heard my talk on varicose veins and how I treat and everything, but this is something completely which is close to my heart. This is the first peripheral angioplasty, lower limb angioplasty done by Dr. Charles Daughter and Judkins in 1964. And if you can see here, what they've done is they have an SFA which is completely occluded, and they've dilated by putting serial dilators, a facial dilator which is done to dilate PCN and do PCNs in these days. These are the dilators that were used, and eventually they opened the artery. Dramatic in that terms, and now we've come a long way where we have balloons, stents, drug-coated stents now available in the peripheral circulation, as well as intravascular ultrasound. A lot of things have changed dramatically in IR over a period of time. You all are aware the way it has improved in cardiology, but IR has also dramatically improved. I'll show you some of it. I cannot give you the entire innovations, but a glimpse of it. I'll show you some of them in interventions, some of the changes in varicose veins. Laser used to be the standard for varicose vein treatment, how it is changing. I'll show you some of the things on perfusion imaging on diabetic foot, some of the drug-eluting technologies, and one of the latest and the newest babies that we have, prostate artery embolization for BPH, and we have a huge role to play in that. And then in osteoarthritis, how we are growing in each and every field. We are able to provide minimally invasive treatment options to a lot of your patients. Talking of diabetic foot, diabetic foot is a situation where the patient has diabetes, peripheral vascular disease, non-healing ulcer, with or without neuropathy. But one of the critical factors here is to improve the blood flow so that the wound would heal in these patients. And the primary principle in these patients is to improve at least one straight line flow going all the way from groin all the way to the foot, so that some vascularity reaches the foot, and that's where the wound healing would occur. One of the issues, and the basic question always arises, is where do you improve the flow and how much do you improve the flow? That is entirely based on angiosomal theory. By angiosomal theory, what we do is basically divide the foot into different aspects, and depending on where the wound is, we will determine which artery is going to supply which area, and that is what we need to open up. I'll just show you an example. If you see, if a patient has a wound in the posterior tibial artery territory, and if you open the posterior tibial artery, the wound healing in that case is close to, the healing time is 146 days in this study, versus if we don't open and we open the other artery, the healing time significantly decreases. So it delays. So if you open indirectly, it helps, but it's a delayed way. So that's how it is important, and obviously how many arteries open, that determines. A critical factor is where do you open. If you look at this example, I'll show you this patient. So one of the basic principles, as we rightly said, open one artery which is going all the way down to the foot, which is there, but this patient has a wound in the anterior tibial artery territory. Obviously it is the indirect artery which is going, so the wound healing time is going to be delayed. What we did in this patient is try to open up the anterior tibial artery and the dorsalis pedis. Now the actual ansosomal artery is opened up, and this patient's wound healing time is going to be faster. So to understand the disease and to treat is critical. But if you do that as well, if you've opened the anterior tibial artery, but a lot of times in diabetes you have microvascular occlusions because of calcification as well as the disease extending into the foot. How do you then quantify that after doing an angioplasty, this patient's vascularity or the perfusion to the tissues have improved or not? Because that is going to tell your patients that I have improved the blood flow, but your wound is still not going to heal, or it is going to heal faster. So that is one of the critical questions, because that will determine the actual outcome of doing all these expensive treatments. There is something called as 2D perfusion scan, and we are amongst the probably one of the only couple of centers in the entire city which has that tool associated with us. What we are doing is doing a 2D perfusion mapping in these patients, like how a cerebral perfusion mapping which is done to demonstrate whether the tissues are alive or not. We are trying to do that with the foot now. I'll show you, it's the same technique. You do angiography, angioplasty, and then you have a software. It's an expensive software. We've invested heavily in that. I'll show you some of the things associated with that. Look at this patient now, 65-year-old female, non-healing wound in the heel. Now this, the angiosomal artery for this is posterior tibial artery. Unfortunately, if you see the angiogram, you have an SFA which is blocked. So I've done is a drug-eluting stent which is now available in India, a drug-coated stent we've placed here in this patient, improved the vascularity, but posterior tibial artery is completely occluded. You cannot, there is no reformation, so there is no way you can improve posterior tibial artery. Now you have a choice to indirectly open up anterior tibial artery in this patient. So theoretically, you've opened up only indirect angiosomal artery, but you look at this now, if you look at this patient's perfusion, and if you see the perfusion scan, this is on the lower end of the spectrum where pre-plasty, the vascularity is very, very poor. It's in the blue-green range, but post-plasty, the vascularity is improved and it's come very fast here. And I'll show you how some of the things that we do post that. Post-plasty, if you see the arrival time of the contrast in the foot, the area of the wound, earlier it was 19 seconds, now it has dropped to 5 seconds. And if you see the peak density, It was 52, it has gone to 208. The improvement in the vascularity is 300%. Now I can very strongly tell this patient, I have not opened the angiosomal artery, but the vascularity improvement is 300%, your wound will heal. That is the kind of prognosis you can give both to your patients as well as the diabetic foot surgeon. So that's the kind of dramatic shift this tissue does for us, you know. Look at this patient now. You have a 75-year-old female, wound again in the posterior tibial artery territory. So now you are talking of a wound which is in the posterior tibial artery territory, and post-plasty, we've improved the vascularity in the posterior tibial artery territory and all the way up to the plantar arch. So now you've opened the angiosomal artery. And again, the same thing, if you look at the improvement in vascularity, 387% improvement in that area. That is the kind of prognosis you can offer to your patient. Yes, we give you treatment and we give you assurance that it's going to improve. So that's the kind of innovation and improvement we are talking in terms of IR. In terms of drug-eluting technologies, obviously when I've showed you a stent, which was earlier we used to put a bare metal stent, and now we are putting drug-eluting stent. We have two drug-eluting stents available across the globe. One is Illuvia from Boston Scientific and another is Zilver from Cook. I am proctor for Illuvia, and in India right now only Illuvia is available. Zilver PTX is not available. One of the critical factors, and I think all of you are aware of the fact that with Illuvia, the drug, the copolymer which is available is based on what is available on Promus and Xience. So you guys are aware of Promus and Xience stents which are available for coronary. That's the same copolymer which is available in this Illuvia stent. Talking of, unlike the coronaries, in peripherals, the restenosis happens in a delayed phase. So this stent elutes drug over a period of entire 360 days, 1 year. So you're talking of primary patency which has been taken care over a period of entire year. So then, do you have science to prove that whether it is better than the bare metal stent? There's an eminent study here, and I'll show you in terms of patency. There's a significant, statistically significant improvement in terms of patency versus bare metal. Does it translate into clinical improvement? Yes, in terms of clinical improvement, also statistically significant improvement for patient wound healing. Lastly, we are talking of situation where comparing it with the other drug-coated stent which is not available in India yet. So there was a imperial trial which was done comparing both the different devices, and I'll show you, I'll rush through this part, I'll show you in terms of patency, 1 year patency rate is 92%, which is very, very high. You know, you're talking of patencies which is much better in terms of the other drug-coated stents as well. What are the other issues with diabetics? Long lesions, calcified lesions. Diabetics have other issues associated with that. So this study even marked patients and they subgrouped it into long lesions, again patency rate very high. High calcium, moderate and severe calcium, again the patency rate is very high. And obviously CTO, the patency rates in CTO is also quite high. So we're talking of a device now available which at 2 years as well, the target lesion revascularization is significantly lower. So this is in terms of imperial trial, both for long lesions, diabetics, CTOs, heavily calcified lesions. You have a device like coronaries which is available which can give you a beta patency. So again, in terms of all-cause mortality, it's also significantly better. It's reduced as compared to the Zilver PTX as well. So in terms of diabetic foot, apart from this drug-eluting technology that we have and the perfusion, we've come a long way in improving the vascularity of these patients pre-procedure. Coming to the next part, the varicose veins, and I'm going to discuss a couple of issues with that. One is patient selection may not be a major issue, but some of the issues related to that, I'll show you that. I'll show you this right now. Endovenous laser ablation is the gold standard, and all these years across the country, all of us have been using 14, 17 nanometer wavelength. I have now switched to 1940. Entire western region, we are the only ones who has this wavelength. This is less painful, less perforative, much better. And we are now doing VenaSeal, which is even better than laser. So you have a lot of advancements in that. I'll show you some of that. Obviously, you know it is a progressive medical condition. It's not just a cosmetic situation here. One of the questions that we ask our patient, and these are the issues we should discuss, what are they seeking, and are they looking for a cosmetic reason or a symptomatic therapy, because that will determine our treatment. And obviously, we need to make sure that these patients don't have underlying peripheral vascular disease, DVT, because these are the ones which are contraindicated, and you will end up messing up the results in these patients. Look at this patient. Now, you have a patient who's got an ulcer above the medial malleolus, typical venous ulcer with a lot of pigmentation. Look at the Doppler report. You have an SF junction incompetent, perforator incompetent, no DVT. Ideal case to undergo endovenous laser ablation. This has been done for years, but when we evaluated on Doppler, we realized that this patient had deep vein reflux. What is deep vein reflux? A lot of times patients might have had developed DVT in the past. Now they've recanalized because of NOACs and other anticoagulation. So anatomically there is no DVT, but the valves in the deep veins have also damaged. So it's a functional DVT. So in these patients, if you treat the superficial system, the deep system is functionally working like a DVT. So this patient is never going to benefit with laser. So obviously you have to offer treatment, and you offer something called as 4-layer dressings, and that's what we do regularly. The intent here is to provide 40 millimeters of mercury pressure from outside, and that's how you heal the wound in these patients without doing ablation. The other issue that a lot of times people fail to understand is the location and distribution of varicosities. Look at the varicosities in this patient. It's anterior thigh. It is not in the great saphenous territory. It is not in the short saphenous territory. That means it's not matching with your Doppler findings. There's something called as pelvic congestion syndrome. These patients a lot of times have dilated ovarian vein. Typically in women, they have pain in the pelvis as well, and dilated ovarian vein, which will reflux into varices in the pelvis, and indirectly through interiliac vein have pressure changes in the lower limb. People keep on doing lasers for this patient, but the pathology is here. The treatment here is, again, ovarian vein embolization. You need to work up these patients well before you decide what treatment you need to offer to these patients. Typically will happen on the left leg. Remember, another cause for left leg varicose veins is May-Thurner syndrome. What you have is an iliac artery on the right side crossing the left iliac vein and compressing the left iliac vein, which will increase pressure in the left leg, indirectly causing incompetence and varicosities on this side. Again, doing laser is not going to help in these patients. What you need to do, like coronaries, we do IVUS, and on IVUS we can demonstrate that the vein is normal and the artery is not compressing that, versus you have a patient where on IVUS the vein is completely compressed, and in that situation we do iliac vein stenting, and on IVUS we can demonstrate that now the vein is opened up, and these patients' venous pressures will come down and varicosities will settle down on their own. So this is something which we do new now. In terms of, I think let's skip this part. The intent here is to show that we need to also evaluate multiple accessory veins, which will decide whether these patients are adequately treated or not. I'll skip this part. I'll show something which is the recent advances right now in terms of varicose veins. And you know, historically for varicose veins, stripping was offered. Recurrence rate was 24 to 26%. Multiple studies showing that the stripping process itself causes neovascularity, which is like inducing recurrence in the patients to begin with. That's why it was completely out of the therapies. This currently is the gold standard endovenous laser, or the RFA. Almost perfect procedure. You're talking of a procedure which is day care, no stitches, done under local anesthesia. So I'll skip this part, and this is what we've been using all this while, 1470 laser. The innovation here is that we are doing now radial ablation, making sure that the entire wall of the vein is ablated and not just the end of the vein. Now the innovation here is, this is how the results are ulcer healing, absolutely fantastic. This is what is new. This is what I have now, 1940 laser. One of the recent articles published in a phlebology journal has compared both 1940 versus 1470. 1940 causes less perforation, less pain, less bruising, less thermal injury. So something which is perfect, you're trying to improve your results in that as well. In terms of science, it tends to be absorbed better by the water in the endothelium, making sure that you cause less of hemoglobin occlusions, thrombosis, and perforations. I'll skip this part. In terms of ablation, now we've improved from 1470 to 1940, and that's the latest and the gold standard available now. How do you make this even better? Because one of the issues with laser, you would understand, and a lot of your patients might have said, is that stockings. I think this is one of the issues that a lot of patients have, that they have to wear stockings, and that's something which is troublesome. How do you modify that? We have something called as VenaSeal system, which is a closure system. This is a US FDA approved system. Like traditionally, we've been embolizing all these AVMs. We use something called as medical glue, which is cyanoacrylate glue. Unlike laser, where you have to give multiple punctures to give local anesthesia around the vein, with VenaSeal, we give one single puncture above the level of the ankle. Likewise, we introduce the entire sheath and reach up to the SF junction. And unlike burning the vein in laser, what we are doing is we are placing a small drops of chemical from outside using a calibrated gun, and practically like a good craft work, sticking the vein. Okay, this is an absolute evolution in terms of varicose vein therapy. You have a lunchtime procedure, half an hour treatment, one single prick, patient walks off the table and goes back and joins the work. Majoritarily, they need not wear stockings post-procedure. That's the kind of benefit you can offer to your patients. And when you offer something which is new, it has to be backed by evidence. This has been FDA approved since 2015. The device, the VenaSeal, has all the ideal situation for any glue. It does not flow off and go into the deep system. The complication rates are very, very low. And in terms of evidence, you have a V-close extension study. Now we have a 5-year V-close extension study available data. Closure rate is close to 95%, recurrence less than 4% in these patients. As good and as comparable to any laser or radiofrequency ablation in today's times. So in a patient who's little more affording, you can offer a treatment which does not even require stockings. So this is what is the recent innovation. You have a WAVES trial, which is 98% occlusion rate in these patients. In terms of complications, a small risk of thrombophlebitis in less than 6.8%, which is quite low in terms of a complication rate. Post-procedure, again, simple antibiotics, anti-inflammatories, like any other post-varicose vein laser ablations. Benefits: it completely eliminates tumescent anesthesia. So no multiple pricks to be given, only single prick to be given. Most of the times we'll avoid stockings, no thermal injury risk, rapid return to activity, and for me, no extra capital investment. Obviously, I ended up investing in 1940 is a separate issue. To summarize, VenaSeal is something which is very, it's going to be the routine for varicose veins now. That's what I would say. Lastly, this is the new child, the favorite child probably, prostate artery embolization. And you know, benign prostatic hypoplasia is something which most of your older patients, sometime or the other, would develop in their lifetime, causing symptoms. And the traditional therapy for that has been TURP, and we all are aware of that. That's the gold standard right now. We are here to add one more layer to that. I'll give you first an example. Look at this patient now. This patient has approximately 290 grams of prostate, heavily enlarged median lobe. Foley's catheter has been placed, and this is not being coming out because this patient is developing retention post that. To that extent, that patient started developing hydronephrosis as a back pressure changes. What we are now offering is an embolization. What you do is, like any other angiography, you enter the prostatic artery, demonstrate the vascularity of the prostate. It is a hypervascular side. You go selectively inside, and then eventually go ahead, and this is what we are showing from the left-hand side. You go ahead and embolize that. You block the vascularity of the median lobe, and the prostate will start shrinking. So I'm talking of something which is new, and I'll give you an evidence on that. One of the best evidences, any evidence for a scientific thing you could give, is a randomized control study and a meta-analysis. These are the two best evidences you give. Look at this now. This has been published in 2020, a randomized comparison of prostate artery embolization versus TURP for BPH. The results, and I'll show you the results. There was lower urinary tract symptoms, reduced post-TURP at 12 months, same result, but with fewer complications post-PAE. And when I'm talking of new, the intent here is to keep on giving you the evidence associated with that. Another study which was published comparing TURP versus PAE, it's a prospective randomized control study. Again, if you compare, what are the issues with patients? First thing is you compare an IPSS score, which is a sign of symptomology associated with that. If you look at PAE and TORP, same results at 2 years. If you quality of life score practically similar at 2 years, you're talking of a PSA values similar, you're talking of residual urinary volume similar, and the prostate volume reduction is almost similar in both the situations. These are other studies, other data, other evidence. Recently published data in Urology Journal as well as JVIR. Gross hematuria, in patients who have hematuria as well, 92% of the patients' gross hematuria significantly reduced and patients remain hematuria free for more than 483 days. That's the kind of clinical improvement also you're talking of. Then it comes to situations where if the patient has retention and Foley is in situ and not coming out, you have a situation where in 18 days, more than 87% of the patients, Foley's could come out in these patients. So you're talking of symptomological improvement and technical improvements as well. If the patient has big prostates, more than 80 grams or less than 80 grams, again the result is similar. The IPSS score is significantly reduced in both the situations, and this has been published by in a UK rope study recently. Symptomology, lower urinary tract symptoms, hesitancy, urgency, again dropped more significantly than irritative, but most of them in terms of clinical significance, similar reduction in symptoms. You're talking of a procedure which is new and which you can offer to your patients. You need a long-term 10-year data, and I'm giving you a 10-year data where IPSS score improvement is by 16 points, quality of life score is improved. In terms of all parameters, you have a good long-term data to prove that now this is a consistent procedure which can be offered to your patient. The best part about this is it can be done under local anesthesia, and you would understand a lot of these patients, old patients, would have either had a PTCA done or a CABG done in the past, so they are on antiplatelets. They cannot be stopped because you can't give them spinal anesthesia. So this procedure can be done under local anesthesia without stopping antiplatelets. So that's an added benefit you're offering to your patients. Again, less complications. I may not have a lot of time to show you genicular artery embolization. Just a couple of words on that. This is new therapy, and I have again 2-year data to show you in patients who have osteoarthritis, who are not responding to medical line of management and who are still not yet candidates to undergo a joint replacement. The principle here is that the entire inflammation associated with the synovial hypertrophy, you're trying to block the vascularity there. And I'll show you just one example in a patient which has, failed conservative therapy, not relieved by intra-articular steroids. In that patient, we went ahead and embolized the genicular artery and making sure that the vascularity of the synovium, hypertrophic synovium is gone, but the actual genicular artery is kept patent, and there was significant pain reduction both at 1 month, 3 months, and 6 months so far. So again, enough data to prove that. I think we'll skip this part. We can take it up much later and on some other occasion. Thank you so much.
Thank you, Dr. Bhavesh Popat, for giving a wonderful information about the recent advances in radiology and interventional radiology. Thank you so much.
Thank you.
There's an announcement. Mediquiz is there in the souvenir which has been distributed to everybody. Before inauguration, please put in the box over here. After that, it will not be allowed to be put into the box. So anyone who wants to give the Mediquiz paper can put it in the box. I request Dr. Jitesh Mehta along with chairpersons to felicitate our speaker, Dr. Bhavesh Popat.
Number 005. Number 210, Dr. Sayyeda Sarwat Qadri.
Yeah, friends, the next speaker is Dr. Ankur Fatharpekar. He is going to deliver Dr. F.P. Antia oration. I request Dr. Sujata
Dr.
Sattar and
Kanishka
Dr.
Gupta.
Prakash Borana to be on the dais. Dr. F.P. Antia oration. Dr. F.P. Antia is a renowned gastroenterologist from Grand Medical College and founder member of IMA Mumbai branch. Dr. Attar, she is the immediate past president of IMA Mumbai branch, honorary joint secretary, IMA Maharashtra State, and organizing secretary of the 51st annual conference Mimacon 2022. Dr. Prakash Borana is the past president of IMA Mumbai branch and co-chairperson of the catering committee. I request Dr. Sujata Nisatta to introduce the esteemed speaker, Dr. Ankur Fatharpekar.
It's a privilege to introduce Dr. Ankur Fatharpekar. He is a consultant interventional cardiologist attached to Bridge Candy, Wokhart, Sefi, Raheja, Fortis, Messina, and Hinduja healthcare hospitals. He has done his MD and DM cardiology from the prestigious Seth GS Medical College and KM Hospital, Mumbai. He is one of the few expert cardiologists doing complex cardiac interventions like TAVI, that is transcatheter aortic valve implantation, and devices like cardiac synchronization therapy, which is a special device to improve the pumping of heart. He is a South Asia proctor of Boston Scientific for rotablation and intravascular ultrasound. He has numerous national and international publications to his credited index journals. Today, he will deliver Dr. F.P. Antia oration on topical coherence tomography, optimizing results of angioplasty. Dr. F.P. Antia oration he was a renowned gastroenterologist from Grand Medical College and founder member of IMA Mumbai branch. Over to Dr. Ankur Fatharpekar to start the lecture.
A very good afternoon. It's my 5th IMA and I'm always happy to be here, seeing all the faces, all the known faces and meeting seniors. Today I'm going to talk about a new imaging modality in cardiology. So to tell you a story, I had a patient who's come from Guwahati just a few days back, and he told me that he's a gynec and I want to do angioplasty. I asked him, is anybody known to you in Mumbai? So he said, no. But then I asked him, how did you get my name? I mean, there are bigger names than me in cardiology. He said, my son is an anesthetist. And he asked his fellow anesthetists that who is the one who's doing the most recent thing in cardiology. So that is a main thing, that any interventional cardiologist or any surgeon has to be good friends with the anesthetists, because they are the ones who give the feedback. So coming to what is OCT, it's what I would say is like the robotics of angioplasty. It's not actually a robotic angioplasty, but it's the robotics of angioplasty. Why do I say that? It gives you precision while doing angioplasty. So till now, we just had the angiography that we used to give the dye, used to see the vessels, whether there's any stenosis, we used to come to know. But this gives you an inside view of your artery and gives you all the measurements required, like the diameter of the vessel, the length of the vessel, the morphology of what the lesion is. And why this is important, you'll come to know as we go ahead with the talk. So this is how an angiography looks to you. You can see there is a catheter which is there. I come from the femoral root. You can see this part. This is the catheter up. This is a temporary wire. We're doing the RCA-plasty. The right side always gives you trouble. There is a lot of calcification you can see the stenosis in the mid part. And there's also some dissection, a very elderly man. So this is how we would look at a coronary artery till now. Now, we have, this is the angiography you would see from outside in, but with an IVUS or an OCT, you would look inside out. So that means you are able to see the lumen, the adventitia, the media, and the intima in all its 3 layers. So what is an OCT? OCT is basically a catheter which contains a single optical fiber and it emits infrared light. So an IVUS is an ultrasound device. This is an infrared device.
An OCT measures the echo time delay and the signal intensity after its reflection or backscattering from the coronary wall structures, while simultaneously there is a pullback along the coronary artery, and thus a scan is performed of the segment of interest. This is not a 3D animation. This is actually how an OCT looks like. This is how beautiful it is. This is a 3D walkthrough. So you're walking inside the artery. It's like walking inside the coronary arteries. You can see this is a cut section, a cross section. This is the length. It gives you all the dimensions and the stenosis. This is a longitudinal section where you can see the stent throughout. And the red dots you can see, that means the stent is not expanded well. When you look at an angiogram, many a times it happens. I've done left main stenting, I've done stenting in the difficult arteries, and I feel it's a fantastic result. Let's quit, let's stop. But then once you put an OCT camera, now you know that the stent is not expanded in one position. You need to post-dilate it better. So that kind of precision is what OCT gives you. So this is how it actually works. You put in a catheter, and you can see this dot coming behind. So that's a pullback which is happening. It's a pullback which is happening, and you have to give contrast during it. That's the drawback of OCT. You have to give contrast to clear the blood from the vessel, while the OCT catheter is enabled to have a pullback. Nowadays, but we have switched to half saline and half contrast, and now it's even lesser, 1/3 contrast and 2/3 saline, and we're getting beautiful images even with that. So what exactly does it do? It does these 9 things. First, it acquires high quality image. Second, assesses the plaque composition, very, very important. Why is it important? Is when you have a calcific block sitting there, and if you try to do an angioplasty is essentially a wire, a balloon, and a stent. That's angioplasty for you. But there is a long story to it. So if you balloon, and if there's a lot of calcium there in the vessel, you try opening it up with a very hard balloon, with a very hard force, it doesn't open up. It doesn't open up. Calcium just doesn't give away. So you have to use special tools like rotablation or cutting balloon or intravascular lithotripsy. This is a new thing. One of the newer things in cardiology is intravascular lithotripsy. What is that? It's just like the sound waves, the lithotripsy was done for the renal stones. In a similar way, there's a sound emitting balloon which is there. So you open the balloon, you oppose it to the wall and give sound waves, it cracks the calcium. So there are special tools to open a calcific block. So that's very important. You know what's the plaque composition. And an angiography doesn't give that detailing. Then assess the reference segments. So angioplasty, you stand from healthy to healthy. So on what looks healthy on the angiogram might not be healthy. There might be lipid plaque. So we can identify which point is healthy to which point is healthy. Choose the size of the stent. Again, diameters, till now you would be surprised to know that all the diameters which we take on the like echo, 2D echo, 60%, 40%, 50% is visual for many cardiologists. Similarly, an angioplasty, when you put a stent, a 2.75, a 3, a 3.25, or a 3.5 stent is just visual. So one cardiologist might say, oh, 3 lag raha hai, the other one might say it was 3.5. But when you put an OCT and you do a pullback, you exactly come to know from the adventitia to the adventitia what's the size and which size stent will you use. Expansion. Once you do the angioplasty, whether the stent has expanded well or no, MSA is your maximum stent area. Rule out geographic miss. So again, you might miss out lesions on angiography which might be which might be picked up by an OCT. Determine the opposition, whether the stent is expanded well or not. Edge dissections, very important. When you put a stent, many a times there are small edge dissections which are missed out, and the patient comes with stent thrombosis later on or stenosis at the edge of the stent. And tissue protrusion. Many a times when you go very aggressive, the tissue which is there in the wall comes inside the stent and it gives you a plaque prolapse. So we have an algorithm or a method by which how we do a OCT. So pre-angioplasty, we use these 3 things. MLD. M is for morphology, that is to understand whether it's a lipid plaque, a calcific plaque, or a fibrotic plaque. L is the length of the stent to which we would put, and D is the diameter. So morphology, this is how a fibrous plaque, a lipid plaque, and a calcific plaque looks like. A very homogeneous, high backscatter and low attenuation is your fibrotic plaque. A lipid plaque looks fainter, that is homogeneous, low backscatter, high attenuation and diffuse borders. And a calcific block will be very sharp. It has sharp borders. So when you see calcium doesn't look like a white structure like it's seen in the IVUS. It looks like a pale structure with sharp borders. Thrombus, you can identify thrombus, whether it's a red thrombus, white thrombus, recanalized thrombus, or a spontaneous coronary artery dissection. Very important. Females, many a times, don't have atherosclerosis. They might have something called a spontaneous coronary artery dissection. That means it's a dissected artery. By itself, they have a spontaneous dissection, which happens. So it is important to identify what's going on. Red thrombus is basically your anticoagulation issues. That means if you're not given good heparin during the angioplasty, you can get a red thrombus. A white thrombus is basically a platelet thrombus. So a platelet thrombus, you have not given your aspirin and clopidogrel well. You have not loaded the patient well. Recanalized thrombus is seen when you give thrombolysis, and post-thrombolysis, you've done an angiography and you come to know it's recanalized. And SCAD would look like a dissected artery. Length. So it's very important. I told you, the diameter as well as the length is identified. You can see here the length is 14 mm. So I want to go from point B to point D. I want to put the stent. I not only get the diameters, I also get the length. You can see the 14 mm seen there. So also the length of the stent can be identified. Diameter, I told you, you either go lumen to lumen and add 0.25, or you go from the EL to EL and then identify and minus 0.25. So this is the reference diameter, lumen diameter, and post-stenting. Now pre-stenting you see MLD, that's the morphology, length and diameter, and post-stenting you see the max. What is max? Max is basically identifying the medial dissection, whether there is a dissection beyond the stent. Apposition, whether the stent is opposed, and expansion, whether the stent is expanded well. Now medial dissection, you can see this is a dissected artery. This is post-stenting. The patient coronary artery was dissected. It's a huge dissection going up till the media. So this needs to be stented. So you cannot leave this on table. If you leave this on table, you shift the patient to the ICU, the patient will collapse. So this can be identified many a times on angiogram. You completely miss this thing. So OCT identifies more dissections than a routine angiography, mostly are minor and non-flow limiting. All dissections don't require stenting. Not associated with acute or long-term adverse effects, most of the dissections heal. But dissections which require treatment or are ones which cause an angiographic flow compromise, if the lumen area becomes less than 4 meter squares, if the arc of the dissection is more than 60%, if the length is more than 3 mm, and it extends up till the media. These are the dissections which might cause issues, and these are the ones which will be, further stenting will help. Opposition and expansion. Now you can see the stent which is there. You can see the under expansion, the medial part. The mid part is less expanded than the proximal and the distal part. This is a stent which you leave. If you don't post dilate, the patient is going to come back. He is going to come back and say, angioplasty karaya tha, stent kharab ho gaya abhi. 18 mahine mein hi kharab ho gaya. So why does it happen? So there are two factors. One is the technical factor for the stent going bad, and the other is the patient factor. The patient factor is the patient doesn't control his cholesterol. He doesn't keep his LDL cholesterol less than 50. There is something called as neoatherosclerosis. That means the cholesterol deposition starts inside your artery. But there is also a technical factor. That means if the stent is not expanded properly, like in this case, the patient is going to come back. So you can give the patient more precision by avoiding these technical factors. You can see the under expansion which has happened. At the edge, you can see a dissection. Geographical miss. This happens very frequently, that on angiogram you feel it's all good, but when you do an OCT, you feel that you have missed that lesion. Then there is hematoma. Prolapse. When you go very aggressive with post-dilatation, you post-dilate, the tissue actually comes inside the stent. So recurrent OCTs will tell you that you're expanded very well, you need not further post-dilate it. So plaque prolapse is also one thing which you will identify. And malapposition, you can see the dots of the stent here, they are not opposed to the wall completely. So this is also identified. Malapposition, you can see this is expanded well. The stents are expanded completely well. This is how a stent looks like. It looks like a dot and there are artifacts behind. So the stent is completely expanded and you can get the luminal area post-stenting also. So what is the OCT criteria for optimal stent deployment? Complete opposition of the stent stud to the vessel wall, optimal expansion, that is good stent areas, no edge dissection, intramural hematoma or tissue prolapse, and full plaque coverage. When you achieve this, you have achieved a good technical angiographic result for an angioplasty. So is imaging for everyone? So adding 1 lakh rupee extra to your regular angioplasty, is it a good thing? Is it for everyone? I would prefer for everyone. If you ask if I would do OCT in my family member, even if it's a regular angioplasty, yes, I would do it. But there are specific conditions wherein you would push the patient or ask the patient that yes, you need to do the OCT. CKD patients, these are patients who have high chances of getting restenosis. So any kidney disease patient, you will ask an OCT for that patient. And these are lesions which have severe calcific blocks. So you use special tools mentioned like rotablation or cutting balloon or an IVL. Diabetic patients, again, high chances of restenosis. And third is patients who have instant restenosis. That means you put in an RCA stent 3 years back, now the stent is blocked. Now you would identify why that stent is blocked, whether it's a technical factor, that means previous stent was malopposed, or whether it's the patient factor, that means the patient has not kept his cholesterol under control. So why OCT? A simple angiography won't identify the morphology of the lesion. Identification of the lesion is important to use specialized hardware. Example, if there's a calcific lesion, you would special tools. If stent is under-expanded, dissection present distal to the stent, malopposed, then there are increased chances of adverse effect like stealth thrombosis and instant restenosis. So now you can see, now this is what I spoke earlier also. Why does the stent fail? Nowadays we don't use BMS, so no point in looking at this part. See this part, procedure-related complications. All the things which we spoke of, under-expansion, edge plaque burden or dissection or geographical miss. See this stent thrombosis, less than 30 days. You send the patient home, the patient might expire at home if you have not done a correct technical job. So this is the importance, and also restenosis might happen after 18 months. These are two different things. Stent thrombosis is the stent, the clot coming in, obstructing the stent. ISR is slowly and steadily there is fibrous tissue which comes inside the stent and causes a blockage. So that will present chronically. Stent thrombosis will present acutely. There are other factors like intimal hyperplasia, neoatherosclerosis, which I spoke of, late malapposition, stent fracture, uncovered stent strut. So all these things can be identified and you can give the proper therapy. This is how an ISR looks like on an OCT. So neointimal hyperplasia, why does this happen? What is the difference between neoatherosclerosis and neointimal hyperplasia? Hyperplasia is basically reaction of the body to the polymer and the stent struts. So this is not dependent only on the patient factors or the technical factors. It is also the polymer which also gives a reaction in the patient. So in this case, if you put a particular stent, you would use a different type of stent with a different polymer and a different drug elution. So that is one thing which you would come to know. Neoatherosclerosis again is fat deposition inside the stent. So once you have identified ISR, you need to know whether it is the under-expansion. That means it's a technical factor. Then you go and correct the technical factor. Whether it is a patient factor, then you have to stent it. So because putting a stent inside a stent is not a routine thing, because again the stent might get blocked. So you need to know what is the reason for the stent getting blocked. So for every ISR patient, I nowadays do OCT and identify whether it's under expansion. If it is an under expansion, identify whether the calcium nodule is there behind the stent, that's why it's not expanded. Whether it's a fibrotic lesion which is there, which was not helping the stent to expand, go ahead and treat that thing rather than putting a stent inside. Because if you put a stent inside a if there's a calcium sitting there and the stent has not expanded because of the calcium, now putting inside one more stent doesn't help. So you have to first identify what caused it to then treat it. Now this is something beautiful. This is called as ACR, angiographic correlation. You can see the white dot going up. So angiography and OCT can be correlated. So you identify the exact point on the angiogram here and the same point on the OCT. Now why this is also important? Again, length of the stent, heart is a very dynamic structure. So it's not a still structure. So during the dynamicity, you might sometimes the length might be 14 mm instead of 14 mm, might get short, 14 mm stent might get short. So this identifies exactly the point to point on the angiogram, the point to point on the OCT. So this, only few hospitals have this because you have to connect the cath lab to the OCT machine. So there are only few hospitals, rest of the hospitals you can get the machine on rental basis. But this is one thing which you need to buy a software for. So ACR. Angiographic correlation. You can identify on the angiography what the lesion was and where you have to actually give the therapy. Now, few more cases. Now, I do a lot of bifurcation stentings, and very important in bifurcation, you put two stents. You know the LAD comes, the diagonal comes, or the left main comes, the LCX comes. So there, many a time, most of the atherosclerosis happens at the bifurcation, at the carina. So this is a special angioplasty technique wherein you put two stents, but if you leave a mesh at the ostia of the bifurcation, again, the patient is going to come back with a stenosis of the side branch. So look at these two images. This is a 3D rendering. Here you have see the stent struts. We have done a bifurcation stent. We have put in the stent, and here you can see the struts, how the struts are crumpled there. And now post-dilatation, now you see how it is opened up. This cannot be seen on an angiogram. This has, an OCT is a tool, even on IVUS, intravascular ultrasound, you cannot see this. This is only seen on an OCT. And so beautifully you can see the lumen now opened up there. Again, this was a left main stenting done. One of the doctors only referred this patient to me. A left main stenting done, this is the left main. And believe you me, on angiography, it was looking very, very good. Now you see here the red dots. The red dots means I am not expanding. See the dots here. They are not expanding, they are not touching the wall. It's in the air, right? So went ahead, post-dilated, now see, now it's all opened up. This part was all completely opened. The dots are now, there are few dots which are there, but most of them are opened up. So just the first angiogram which I showed you, you can see this, in this patient there was a lot of circumferential calcium. There was calcium all across. So we used a rota ablation. This is a rota ablation. This is like the diamond burr, which you must be knowing about rota ablation. It's a diamond burr which moves at 2 lakh rounds per minute, and it cuts the calcium. It essentially works on the principle of differential cutting. That means hard substances are cut, the softer ones are not cut. I am a proctor for Boston. I go and train patients, train cardiologists in this rota ablation. So what it essentially is like the dentist, it's the same noise which produces the same speed. When the dentist has the drill which he has, the same thing happens in the coronary arteries. It's like a hammer. If you put on a hammer on the glass, it breaks. But same thing you do on a pillow, it will not break. So it works on the principle of differential cutting. And now after this is done, now post rota ablation, I saw the cuts were very good cuts here. You can see the cut happening here. So now once it's cut properly, now you bring in the stent. Because if you're not expanded, if you're not cut the calcium properly, and now you bring in the stent doesn't expand. So whatever you have to do pre-stenting. And pre-stenting, this precision, we come to know after rota ablation, there are adequate cuts. Once the adequate cuts are come, now you get in the stent, now you expand, you have given a good result to the patient. This is post-stenting. See how it's expanded very well. That same patient. The same thing, this is one more patient. This is a calcified nodule, already a bypass. The patient had undergone a bypass now with significant angina. Even while walking few steps, he used to get chest pain. There was a lesion here, you can see. And again, this was a calcific lesion. We did a rota ablation because we came to know it was calcific on the OCT. We rota ablated, and now you can see post-stenting, it's all cleaned up. Thank you.
Hello. Thank you, Dr. Ankur. These very informative lectures. Thank you.
Thank you, sir.
I request President Dr. Jitesh Mehta and the chairpersons to felicitate Dr. Ankur Patarpekal.
Lucky draw winner, Rohit Suchak. Open 190, Rohit Suchak. Second winner, Dr. Arun Gangavane. Dr. Arun Gangavane.
I also request Dr. Sachin Patharkar to felicitate the chairpersons, Dr. Prakash Borana and Dr. Sujatuni Sattar.
Hello. Our next speaker is Dr. Amita Nene. We are honored to have her for President Oration. Her topic is Simplifying Difficult Asthma. I invite Dr. Sunita Shanbag, Madam, and Dr. Yogesh Shah on the dais to chair this session. Dr. Sunita Shanbag is chairperson of Aao Gaon Chale, Rural and Community Health Subcommittee, and chairperson, Hospitality Committee. Dr. Yogesh Shah is past president of IMA Mumbai branch and chairperson, Catering Committee. I request Dr. Sunita Shanbag, Madam, to introduce our esteemed speaker, Dr. Amita Nene.
Dr. Amita Nene is consultant chest physician, interventional pulmonologist, and sleep disorder specialist at Bombay Hospital. She is head of the Department of Respiratory Medicine, and she has started sleep laboratory in Bombay Hospital in 2004. She is author of 12 chapters in national and international pulmonary textbooks. She is a program director and teacher of DNB respiratory diseases and national examiner for MD and DNB pulmonology exams of India. She is executive committee member of Influenza Foundation of India and Southeast Asia Academy in Sleep Management. She is a governing counseling member of Indian Chest Society. She is actively involved in planning and execution and care of COVID-19 patients at Bombay Hospital, including the COVID ICU patients. Today she will deliver President's oration on simplifying difficult asthma. I invite her on the dais.
Thank you very much, Madam, for the very kind introduction. I'm very, very happy to be here today, seeing all the familiar faces, all my very, very close friends. I'm happy you all have been safe, and I'm very, very happy to see your bright, happy faces. I'm going to be talking today about simplifying difficult asthma. So actually, asthma shouldn't really be difficult because we know that the airflow obstruction of asthma is reversible. Now, there is better understanding of asthma pathogenesis and airway inflammation. We have modern pharmacotherapy to treat the inflammation, and we have many, many new drugs which are for better symptom control. So because of all these reasons, asthma should not be difficult, but unfortunately, sometimes it is. So there are 300 million asthmatics worldwide. The correct diagnosis of asthma is usually easily made, and most patients of asthma are wonderfully controlled. However, approximately 5% of patients of asthma become difficult to control. Their symptoms don't really respond well. They keep on getting exacerbations again and again despite taking maximal inhaled corticosteroids. So what is difficult asthma? So earlier, difficult asthma was said to be present when the patient required to get hospitalized multiple times or if he had life-threatening attacks. Now the definition of difficult asthma has been broadened, and those people who require very high doses of inhaled corticosteroids to manage asthma, or those people who actually require small dose of oral corticosteroids to manage asthma, are also included in the umbrella of difficult asthma. Difficult asthma has many names. It's also called severe asthma, difficult to treat asthma, refractory asthma, therapy-resistant asthma, and steroid-dependent asthma. But there's something very, very interesting. A high percentage of patients who are labeled as severe or difficult asthma actually do not have severe asthma. Comorbid conditions and inadequate treatments may interfere with asthma control and may wrongly label these patients as having difficult asthma. So addressing and treating these factors has been shown to improve and result in better clinical outcomes. So this is very, very important. There is a patient who is severe asthmatic. He is wheezing all the time. He is exacerbating all the time. But just by touching upon a few points, we can actually make him get very, very well controlled. So let's talk about systematic evaluation of patients who have difficult asthma. So whenever a patient of difficult asthma comes to us, we need to confirm if the patient really has asthma. After we do this, we have to evaluate the risk factors and the trigger factors. We have to manage coexisting comorbid conditions. We have to ensure compliance to treatment. We have to ensure we are giving him the correct type of inhaler, and we should be then phenotyping the type of asthma that the patient has. Let's go systematically. Number one, reassess and confirm the asthma diagnosis. So it is important to remember that all that wheezes is not asthma. In addition to asthma, there are so many conditions which give rise to wheezing. This could be COPD, this could be left ventricular failure, this could even be carcinoid tumor, or sometimes it could be upper airway obstruction, where patient actually comes with a stridor and we mislabel this patient as having asthma. So we should always maintain a degree of skepticism. When we have a patient of asthma, we are treating him correctly, we are giving him inhaled corticosteroids, we are giving inhaled long-acting bronchodilators. Despite this, the patient is wheezing again and again. We have to wonder if our diagnosis is really correct, because 12 to 30% of so-called difficult asthma actually don't have asthma at all. So when there's lack of response to treatment, it is very important that we question and confirm our diagnosis of asthma, and therefore doing a pulmonary function test is very, very important. The loop of the pulmonary function test will tell us if this is obstruction or not, and we give bronchodilator, and we all know that asthmatics will have good reversibility. After bronchodilator, the FEV1 should improve by 200 ml and also by 12%. If this is happening, then we know we are dealing with reversible airway obstruction, and therefore this patient has asthma. We should always look at the inspiratory loop. The loop below over here is the inspiratory loop. Please look at this loop on the right side. The below loop is actually a flat loop. So if this happens, this patient has upper airway obstruction, and the so-called wheeze is actually a stridor, and a diagnosis of asthma is actually incorrect. So a simple PFT, looking at the loop, we know if this is asthma or not. Sometimes a patient could be having asthma, but his PFT could be normal. So if this patient is not responding well to treatment, we need to do methacholine challenge test, that is bronchial provocation test. We know methacholine causes bronchospasm. So this patient of asthma, if he has normal PFT, we give him methacholine for nebulization, and slowly we keep on increasing the dose, and we keep on repeating PFTs after every 10 minutes. So if the patient has asthma, then after giving methacholine, the FEV1 will reduce by 200 ml, and the diagnosis of asthma will be confirmed even if the patient's PFT is normal. Normal test results of bronchial provocation test will point away from the diagnosis of asthma, and then we know we need to look at alternative diagnosis, which could be left ventricular failure, COPD, vocal cord dysfunction, restrictive lung diseases, obstructive sleep apnea, central airway obstruction, recurrent aspiration. A patient of Parkinsonism may have recurrent aspiration and he'll keep on wheezing, and we may keep on giving him inhalers after inhalers, but we are not looking at the cause of aspiration, and therefore this patient will keep on wheezing, and we may want to call him difficult asthma, whereas the fact is that this patient only has Parkinsonism. Very often there are certain drugs like ACE inhibitors. These patients also present with severe cough, sometimes also spasm, and we need to know that this is a drug which is causing this, and this is not really asthma. We need to remember that pulmonary embolism can actually present with wheezing, and therefore every patient that wheezes is not asthma. A good clinical history, checking both the lower limbs for any presence of swelling, presence of loud P2 will tell us whether this is pulmonary embolism or asthma. After we confirm the diagnosis of asthma, we want to look for and treat other concomitant diseases which can worsen asthma. So sometimes patients of asthma that is difficult to cover actually has pre-existing conditions which are actually worsening the asthma. So your treatment of asthma is correct, but you are not treating other conditions which can worsen asthma. So simple thing, a patient of asthma could be having allergic rhinitis, he could having blocked sinuses. So every time the patient goes to sleep, there is inflammatory stuff in the nose, which is going to go from the back of the throat, because of the postnasal drip, it is going to enter the airway, and it's going to worsen the inflammation. So if you keep on giving inhalers to the patient which are correct for the treatment, if you don't take care of the postnasal drip, every night inflammatory more and more stuff is going to go into the lungs, and this patient's asthma will never get controlled. What you need to do is, in addition to correcting his asthma, you need to give him nasal steroids, inhaled nasal steroids, which will take care of his allergic rhinitis. There will be no postnasal drip, and he will not have a cause of trigger. Very often patients have gastroesophageal reflux. Every time they lie down, they go to sleep in the night, there's acid reflux. The reflux, because of the reflux, the acid comes in the throat, it enters the airway, it causes bronchospasm, and the asthma doesn't come under control. There are certain endocrine conditions like hyperthyroidism. If the patient has hyperthyroidism, the metabolic rate increases and the asthma will never come under control. Also, some patients could be having carcinoid syndrome, and therefore there will be release of serotonin mediators, and the patient will keep on wheezing. If the patient has coexisting depression, if you don't take care of depression, his asthma will never come under control. Sometimes people are allergic to aspirin. We keep on giving them aspirin without our knowledge, and the asthma will never come under control. Also, sometimes patient could be having, in addition to asthma, other conditions like allergic bronchopulmonary aspergillosis or vasculitis like Churg-Strauss syndrome. Therefore, look for these conditions, and if you treat these conditions over and above asthma, then the asthma will come under control. Also, it's very important that you need to avoid aggravating factors and triggers. So we have to identify triggers. They could be anything. Right now, it's really fashionable to have pets at home. I mean, I think more than 50% of population has either cats or dogs at home, and they are a huge trigger of asthma. So whenever you're asking history of asthma patients, please ask them if there are any pets at home. Smoking is so much into fashion. People have so much of hookah smoking going on, and passive smoking is happening all the time. So active or passive smoking is actually a trigger, and please make sure that this exposure is stopped. Sometimes patients could be on medicines like aspirin and most importantly beta blockers. So the beta blockers in any form. So patient could be just putting timolol eye drops. So an asthmatic patient on beta blocker eye drops is going to keep on exacerbating all the time, and therefore important is to take drug history of everything, whether it is topical or oral. Even painkillers, NSAIDs, we know they give rise to asthma, but even simple thing like applying Volini gel or Voveron gel. So any diclofenac application also will give rise to a severe asthma attack. So we have to be very, very careful about what we are prescribing and what the patient is taking. We need to remember that there's something very interesting known as Chinese restaurant syndrome. So monosodium glutamate, the so-called Ajinomoto, is a trigger of asthma. So a patient who is well controlled, he has no problem, an asthmatic patient goes to eat food in a Chinese restaurant. In India, every Chinese restaurant puts Ajinomoto because it allows the food to last longer. So a properly well-controlled asthmatic will go in Chinese food, he'll eat. Within 20 minutes, he complains of discomfort. Within half an hour, he starts wheezing. And in 45 minutes, this patient is going to land up in the hospital, in the ICU, and sometimes may also need to get ventilated. Please note, Ajinomoto is a high risk factor for asthma, and whenever you're treating your patients of asthma, please tell them no Chinese food which contains Ajinomoto. Also packeted food like Lay's, Kurkure, Maggi noodles also contain Ajinomoto. Please tell them not to take this because this can give rise to a life-threatening asthma attack. Our patients often ask us, what alcohol can I drink? Of course, we want to tell them don't drink alcohol, but we also know that they're not going to listen to us. So we may be tempted to tell them, please drink wine. Or even if we don't tell them, they will assume drinking red wine is good because we all know that drinking red wine reduces cholesterol and is safe for heart. But what works for heart doesn't work for asthma, and red wine is a huge trigger for asthma. So red wine followed by white wine, followed by champagne because champagne contains white wine. So I'm not no ways encouraging alcohol intake, but I'm just saying that we have to tell patients of asthma, please don't have alcohol, but if you have to drink, don't have red wine, don't have white wine, don't have champagne. These are simple tips, but these will really help us control our patients' asthma better. Sometimes patients tell us that over the weekend I feel very good. I go for a holiday, I feel very good. But during weekdays I'm not fine. I go to work, I'm not fine. Maybe I've got work phobia. It's not really work phobia. It could actually be occupational asthma. So people could be getting exposed to wrong things at work, and this could be a trigger for them. So whenever patients say that when they go out of town, when they are at home, asthma gets better, please think that they could be having an allergen at home. Please take a proper history. Please tell them to change the job if possible. Otherwise, they can actually start wearing N95 masks. Because of COVID, wearing masks now has become extremely acceptable by patients. And if they can't change the job, at least this could be done to prevent occupation as the trigger of asthma. Compliance is very, very important, and there is a huge problem of poor adherence, especially for patients of asthma. If it's a heart problem, patients will take treatment, but somehow asthmatics feel nothing will ever happen to me. And the worst thing is that people who got bad asthma take the inhalers the least. They feel that inhalers are addicting, they feel inhalers are embarrassing, they feel inhalers are habit forming. So much of misconception, but whatever it may be, because of this, they are not compliant, and therefore, please make sure that you explain to them that inhalers don't have side effects, they are not addicting. In fact, we have so many actresses who are happily giving ads about they using inhalers, and therefore using inhalers is no down market thing at all, but it is good because there are no side effects. We are giving lesser doses of medicine, and the effect is quicker and faster. Also, the side effects of oral medicines will not be there. Inhaler technique is very, very important, and 3/4 of the patients who take inhalers actually don't take the inhalers correctly, more so with the PMDI. So people who just take the pressurized inhaler, they don't really coordinate well between the pressing and the inhalation. More than 80% of the medicine goes out in the air, and we know spacer is better. We give them spacer, but they don't like to take spacer because they can't feel the medicine in the throat, and therefore with the spacer they feel medicine doesn't come. So this is a huge problem. Very often people feel dry powder inhaler good, but patients require huge inspiratory flow rates. So if they have poor lungs, or if they have an exacerbation, they have an attack, at that time a rotahaler, revolizer, dry powder inhaler will not enter the lungs. Also, what happens is that often patients exhale into the device. If you exhale into the device, the dose is washed out. You don't get the dose at all. Also, moisture will come in, and the powder will keep on sticking to the device, and the patient will not get anything. So, you please choose the correct inhaler, teach them how it's to be taken, and every time that the patient comes to you, you make them demonstrate how they are taking it so that you know the technique is correct. Also, now we have inhalers which have numbers which are written. So every time you know that if it's a meter dose inhaler, it is going to last for 1 month if they take 2 doses twice a day. So please tell them to come and get the inhaler, ask them when the inhaler was started, turn around. From the number of doses that are remaining, you will come to know if the patient is actually taking the doses or not, and you can catch him nicely and urge him to be more regular. No matter how good the drug is, it cannot be effective if it does not reach the targeted airways. So choosing the correct type of inhaler is very, very important. I told you all about the MDI is the problem. You need to take it with a spacer, but patients don't want to take the spacer. Dry powder inhalers, I told you all, we like to give it to them. Patients feel it's good, but half the times the doses are not being taken. So we should ideally use breath actuated inhalers. So basically these are smart inhalers. When the patient starts inhaling, the inhaler is going to sense if the inspiratory flow rate is correct, and only when the flow rate is correct, the inhaler is going to give the dose. So you don't require hand-mouth coordination, and only if you're breathing well, the dose will be given. If the dose is given, it makes a sound, thud. So the patient also knows that the dose is delivered. So this overcomes the problem of coordination. We have number of breath actuated inhalers available. So SynchroBreathe is something which is widely available. We had AutoHaler, right now it is out of stock, but SynchroBreathe is something which is very much available, and it also has a fixed dose counter. The other ones on the right are not currently available in India. This is gamma scintigraphy photography. So we know that PMDI delivery is the best, but you can see over here on the left the PMDI delivery, and you can see on the right the SynchroBreathe delivery of the inhaler. So we can seriously see that breath actuated devices are much better. So the advantages of breath actuated inhalers would be overcome the need of coordination, gets actuated with minimum inspiratory flow rate. So even if the patient is having an acute attack, the inhaler will give you the medicine. It improves the asthma control, simple to learn and use, portable, no spacer is required so patients are happy, and it can be used in children and elderly. Psychological factors are important. So patients who have negative emotions, patients who are depressed, people, they will never get over their asthma control if you don't treat their coexisting depression, and therefore if required send them to a psychologist, a psychiatrist, but treat the depression because it is an important comorbidity. After doing all this, if the patient is not getting better, please remember that sometimes symptoms could be functional. The patient for some reason could be just faking asthma. You need to confirm this with PFT and also by doing a bronchial provocation test with methacholine. So now most of the talk is over. We come to treatment of asthma, what is new. So I want to tell you all that short-acting beta-2 agonist, the salbutamol, was recommended as the first-line treatment in mild asthma for last 3 decades. Asthma, salbutamol. That was what was there. In 2018 GINA guidelines also, if you can see, they said whenever the patient has a problem for relief, always use salbutamol. However, key change in GINA guidelines happened in 2019 and there was a fundamental change. They said that you can never use salbutamol alone. I'm using the word salbutamol because we are using salbutamol commonly. Otherwise, they said short-acting beta-2 agonist. So basically, whether salbutamol or levosalbutamol, GINA says you can never use it alone. This is because there is evidence that if you only give SABA treatment, even for patients with mild asthma, it increases the risk of severe exacerbation and also death. So there was a very important study that was published by Dasser, and it said that about 35% of patients who got acute attack of asthma, 16% of patients who got near fatal asthma, and 20% of patients who died of asthma. For previous 3 months, they never had any attack every weekly. So the so-called mild asthmatics actually either died or had fatal asthma or had acute exacerbation of asthma. So patients who have mild asthma also have ongoing inflammation and they can also have life-threatening attacks. And by giving only SABA, you're actually promoting and increasing inflammation, which will result in a life-threatening attack. A very good study from Sweden, which had more than 380,000 patients. And this study showed that if patients were taking more than 3 canisters of SABA in a year, then they had a higher chance of acute exacerbation and they had a higher risk of mortality. Thus, for asthmatics, prescribing SABA alone, you can't give them even for SOS. No SABA. For asthma, salbutamol inhaler cannot be given in their hand. No SABA for SOS also. So giving one inhaler of SABA is actually the captain of death. We will not do it anymore. Second key change in GINA 2019, 2020, 2021 proposes that we basically give them a single inhaler, which is known as smart inhaler. So basically this inhaler is going to contain inhaled corticosteroid and it will have a long-acting beta-2 agonist which acts faster, which is formoterol. So formoterol also starts working in 1 to 2 minutes, just like salbutamol does. But the inhaler is going to have ICS and formoterol. So this inhaler will be used for regular usage, that is 2 puffs twice a day. And also when the patient gets an attack, he will be using this also as a reliever. So this is known as smart therapy. The same inhaler is for prevention and the same inhaler is for reliever. So you are not giving SABA alone, you're giving only one inhaler, there's no confusion. Patient has to take the right thing. So this is something which is very, very important to treat a patient of difficult asthma. Also, smart therapy reduces the need for systemic steroids and it reduces exacerbations. Additional therapy suggested by GINA for asthma control is venoleucotriene antagonist. All of us are using. Montelukast, our favorite drug, it is very effective. Also, anticholinergic drugs, example, tiotropium, long-acting, is in addition to COPD, very, very important for patients of asthma. So patients of asthma, ICS LABA first, followed by that, if not controlled, Montelukast. If not controlled, tiotropium, inhaled antimuscarinic. It reduces exacerbation and it improves lung function. So whenever we get a patient of difficult to treat asthma, confirm diagnosis, ensure correct inhaler technique and compliance, treat comorbidities and modifiable risk factors, provide asthma education, switch to ICS formoterol smart therapy, consider adding medicines like LABA, tiotropium, leukotriene antagonists if patients don't get better. Also encourage smoking cessation, weight loss, mucus clearance by physiotherapy and influenza vaccination. After this also, if the patient is not controlled, then this patient has severe asthma and you look at the phenotypes, what type of phenotype it is. So if the patient has high IgE or high eosinophils, it becomes high inflammation. So to these people, we give biologics like omalizumab or we can give mepolizumab, bendalizumab. However, if these people don't have high IgE or if they don't have high eosinophils, then we can actually give them macrolides. This is very important for us. So these patients of severe asthma could be given You can give them azithromycin 500 milligram thrice a week for 1 year, and this actually reduces exacerbation and also improves lung function. There is something which is known as bronchial thermoplasty, in which patients of asthma who have lot of hypertrophy of the smooth muscles, you give heat and you burn off the extra muscle, and this improves the lung function. However, there are very few people who can undergo this, but if you look at biologics, if you look at thermoplasty, they are very expensive. So if your patients of ICS lab are not getting covered, please increase the dose of ICS. After that, add montelukast. After that, add tiotropium. After that, they are not getting control. Consider giving them macrolides for a year, 500 thrice a week. So I've given a lot of information. Let me conclude everything in the form of take-home messages.
Hello.
When confronted with a patient of asthma, just last. It is important you confirm the diagnosis, assess compliance to treatment given the correct inhaler. Breath actuated inhalers are better. Please look for triggers, correct them. Concomitant disorders like GERD, allergic rhinitis, sinusitis should be covered. Make sure they are not on NSAIDs, beta blockers, aspirin. Underlying depression, etc. should be treated. And after this, if it's allergic, eosinophilic asthma, you will give them biologics. Otherwise, you will give them macrolides or bronchial thermoplasty. To conclude, difficult asthma is a treatable disease, and every effort should be made to prevent its upward march on charts of global mortality. Thank you.
Thank you, madam.
I request
for
our
the
president.
wonderful oration.
I request our President, Dr. Jitesh Mehta, along with our chairperson to
Lucky draw winners are
I request our President, Dr. Jitesh Mehta, along with our chairpersons to felicitate our
Dr. V.N.
esteemed
Gokhale.
speaker, Dr. Amita Nene, please.
Dr. Sarla Shah. नहीं है Dr. Akash Duru. 142. 142.
Anyone who wants to put the Mediquiz paper, please put in the box, because we are closing the thing before the inauguration, the papers from the souvenir fund. The box is kept over here. Hello, please be seated. Lunch will be served only after the inauguration. Excuse me.
Good afternoon, everybody. On behalf of Indian Medical Association, Mumbai branch, we welcome you all for the inaugural ceremony of 51st Annual Conference, Mimacon of our branch.
So far, we have had a very fruitful deliberation on various topics of importance in our day-to-day practice. We have many more interesting and informative scientific sessions after the inauguration ceremony. I request our President, Dr. Jitesh Mehta, President-elect, Dr. Anil Awad, immediate past President, Dr. Sujata Nisa Attar, and Honorary Secretary, Dr. Girish Lad, to escort our chief guest, Director of Health Services, Government of Maharashtra, Dr. Sadhna Taide. Guest of honor, immediate past State Secretary, Dr. Pankaj Bhandarkar, and President of the Maharashtra Medical Council and Executive Member, National Medical Commission, Dr. Shiv Kumar Uttare, to the dais.
I request everybody to please stand up for the IMA prayer and IMA flag salutation. First, we'll read IMA prayer. Please repeat after me. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Now I will read the IMA flag salutation. Please do not repeat with me, after me. The members of Indian Medical Association stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the committee of the nations. Jai Hind. Please be seated. Long live IMA.
Friends, let us welcome our dignitaries with a floral bouquet. I request Dr. Usha Shah, Dr. Kajal Ahuja, and Dr. Sachin Patharkar to welcome our President, Dr. Jitesh Mehta. Our chief guest, Director of Health Services, Government of Maharashtra, Dr. Sadhna Taide. Guest of honor and immediate past Secretary, IMA Maharashtra State, Dr. Pankaj Bhandarkar. President of the Maharashtra Medical Council and Executive Member of the National Medical Commission, Dr. Shiv Kumar Uttare. Honorary Secretary, Dr. Girish Lad. Immediate past President, IMA Mumbai and Joint Secretary, Maharashtra State, Dr. Sujata Nisa Attar. President-elect, IMA Mumbai, Dr. Anil Awad. We also acknowledge the presence of Vice President, IMA Maharashtra State, Dr. Suresh Doshi. Honorary State Treasurer, IMA Maharashtra State, Dr. Rajiv Agarwal. Honorary Joint Treasurer, IMA Maharashtra State, Dr. Arvind Patel. President, General Practitioners Association, Dr. Bharat Bhatt. Our branch treasurer. Honorary Secretary, GPA, Dr. Pragji Vaja. President of the Mahim Dharavi Medical Practitioners Association, Dr. Usha Johri, and Secretary, Dr. Avni Walke. and the First Lady of our branch, Dr. Asha Mehta. Sorry, we forgot our honorary treasurer, Dr. Shingarpurkar. So I request Dr. to felicitate our honorary treasurer of our branch, Dr. Shingarpurkar. Thank you. I request the dignitaries on the dais to rise and light the ceremonial lamp.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश मतिं स्वच्छाहि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः
Thank you all. We also acknowledge the presence of D Ward Vice President Dr. Akshay Shevak. Now I request our Honorary Secretary Dr. Girish Lad to present the annual report of our branch in brief. Dr. Girish Lad, sir.
Yeah, good afternoon, everybody. Respected Chief Guest, Director of Health Services, Government of Maharashtra, Dr. Sadhna Taide, Guest of Honor, immediate past State Secretary and Senior Vice President of IMA Mumbai Branch, Dr. Pankaj Bandarkar, President Dr. Jitesh Mehta, dignitaries on the dais and off the dais. It's a proud moment for me to present the annual report of IMA Mumbai branch activities. We have received many prestigious awards from IMA Maharashtra headquarters and IMA Maharashtra state. Following members have been elected as office bearers of IMA Maharashtra state. Vice President Dr. Suresh Doshi, immediate past Secretary Dr. Pankaj Bandarkar, Honorary Joint Secretary Dr. Sujatun Attar, Honorary Joint Treasurer Dr. Arvind Patel. Besides undertaking regular continuous professional development as part of our academic activities, we don't lag behind in organizing community projects. Our community projects are blood donation drive, Aao Gaon Chale project, Mission Pink Health, Pulse Polio Immunization Program, Martyr Fund contribution to IMA headquarters. Our branch distributed more than 60,000 masks, 20,000 PPE kits, more than 20,000 face shields, N95 masks for various doctors from municipal and government general hospitals and practicing doctors as well during COVID pandemic. Other activities included support to medical students through Junior Doctors Network and Medical Students Network for fighting against delayed postgraduate NEET counseling. Due to restrictions of gathering, we conducted 25 educative webinars virtually during the year. It not only helped the doctors to replenish their knowledge, but also helped them to earn MMC credit points required for renewal of their MMC registration in February 2022. Our branch hosted a cultural program, Sahela Re, organized by IMA Maharashtra State branch on the occasion of birth centenary of Bharat Ratna Pandit Bhimsen Joshi. It was planned by Dr. Prajakta Lele, IMA Maharashtra State Cultural Committee Chairperson. Our members, Dr. Sachin Patharkar and Dr. Disha Patel, participated in National IMA Sports Olympiad at Nashik. We bagged 6 gold medals, all by Dr. Disha Patel in various events. Dr. Kajal Ahuja, Honorary Secretary IMA CGP, was selected for IMA National Dancing Competition. Our members, Dr. Girish Lad, Dr. Suresh Doshi, Dr. Kiran Desai, and Dr. Hemant Vinze were selected for reciting their own poem in Kavya Gandha competition. President Dr. Jitesh Mehta, President-elect Dr. Anil Awad, past President Dr. Yogesh Shah and Dr. Deepak Desai were shortlisted to participate in Sargam, a musical contest of IMA HQ. Friends, this is in brief the activities of IMA Mumbai branch. Details of this is already printed in the souvenir. I request you all to go through it. I thank all the chairpersons of various subcommittees for conducting all the activities successfully. Thank you very much for your patient listening. Jai Hind, Jai IMA.
Thank you, sir. Besides the blessings of the dignitaries present here, we have received messages from various stalwarts. National President, IMA Headquarters, Dr. Sajanand Singh, Honorary Secretary General, IMA Headquarters, Dr. Jayesh Lele, immediate past IMA National President, Dr. J.A. Jayalal, President Maharashtra Medical Council and Executive Member, National Medical Commission, Dr. Shiv Kumar Utture, sir, IMA MS President, Dr. Suhas Pingle, Honorary Secretary, IMA MS, Dr. Mangesh Pate, immediate past President, Dr. Ramkrishna Londe, immediate past Secretary, IMA Maharashtra State, Dr. Pankaj Bandarkar. We thank all of them. We also acknowledge the presence of IMA Maharashtra State Vice President, Dr. Suresh Doshi. Thank you.
I request our President, Dr. Jitesh Mehta, to deliver his presidential address.
Good afternoon, all. It's a pleasure to see all of you in person. This conference was supposed to welcome this new year, 2022, on 2nd of January, but Omicron beat us to it. The old adage, man proposes but God disposes, holds true. And so here we are today. I extend my best wishes and heartwarming welcome to our chief guest, Dr. Sadhna Taide, Madam, Director of Health Services, Government of Maharashtra. I also welcome guest of honor, our very own Dr. Pankaj Bandarkar, sir, immediate past Secretary, IMA Maharashtra State. A warm welcome to Dr. Shiv Kumar Utture, President, Maharashtra Medical Council. I take cognizance of all the luminaries on and off the dais with due respect and recognition. The theme of our conference, Innovations in Healthcare, is very apt in today's times, when the whole world is innovating to fight the coronavirus. The future of healthcare is going to be completely dominated by digital technology, artificial intelligence, nanotechnology, and many more. The list is endless. And you already experienced it from the previous lectures, how medicine is progressing. Friends, I'm proud to say that during the past 1 year, which was riddled with corona waves, as was the year before, Mumbai branch has not deterred and has continued almost all its activities strictly following COVID protocols. To narrate a few activities in brief, we had a chain of webinars, 25 to be exact till date, with an overwhelming attendance of 700 to 1500 delegates each time, which speaks volumes of its popularity. All our webinars were accredited with MMC credit points. More than 25,000 delegates attended the webinars and over 30,000 credit points were allotted. 7 blood donation camps were organized at various railway stations in collaboration with KAIM, Blood Bank and other NGOs, and we collected over 570 units of blood till date. Our Aao Gajchale project team of doctors have visited Sonale village, Palghar district regularly, and till date we have treated more than 600 patients. Our contribution to the COVID Martyrs Fund has been very commendable. We have collected 57,88,000 rupees with a major contribution of rupees 50 lakh coming from Vilu Punawala Foundation of India. Our hall was a landmark of worship during the 7-day Durga Puja festival, which was relayed online for all the devotees. Our branch participated in a free eye checkup and free cataract surgery camp in August. Doctors' Day celebration was conducted on a hybrid platform, felicitating 4 doctors from different fields actively involved in the fight against COVID. This year, for the first time, IMA headquarters conferred 6 honorary professorships. I am proud to announce that Dr. Shivkumar Utture and Dr. Sachin Patharkar of our branch received these prestigious professorships. Friends, we are proud to announce that we have started a fully functional, state-of-the-art family planning and vasectomy center in our premises, financed by Vilu Punawala Foundation. Friends, the galaxy of speakers will make you wiser, and the gourmet delight will deliver a sense of fulfillment. Let us enjoy this academic and gourmet feast. Let us get connected with each other and with old friends and recreate the old lost world of fun and frolic. Friends, this mega event is a testimony of commitment, hard work, and team spirit of our branch. To sum up the solidarity, I conclude by saying, बुलंद हौसले है हमारे मंजिल तो क्या आसमान छूने की ताकत रखते हैं. Thank you. Jai Hind, Jai Ame.
Thank you, sir. I request the Chairman, Souvenir Committee, Dr. Rajendra Trivedi, and Dr. Suresh Doshi to please be on the dais for the souvenir release ceremony. I request our Chief Guest, Director of Health Services, Government of Maharashtra, Dr. Sadhna Taide ma'am, and dignitaries on the dais to release the souvenir.
Thank you all. I request Secretary IMA CGP, Mumbai Sub Faculty, Dr. Kajal Ahuja, to introduce the guest of honor, immediate past secretary, IMA Maharashtra State, Dr. Pankaj Bandarkar.
Dr. Pankaj Bhandarkar is a grassroots worker of IMA. He is the immediate past honorary state secretary, IMA Maharashtra State, and senior vice president of IMA Mumbai branch. He did his graduation from the prestigious CGS Medical College, KM Hospital, Mumbai. He is a family physician practicing in South Mumbai for the last 40 years. During COVID-19 pandemic, he served the community without break. In appreciation, he received COVID Warrior Award from IMA Maharashtra State. He has received many IMA President Appreciation Awards from his branch, IMA Maharashtra State, and IMA headquarters. He is recipient of many awards for his extracurricular activities, which include paintings and sculpturing. He is associated with many social organizations and schools. Thank you.
I request our guest of honor, Dr. Pankaj Bandarkar, to address the gathering. Dr. Pankaj Bandarkar.
Good afternoon, everybody. Respected President, IMA Mumbai branch, Dr. Jitesh Bhai Mehta, Chief Guest for today's inauguration, Sadhna Thaide Madam, MMC President, Dr. Shivkumar Utture, and all the office bearers of IMA Mumbai branch, as well as office bearers from IMA Maharashtra State. I'm very happy to be a part of this inauguration ceremony of 51st conference of very, very prestigious and vibrant large branch of IMA Maharashtra State. I am also as hungry as you all who are over here, so I'll be very brief. As she has mentioned, I'm a grassroots worker of IMA, hence I will like to bring to your notice only few points. Friends, what respect and we enjoyed few years back from our patients is not so now, which is creating lot many problems, and we are facing not many problems because of the new laws which are coming up. All of us have worked very hard during COVID. One of those, it was like a war-like situation, and you know, one of the ground person who was working very hard during such time, Dr. Anil Pashnekar is there, and guiding them, Dr. Utture, during that period is also over here. Friends, I just want to remind you one incident which happened in Nagar, a fire incident. And one doctor, a budding doctor, and 4 nursing staff were behind the bar. The investigation is going on. But what I want to reiterate is we are treated like a crime. That's what our feeling is. Being a doctor, we are potentially criminals. That's what we think as a fraternity. There are so many laws coming up without taking in consideration the stakeholders' opinion. Last few years, IMA is very active and acting proactively. Still, there are certain rules, regulations which are coming up, which are really bothering us and making our practice very difficult. Taide madam is from gynecologist. For example, we take PCP Indity Act. So many our doctor friends are suffering a lot because of this law. As a IMA, we don't want to protect all the people, all the doctors who have done something wrong against the law. But just on technical grounds and few people, cases are filed, and for years together, there is no result coming up, and that hanging sword is always there with them. Similarly, we have a CEA, which can make our practice impossible. Luckily, we have all stalwarts, knowledgeable people in our IMA who have formulated a Maharashtra-specific CEA, which was about to be accepted by government, and in between, that new Bombay Nursing Home Act Amendment Bill was passed. Now here again, last 2 years we were fighting, we were meeting all our authorities, and ultimately, I think only last month, they have given us the appointment and things will go on. In short, what I want to say, there is a CPA also, where we are treated like a traders, and they expect us to be we have to do a charity and all those things. But when you are calling us as a traders, then of course we will see the patients as a consumer. So that is not correct. The whole patient and doctor's relationship has gone somewhere wrong, which is creating a lot of problems for both, for patients also, and for us also. It is more on the side of patients. So, in fact, what I want to tell today and take this opportunity to appeal to all of you who are present here, because you all are like our family members, IMA family and Modern Doctors family, to at least do something for IMA, which is fighting at all levels, local levels, state level, as well as headquarters level, considering and taking consideration all these problems we are facing. So least you can do is at least help and make more members. If I am correct, we have in Maharashtra more than 1,70,000 RMPs, and only 45,000 people are members of IMA. So we are looking forward to have more and more members. This we are saying so because ultimately in democracy the number counts. And to have that number, to make the government listen to us, we must have that number. So that is my humble request to all of you. Each one of you at least get one. Most of our friends are out because they are hungry. We also will be going in sometime, so I will have to take a break over here. But before ending, because I have reiterated all the problems, but there are certain good things which have happened, basically in the MMC. Age-old days, when we registered, after passing, you must be remembering how the office was, a typical government office. Last 2 terms, our people are there in MMC. I think first term it was for only 3 years and next for 5 years. A very good state of art office is formed, and now the functioning is totally digital. The man behind this is no more than Dr. Shivkumar Utture, who has that vision, power, and ability to get it done. So I stop here and request our president, Dr. Jitesh Bhai Mehta, to request Dr. Utture to say at least few words, and at least few words, sir. I know. And once again, I thank all the IMA Mumbai branch office bearers and organizing committee for allowing me to say a few words in front of you. Thank you once again.
Thank you. Thank you, sir, for your kind words. You are just a symbol of simplicity redefined. I request Conference Organizing Secretary and President-elect Dr. Anil Awad to introduce Chief Guest, Director of Health Services, Government of Maharashtra, Dr. Sadhna Taide Madam. And I request our President, Dr. Jitesh Mehta, to felicitate our respected Chief Guest, Dr. Sadhna Taide Madam.
Dr. Sadhna Mukund Taide is the Director of Health Services and Director of State Blood Transfusion Council, Maharashtra State. She is MBBS and MD Gynec and Ops degree holder. In the past, she had held posts of Additional Director of Mental Health Program, Joint Director NCDs for Maharashtra State, Deputy Director of AIDS Control Society, Medical Officer, JJ Hospital, Mumbai, and Medical Superintendent, Kama and Albase Hospital. She successfully spearheaded all national programs related to non-communicable diseases across Maharashtra. Besides establishing chemotherapy centers, she developed a cancer registry at Kolhapur in collaboration with Tata Memorial Hospital, Mumbai, and developed a state-of-art radiotherapy unit specially for women in Kama and Albase Hospital, Mumbai. She has extensively contributed towards various projects of mental health and rehabilitation of patients at mental hospitals, played a key role in implementing tobacco control program in Maharashtra and publishing various tobacco control related government resolutions. She has strengthened the prevention of parent to child transmission program in Maharashtra. She has presented papers at various prestigious conferences. She is actively associated with Federation of Obstetric and Gynecological Societies of India, Mumbai Obstetric and Gynecological Society, Maharashtra Medical Council, and MUHS Nashik.
Madam, we are fortunate to have you as the chief guest for the event. Now I request you to say a few words.
Thank you very much, and good afternoon to all my colleagues. The respected dignitaries on the dais, Dr. Anil Awad, President-elect, Dr. Girish Lad, Honorary Secretary, Dr. Pankaj Bhandarkar, Guest of Honor, Dr. Jitesh Mehta, President, IMA, Dr. Shiv Kumar Utture, President, Maharashtra Medical Council, Dr. Attar, past President, IMM, Dr. Shingnapurkar, Honorary Treasurer, and all my dear colleagues. I'm indeed honored and feel privileged for opportunity to address the esteemed doctors fraternity, the oldest and the largest democratic body representing all doctors of modern scientific medicine in our country, the Indian Medical Association. Over the years has been flag bearer for the diverse medical community in Maharashtra and all over country. IMA is committed to the betterment of medical profession in India. IMA serves for the humanity, endeavoring to achieve highest standards in medical education, medical ethics, and medical care. With a huge force of doctors as members, IMA is easily one of the largest association. We see IMA as a long-term formidable partner where prime beneficiary will be the patients as they get high quality care at affordable cost while reducing the out-of-pocket expenditure. Standing here, I must proudly acknowledge the healthcare achievements in public health sector, which Maharashtra government, with the help of all doctors, private practitioners, has done. Today, we see that the infant mortality rate of Maharashtra is just 17 as compared to the national average of 30. And this was achieved with the help of you practitioners only. The maternal mortality rate is 46 as compared to the national average of 113. Institutional delivery rate is 94.7% as against the national average of 78%. The average life expectancy in men and women are 71.2 and 73.9 as compared to national average of 67.8 and 70.4 respectively. So all these indices, they show that the healthcare system in Maharashtra is working very hard and very beautifully. The COVID pandemic, you all know that the COVID pandemic hits us hard since the beginning of March 20. At one end, the public health services were coping to address COVID-19 pandemic, while at the other end, we were committed to maintain the routine health services during the nationwide lockdown. The overall response to pandemic witnessed both private and government sector working in tandem, which involved significant investment in preparing facilities for prevention and control of infections, building or modifying infrastructure for the treatment of patients, equipping facilities, developing capacity of frontline health workers to tackle the pandemic and health education of general masses. Since the first case in Kerala in Jan 20 and in Pune in March 20, the number of cases in India tallied to 4.28 crores as on 1st March 22. Maharashtra shared the maximum number of cases in India, that comes to around 78.66%, and with overall recovery rate of 98.04%. Our fatality rate was little high in the beginning, but then it reduced to 1.82%. Multiple efforts were invested by Public Health Department in coordination with other departments and private sector to control spread of COVID-19 pandemic, such as initial screening of passengers at airport was started for the high-risk countries. We set up almost 688 RT-PCR labs in Maharashtra for the diagnosis of COVID-19. And today, the result turnover time is reduced to less than 48 hours. And the credit goes to all private practitioners, those who are involved in this, developing the RT-PCR laboratories. Because in spite of capping the rate, they help us a lot. The robust surveillance system was established in Maharashtra, and we conducted this survey with the help of more than 4,000 teams in all over Maharashtra. We could trace almost 92.2% of contacts with the help of these teams. Based on Government of India guidelines, a 3-tier treatment and a care system was established in Maharashtra with the help of private hospitals only. We started with, initially when the COVID pandemic was started in March 20, that time we started with hardly 7,000 beds, 3,000 ICU beds, and 1,100 ventilators, with only 211 facilities in Maharashtra. Currently, if you will see that, currently Maharashtra is having more than 4 lakhs beds available in Maharashtra, 39,000 ICU beds, and more than 15,000 ventilators available in all over Maharashtra in 6,500 facilities. Oxygen management, which is the key to COVID-19 treatment, are operationalized in all districts of Maharashtra with 331 PSA plants functional today in Maharashtra. And if you will see today, we have a capacity to store more than 3,500 metric tons of oxygen. So I don't think there will be any problem for the third or the fourth wave. So our capacity building is done, infrastructure is increased, and this was possible because of you all people who are working very hard day in and day night. Thanks for all your efforts. State also ensured that the required medicine, including injection remdesivir, injection amphotericin B, medical equipments and supplies such as PPE kits, masks, etc. are available at all levels in sufficient quantities. The death audit committee were constituted to analyze the reasons for death. Health education was the mainstay of COVID-19 pandemic. Also, capacity building of all frontline healthcare workers in all aspects of COVID-19 pandemic management was imparted. Not only the physical health, but also the mental health care was imparted by engaging psychiatrists, clinical psychologists, counselors to tackle post-COVID stress in COVID patients and their families. COVID-19 response from state government could not have been possible without a generous support from private sector during emergency. I am happy to share here that not only during the COVID-19 pandemic, but the private sector has been part of various national health initiatives in achieving the sustainable development goals in health. And that's why today, all the indices of Maharashtra are at par with other states in the country. For example, I'm just giving one example that Foxy under Nari Swasthya Pahal conducts free checkups for women on 9th of every month. The private health sector also help us in providing end-to-end healthcare services in unserved and underserved areas of tribal areas. Due to time constraint, I may not be able to elaborate all symbiotic association with private health sectors, but I would like to stress upon that the collective efforts can bring unbelievable changes that can make positive impact on health in generations to come. I do understand that there are some constraints, such as capping of rates, regularization under Nursing Home Act, implementation of PCPNDT Act, which can be sorted out by proper dialogue and mutual understanding. As a representative of Public Health Department, Government of Maharashtra, I strongly urge the esteemed organization to continue their support to the state government in delivering quality health care. And last but not the least, I would like to give big thanks to IMA and congratulate them, especially Dr. S.S. Utture sir and his dedicated team for providing us continuous support during COVID pandemic. I distinctly remember that whenever there was shortage of physician or any medical person, I used to call Dr. Utture. And he immediately called the IMA person and he said, yes, madam, I will give you free consultation. So that was the support we got from IMA. Thank you. And my best wishes to all Indian Medical Association and for their par excellence work. Thank you very much. Thanks, sir.
Thank you very much, madam. I may say, madam, I may say, madam, that you are really an epitome of meticulous and methodical Management of Health Services. Thank you, Madam. Now I request President Maharashtra Medical Council and Executive Member National Medical Commission, Dr. Shivkumar Uture.
Yeah, good afternoon, everybody. I'm not here to give any speech or talk or anything, but I thought since this is a vote of thanks, before giving the vote of thanks to everybody else, you have to understand that I think this is the first physical meeting we are having after 2 years, and I hope all of you all are enjoying that. And I would like to place my appreciation for the whole team under Dr. Jitesh, Dr. Lad, and organizing secretaries for having worked to make this a grand success. And let me tell you, this is one of the first huge scale conferences which is being held, and you have to give it to them because in January, when everything was prepared for a physical conference, they had to close down that conference because of the government notification. So right from predicting the day that in future the government would open up all the, all the hotels and all for us, to arranging this they have given. So I feel to the whole team, not only who is sitting over here, but even on the first bench, we should give a standing ovation to them for having conducted this conference and bringing the whole IMA family today, because right in the morning I would see when we were asking people to come, they used to tell us, no, wait, we are meeting each other after more than 2 years, so let the family members meet. So thank you very much for having made this possible, all of you. So this is the first vote of thanks. The rest of the vote of thanks will be given by the whoever has been deputed for that. Thank you.
Thank you, sir, for your kind and encouraging words. Now I request Honorary Joint Secretary, IMA Mumbai Branch, and Honorary Joint Treasurer, IMA Maharashtra State, Dr. Arvind Patel, to propose a vote of thanks.
We thank coronavirus for bestowing mercy on us and showing receding trends. Good afternoon, friends. It gives me immense pleasure to propose the vote of thanks of the inauguration ceremony of the 51st Annual Conference 2022 of Indian Medical Association Mumbai Branch. We thank our chief guest, Dr. Sadhna Taide Madam, our guest of honor, Dr. Pankaj Bandarkar sir, for sparing their valuable time despite from their busy schedule and gracing this special occasion. We thank all the speakers who have imparted valuable knowledge to us. We thank all the dignitaries from various IMA branches and medical association for their kind presence. We thank our President, Dr. Jitesh Mehta, Honorary Secretary, Dr. Girish Lad, all the office bearers and managing committee members for using their good offices to make this function a grand success. And last but not the least, we thank you all delegates for your kind presence. Without you, this conference would not have been a grand success. Thank you all. Thank you all of you. Please join for lunch.
Friends, we have half an hour this time for lunch, and we are starting our post-lunch session sharp at 2:50. So I request you all to be in the auditorium by 2:50. So enjoy the lunch and come back very soon.
एक बाजू एक्सेलर आणि एक बाजू फोल्डर करून येतच नाही तर काय
Hello. 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 Usha. Good afternoon, everybody. Once again, I welcome you all on behalf of Indian Medical Association Mumbai branch to our this annual conference. I hope you all have been enjoying since morning. We had a very eminent speaker and we have delivered a good deliberation from them with a lot many take-home messages. And you also must have enjoyed the lunch. So now you are geared up for the post-lunch session. And so we proceed with our post-lunch session. And our first speaker is Dr. Arun Shah for Mathurdas Parikh oration. And to introduce and to welcome him, I invite Dr. Akshay Shevak and Dr. Vijay Karanjkar to come on the dais to chair the session.
Good afternoon, everyone. Dr. Arun Shah is a consultant neurologist and postgraduate teacher and director of the Department of Neuroscience at Sir H.N. Reliance Foundation Hospital and Research Center. He completed his MBBS with gold medal, MD in internal medicine and DM neurology from St. G.S. Medical College, Mumbai. He completed fellowship in cerebrovascular diseases and stroke at the Oregon Health Science University, Portland, Oregon, USA. He was professor and head of Department of Neurology at TN Medical College and BYL Nair Hospital, Mumbai. He was the first neurologist in Mumbai to use reperfusion therapy in acute stroke in 2002. He is actively involved in clinical research in the field of stroke, dementia, and Parkinson's disease, and has delivered several lectures at various prestigious meetings. Today, he will deliver Mathuradas Parikh oration on approaches to rapidly progressive dementia. I invite him on the dais. Mathuradas Parikh oration, Mr. Girishbhai Parikh, Director of Zendu Pharma, has donated for elderly welfare in memory of his grandfather, Mathuradas Parikh.
Good afternoon, everybody. I think it's the post-lunch session, so let's hope we don't slip off. And because I want to make some important points and make it interesting by showing you clinical cases, so that makes it less boring a topic, which is of course rare. I think I was prompted to start this topic because of the good response we had when we talked on Alzheimer's dementia. Whole session we kept, and attendance was more than 600 people. So I thought people are interested in degenerative dementias. So I think this is a subset of conditions which I want to highlight, because one has to, the importance of recognizing this syndrome is that there are many of these are treatable as versus degenerative dementia, as we discussed in our webinars last year. So that's why it is important for you to at least get a glimpse of principles of this concept and how we manage with that. So my objectives of the top is first to introduce the concept of rapidly progressive dementia. I'm going to describe to you 3 clinical cases, list the differential diagnosis, which of course you don't have to remember, you just remember the mnemonic and category is good enough, and then explain you the rational diagnostic approach. Now, as we know, what is dementia? I think dementia is where there are impairment of more than 2 cognitive domains. As you know, cognitive domains consist of language, memory, apraxia, agnosia, apathy, and executive functions. So if you have more than 2 impairment of functional domain to an extent that your day-to-day social living in a social environment becomes difficult, that is, there is functional impairment. And that's the textbook definition of dementia. And one, of course, has to make sure there are no better explanations for this term, and it is a general umbrella term. And we see this is just a schematic diagram that dementia word is an umbrella term, and underneath we have various conditions, which is Alzheimer's would account probably 60 to 70% of dementia patients. Lewy body dementia is a rarer variety, accounts for about 5 to 10%. Vascular dementia, the people who have vascular risk factors and go into multiple strokes, accounts for about 5 to 10%. The rare familial variety of dementia, that is frontotemporal dementia, accounts for about 10%. And then we have rarely Parkinson's disease, Huntington disease, which as associated with immune disorder also may have dementia. And whenever you have more than 2 pathologies, we call this mixed dementia. Important to remember that these are in general, dementias are slowly progressive diseases. Their history would, if you take a history of a person who is coming to dementia for Alzheimer's, for example, the onset to cognitive impairment will be at least more than 2 years. So when you have this interval less, that is where the concept of rapidly progressive dementia started. So this is an entity, their functional impairment is manifest within weeks to months of the onset. And that's why we want to separate this out, because the differential diagnosis is different, management is different. The classic example, I'm sure you must have heard, a lot of publicity was given to mad cow disease, and then that is a variant of prion disease, and that is a prototype of rapidly progressive dementia, where dementia progresses within months or within weeks to months. However, there are several autoimmune, toxic, metabolic, infectious, and neoplastic, and of course the vascular processes which cause similar syndrome. And most important point is many of these later are easily treatable, and it's important for you to diagnose them rapidly so that most of them can be reversed if you diagnose them early. And this is how the concept of rapidly progressive dementia is existing in neurology field for the last 2 decades or so. So this is just a mnemonic, so it's very difficult for anybody to remember all the causes, all the conditions which can cause that. So when you are faced with a case like this, classify them into what is known as vitamins, that is vascular causes, infectious causes, toxic metabolic causes, autoimmune causes, metastatic or neoplastic causes, iatrogenic or drug-induced or neurodegenerative diseases. One of them which I just mentioned is prion disease, and sometimes you have systemic illnesses which can cause rapidly progressive dementia. So it's important to go through this, and then under each category we have several causes which you need not remember. If you just remember this concept that when you go to trace the case, go through these causes and make sure you don't miss any particular entity. So this is the chart pie diagram from one of the series, a dementia specialist center, where rapidly progressive dementias were referred, and they analyzed their cases in about a decade or so. And if you see what is the percentage of cases, so if you see patients with rapidly progressive dementia, about 25%, that is 1/4 will have what is known as autoimmune disease, dementia or autoimmune encephalopathies, and these are probably treatable conditions. You have about 16% where the cause could not be established despite various investigations. We have prion disease, which is, as I told you, prototype, is almost about 16%, where there is no treatment at the moment. Neurodegenerative, rapidly progressive dementia, such as sometimes Alzheimer's and so on, so forth, when develops already. And then we have another 30%, about 23 or 30%, that means almost 1/3 of them could have recoverable causes, such as toxic metabolies, infarct, HIV-related dementia, neoplasm, which can be treated, and so on and so forth, and certain infections, which can be sometimes treated. So in general, what we are looking at is catching all this about 50% of patients where there could be something done as opposed to their other 40% of patients where most of the need is degenerative and we have no treatment options at the moment. So this is the big list of workup which has to go through, but of course the workup has to be not so exhaustive as mentioned in this slide. What one would do is an approach where you do a core testing, where you do a testing, certain testing which must be done in every patient. Then you do a expanded testing depending on your results of core testing, which would amount to various things which are mentioned there. And of course, rarely you may have to go to extended testing, which may include brain biopsy or an organ biopsy to arrive at a diagnosis. So the clinical bedside approach would be to do core in everybody. Then depending on your whatever is highlighted, you do expanded testing, and then of course do an extended testing. So I'll go through now the causes. So this vascular is everybody knows that people who have multiple infarcts and a strategically located infarcts when give you dementia. So person who has bilateral thalamic infarct may develop amnestic syndrome and dementia. Within just first stroke itself, he may develop dementia. Then you have people who have multiple infarcts, such as hypertensive people with small vessel disease. So there's multi-infarct dementia. And of course, there is subcortical dementia where you have multiple small vessel disease in a hypertensive person or a diabetic people who can develop this. And there are rare varieties of white matter diseases or ischemic diseases like CADASIL. And of course, what is interesting coming up is this concept of cerebral amyloid angiopathy, which comes in people with Alzheimer's disease. And they have amyloid angiopathy, which is sometimes treatable because it is inflammatory in nature. So this is generally the vascular causes, and I'll just run through. I'll not waste more time here. Then there are infections. Of course, in infections, the commonest variety of dementia which we see is, of course, HIV dementia. And despite, I think, availability of antiretroviral therapy, the dementia is still not preventable and it still is seen rigorously. Then there are various other conditions which are listed here, like JC virus infection, that is PML. Then people who have not been vaccinated for measles can develop SSP, but much less common now with vaccination going on. Neurosyphilis, fungal infections. Lyme disease, of course, we don't see in India, and Whipple's disease is another thing which have granulomas in the brain. So these are some of the infectious causes of rapidly progressive dementia. I'll go on to the first case of my presentation. This is a 57-year-old LIC agent who is non-hypertensive diabetic, and his history of neurological illness is only 3 months. He has progressive cognitive decline, characterized by recent memory impairment, difficulty in calculations, inability to do day-to-day tasks, and he had to give up working within 1 month of onset of his symptoms. Of course, associated with this, he had behavioral problems such as insomnia, hallucinations, and irrelevant talks. And then he developed motor phenomena, that is gait difficulty and imbalance while walking. In the background history was that he had episodes of diarrhea, 5 to 8 episodes of large quantity stools, and was diagnosed as Crohn's disease, and was being treated with capsule bidets and of course intermittent prednisone therapy. He of course had initial hypothyroidism, and during these 3 months of illness, he had lost almost 10 to 11 kg of body weight. So he was admitted in a suburban hospital, well investigated in detail. While the hospital investigations, CSF was normal, anti-TPO was one reason which they had done, which was nominal, EEG was normal. His MRI brain, they have depicted here, showed some sort of cortical ribboning, which later on I thought was not a correct ribboning. It was not confirmed by our studies at Reliance Hospital. And he was treated with methylprednisolone without any relief, and he was transferred in an encephalopathic phase in our hospital. When we came here, he was underweight, his nourishment was poor. He has generalized muscle wasting, he had pallor, edema, and he had most important diagnostic feature which we found was hyperpigmented skin lesions over the bilateral upper limbs dorsal aspect. And of course, the angular ciliosis as shown in this frame. You can very well see the ciliosis, bald tongue, and this classic this. So all senior physicians here would probably know 3 Ds, dementia, dermatitis, and diarrhea. And that's what probably we came to a diagnosis. So many investigations did not give us a clue, but what gave us a clue was a clinical examination. These are his findings. On detailed examination, we did find there was a myeloneuropathy in addition, and we diagnosed him to have pellagra. He was treated with IV nicotinamide, B1, B6, and he recovered completely at 12 weeks. His MRI brain, of course, was normal at our center, and if you see, the skin has completely recovered. So logical examination and understanding probably gave us a clue, and is well defined that pellagra, though rare now, it can occur as a condition deficiency in people who have been probably treated, or of course, Dr. Lakdawala is here, people who undergo bariatric surgery can come out with various vitamin deficiencies and can develop rapidly progressive dementias, and we should think of this as an important condition. So he was treated well and of course come out well. So in general, toxic metabolic conditions which should be thought of in people with Rett syndrome, B12 deficiency, B1 deficiency, niacin deficiency, folate deficiency. Then of course people who have chronic liver disease, acquired or Wilson's related, can develop dementia. Then porphyria, probably the heavy metal poisoning, and electrical impulses. So these are various, in nutshell, brief conditions which you should thought of in this under the category of toxic metabolic conditions which can give you dementia. This is of course the classic of Wernicke's encephalopathy, where this is of course this condition is more of an encephalopathy, not so much as dementia, but it can present as dementia as well. B12 deficiency everybody knows. So now I move on to switch gear to the next entity under vitamins, that is A factors or autoimmune or mediated growth. So this is a very important concept which is again developed over the last 15 years, that there is a group of neurological diseases which are caused by autoantibodies directed against neurons. And this is an emerging recognition that many of these people we have surface antigens. If you diagnose them early and give them immunomodulating therapy, they recover, and that's why every patient of rapidly progressive undergoes. And this field has expanded so much that every year some new antibody is diagnosed and is identified. So this field has to keep up with the commercially available kits, will not test all of them. That is another important thing to remember. And I will just show you an example of a case which we have. As a 66-year-old man, he had a 4 months history of neurological illness, has difficulty in speaking and change in speech. He had impaired recent memory and altered behavior. The most characteristic feature of this gentleman was sleep disorder. And sleep disorder was so much that in the night he would have fragmented sleep. He would wake up every now and then and shout. And of course, wife had to sleep in a separate bedroom, and she couldn't sleep next to him. And then, of course, he started having difficulty in speaking or dysphonia and gait ataxia. So with this syndrome, he came to us about a year ago. He was conscious and alert. His MMSE was difficult to test because he had very thick speech and hardly could speak. He had bulbar weakness, his depressed gag. Motor power was preserved except for the left upper limb discs, and he had, of course, truncal attacks and couldn't walk. So his polysomnography confirmed that he has a RAM and non-rapid eye movement disorders, behavioral disorders, plus, of course, he was having obstructive sleep apnea as well. His MRI brain was non-contributory, which was not important. Even if you advise MRI is normal, doesn't mean you are ruling out many important conditions. What helped us is the FDG PET scan. When FDG PET scan is shown, these whatever red areas are the areas where the increased glucose uptake has occurred, which has occurred in brainstem, basal ganglia, and so forth. So I know we had something abnormal or some encephalopathy going on. And this is the findings of FDG PET scan. And when we investigated him, CSF was normal again. We did the paraneoplastic panel and autoimmune panel where both were negative. Then we did a CSF, and CSF we asked for a special antibodies which is known as Ig lone 5 antibodies. These are again neuronal antibodies which cause autoimmune disease, and this assay was not possible with all the commercially available Metropolis labs and all that. We had to send it across to Amrita Institute in Kochi, where Mayo Clinic has set up a center there, and that confirmed that the diagnosis was Ig lone 5 syndrome. He was treated with methylprednisolone, intravenous IV infusion was given, and of course he required bypass support because of his nocturnal obstructive sleep apnea. And he was later on maintained on rituximab, and I think 2 years down the line, he's come for follow-up just last month and is absolutely normal cognitively, except that he needs CPAP at the night because of his OSA. So if you diagnose him probably this 4 months history and the whole illness was so this is Ig lone 5 antibody syndrome, which is now famous. This syndrome you will hear more and more because it appears that it can mimic certain patients with degenerative brain, Parkinson's disease as well. So I think in future, some of patients who are rapidly deteriorating Parkinson's disease or atypical Parkinson's disease, you may end up doing this test and it may come out to be positive. So rapidly, so what are the other autoimmune disorders one should think of? Of course, I already mentioned about paraneoplastic, non-paraneoplastic autoimmune, which is what lone 5 is. Then the SLE can sometimes present with lucid cerebritis, which can present with subacute dementia. And vasculitis and of course neurosarcoidosis also can sometimes present with or, rapidly progressive dementia. So as I mentioned, prototype of degenerative dementia, the rapidly progressive dementia word came basically for prion disease or CJD. And that was, it's a rare disease, affects about 1 to 1.5 per million per year. There are different varieties. One is sporadic, and of course you have genetically determined hereditary prion, and of course the variant disease. Obviously, the prion, it's supposed to be some disorder where prion protein is a normal protein in the body. When it gets transformed, gets misfolded, then it becomes transmissible. So this misfolded protein, when it goes to a normal cell, it changes all the prion proteins there into misfolding. And that's how the disease progresses. Accumulation leads to the classic variant of spongiform encephalopathy, and patients usually present with short history. They have personality changes, psychiatric problems, ataxia, involuntary myoclonic jerks. They may develop Parkinsonian syndrome, memory problems, confusion, and usually the lifespan is about few months, 6 months or so. Most of them, very rarely, they survive for a couple of years. And the disease we don't have handle as yet. It is diagnosed on the basis of MRI. There is a probability is diagnosed in the classic MRI, which is shown here. Is you see a cortical ribboning, and you see increased uptake of diffusion restriction in the basal ganglia or putamen and cortex. And of course, EEG is again classic. It shows periodic complexes as shown here. So of course, you require biopsy to be definite, but we don't do biopsy in these patients. If you have probable diagnosis on the basis of clinical criteria, MRI and EEG, it is sufficient to make a diagnosis of CJD or Alzheimer's disease. And of course, there are a new lab test which is not available in India is RT-QIC assay, and this is of course available and it can be done in certain cases. So there are other, as I mentioned in my talk, some of the rapidly neurodegenerative disorders can be rapid, and these points I've already discussed. So we'll not go into this detail, and let me end with the last case. This is a 70-year-old radiologist by profession. He had progressive cognitive decline from March 2020 month. This is a recent case. He had again recent memory impairment, personality change. He continued to report for some time, but later on he couldn't find words while typing or reporting. And he complained of intermittent headaches, and he had walking difficulty in November. He had, of course, associated diabetes, hypertension, irritable bowel syndrome, glaucoma, and vitiligo. So when he came to us, he was awake but disoriented in time place. His attention span was reduced. He could not do simple calculations. He could not find proper words. He had no focal signs as such except for mild pronated drift. His detailed investigations, which was already done outside, showed that most of the systemic investigations were all negative. His CSF, of course, was abnormal. CSF showed protein 90, glucose normal, cells were increased, and his investigations for TB, meningitis, ADA, gene expert, everything was negative. These are a serious CSF samples from almost 6 months, which showed cells from 230, 210, 60, 110, 12. We were not coming to conclusions what was going on. It was obviously not an infective illness because his presentation, he had no fever, nothing. What he had is just dementia and a little bit of headache. So finally, when his MRI brain done repeatedly showed that there was enhancement of meninges. If you see this, arachnoids are enhancing in this area. So ultimately, we took a biopsy from that area, and it turned out that it was a B-cell lymphoma, which was causing meningitis or meningitis involving the arachnoid and pia. He was treated with therapy, and as you can see, his November 21 MRI shows all the abnormalities. And in Jan 22, the whole thing has cleared up. He is being treated now and is improving. So intravascular lymphomas can cause rapidly progressive dementias and B-cell lymphomas and all that. So I'll just complete the list of endocrine and neoplastic conditions which can present rapidly. Always hypothyroidism can present with dementia, parathyroid abnormalities, adrenal disease, or autoimmune metastasis to CNS, primary CNS lymphoma, intravascular lymphoma, and sometimes the brain tumors such as gliomatous cerebri can present with this syndrome. So let me conclude. By evaluation of rapidly progressive dementia needs a systematic approach. We need to go beyond routine dementia screen. Of course, history taking and clinical features will give important clues as we shown in the first case. The prion disease, of course, you need to diagnose them properly, positively, not because of exclusion. Whenever you're in doubt, don't label them. investigate them further because you may find a treatable cause. The field of autoimmune encephalopathy is rapidly growing, and this is very important cause of rapidly progressive disease, particularly treatable cause. Imaging studies, including PET scan, is available in arriving diagnosis, and at times, for early treatment and proper assessment, you may need to hospitalize the patient. Thank you very much.
Thank you, Dr. Arun Shah, for his excellent talk on dementia.
I'll request Dr. Akshay and Dr. Vijay to felicitate Dr. Arun Shah.
Hello.
I'll request Dr. Jitesh Mehta to felicitate Dr. Arun Shah.
Number 294, sorry. Dr. Ganesh Kolle. Dr. Ganesh Kolle. Dr. B.S. Apte. Dr. B.S. Apte. And Dr. Ganesh Kolle.
Thank you, sir. I request Dr. Usha Shah to felicitate our chairperson, Dr. Akshay and Dr. Vijay. Our next speaker is Dr. Muzaffar Lakdawala. To chair the session, I request Dr. Anil Awad and Dr. Vijay Punjabi to come on the dais. Thank you, sir. Thank you. So, Dr. Anil Awad and Dr. Vijay Punjabi, I request them both to come on the dais to chair the next session. And our next speaker is Dr. Muzaffar Lakdawala, who is going to speak on benefit of robotic surgery in general surgery. Dr. Anil Awad.
Good afternoon. Dr. Mufazzal Lakdawala is India's best-known laparoscopic surgeon specialized in bariatric and gastrointestinal surgeries. He is Director of Department of General Surgery and Minimal Access Surgical Services at Sir H.N. Reliance Foundation Hospital, Mumbai. After passing MS General Surgery from B.Y.L. Nair Hospital, he was trained in bariatric surgery at Cleveland Clinic, USA. He was further trained in gastrosurgery at University of Ghent, Belgium, and in advanced laparoscopic colorectal cancer surgery at Seoul, Korea. He was honorary surgeon to the Vice President of India, Dr. Venkaiah Naidu. He has won numerous awards. To name a few, Best Surgeon in the World Award by the American Society for Metabolic and Bariatric Surgery, the World Master Educator Award by International Federation for the Surgery of Obesity, Rotary Excellence Award, Giants International Award, Lokmat Maharashtrian of the Year, and many more. During Corona crisis, he volunteered his time, skills, and services with BMC to set up a dedicated COVID hospital at NSCI Dome, Mumbai. He received the Corona Warrior Award for his exemplary work in Corona pandemic. Today he will speak on benefits of robotic surgery in general surgery. Over to Dr. Mufazzal Lakdawala.
Thank you very much, and it's always a pleasure to come back and speak at IMA. So without much ado, I'm going to speak to you about something which is still alien to us. We only hear about robots, but what about robots in surgery, and why have I got into it of late? I'll just share a little bit. So Da Vinci, we all know about Da Vinci, and this picture has been so common to us. Well, why the company named it Da Vinci is only because the multiple positions that the arms and the legs can take whilst you're doing surgery. Ideally, classically, that's how a robot looks. You've got a surgeon console, you've got a patient cart, and then you've got instrument cart. So that's how robotic, all these three things form a very important part of how we do robotic surgery today. So going back to robotics and how it's progressed in the world, well, it is not too long back that robotics started, all right? First robotic biopsy was for the brain in 1985, in April of 1985. So in 1980s is when the advent started. In 1991, the Probot, which was the first use of robotics to remove a significant amount of tissue from the prostate of a human being. 1992, Robotalk was first used in humans. Robotalk got FDA clearance in 1998, so it's been only a 20 to 25-year journey. Da Vinci was launched by Intuitive in Jan 1999, and then everything around robotic kind of changed. The ESOP robot, which was launched before Da Vinci, of course, has not made. And now as we move forward, well, we do know what all has happened. So we started with the first robotic surgery, which was Puma 560, which was like in the brain biopsy in 1985. ESOP was first used for manipulated introduction, and Da Vinci with the Zeus computer motion was used and FDA approved in 2000, 2001. So it's only in this century that actual robotics has made an entry into surgery. Well, today, when we speak, we all talk about prosthetic surgery, which is very common now to be done with the robo. Most urology, most gynecological procedures are very much, but what about other procedures? So now, today we have knee replacements and hip replacements all being done with robo-guided mechanisms. So robo has come and made a role into our thing. But so far in the field of general surgery, it never really made inroads. Well, something that we do know about, we've moved from the era of open surgery to laparoscopy, and the eventual movement is going to be in robotic. But the movement from laparoscopy to robo has not taken as much as we thought it would move that fast, only because most gifted laparoscopic surgeons are doing it almost the same way. So the advantages of laparoscopy over open surgery, like minimal scarring, earlier return to work, cosmesis, lesser pain, better enhanced outcomes, all remain the same. So what's the difference when it comes to between robotic and laparoscopic surgery? Well, in robotic, the camera is a 3D camera without you having to wear 3D glasses, which if you operate throughout the day can be quite cumbersome to your eyes. The surgeon sits comfortably on a chair, so he does not have to play all these various motions that he does in laparoscopic surgery. The instruments of the robo can move 360 degrees, and that's the main advantage. It can access places that a human hand cannot reach. For example, in thoracic surgery, where the rib cage is kind of difficult to manipulate instruments inside, or deep in the pelvis. That's why prosthetic surgery really picked up with robotic surgery. So those are areas with the enhanced vision, with the flexibility and dexterity of the robo that has come in. And today, with the XI robo, all that is very possible. So far, and in terms of oncosurgery, we never really ventured in because the staplers were not available. So you needed an assistant to use the sealant, the harmonic or the ligature to seal the vessels or buzz the vessels. But that only the assistant could do. You could not do it yourself. With the advent of the XI, everything has kind of changed. So of course, like I said, with any laparoscopy or minimal access surgery, the benefits of robotic surgery remain the same. For the surgeon, you need lesser massages on your back. You can operate for longer hours, and like some American surgeons said, it adds 10 years to a surgeon's life. I'm not really sure about that yet, but that we can only say with time to come, because I'm just looking at retiring every single day. Well, As far as the differences between the previous robos that were available, the SI robo versus the XI robo, which is currently available. And the reason why I'm speaking here today is because with the advent of the XI, general surgery has now become a norm. So if you look at it, most of the things in terms of core technology remain the same. But where are the technology enhancements? Well, if you look at docking of an XI robo or an X robo is far, far superior. You have a button which kind of docks it, and you don't have to do anything. The machine does everything for you. You just have to press the button on your telescope and everything is done. The next thing is you can access all anatomical parts. So if you have to look at the upper abdomen, you look upper abdomen. If you have to look lower abdomen, you can look lower abdomen without actually undocking your robo. The big problem with robos is when you dock it, you cannot just change and look the other side. So you have to completely undock the robo, which takes 10-15 minutes, and then redock it. With range motion and table motion, now all that is available with the XI. And the most important thing is that the stapling, the sealing, and the suturing is all done by the surgeon himself. You don't need your assistant for anything. So actually, a surgeon can perform the entire surgery with a trained nurse. He does not need any assistant. You don't need a camera assistant, so you can do away with that. Like I said, where all has robotic made entry into orthopedic surgery, like I said, all replacements today are kind of very commonly done with robo-guided mechanisms. Gynec surgeries I'm not going to speak much about because it's been there for a while. Again, urological surgery again has been there for a while. General surgery, well, fundoplications, helicardiomyotomy. The vision is so clear that you actually can see every tiny little vessel deep into the mediastinum, so it becomes that much easier to do. In bariatric surgery, the sleeve gastrectomy is a gastric bypass we can do. In terms of oncological procedures, colorectal surgery, gastrectomies, colectomies, all have become norm. Splenectomies, adrenalectomies, and pancreectomies, even Whipples now is being done. Hepatic transplants are being done robotic. So it's moved a long way. And today, if we were to say that I'm not going to use the robo because it's going to be more expensive, it is going to be more cumbersome to learn the robo, well, it's like talking about the new technology when it rolls in. You either be part of the roller or part of the road. The roller is going to keep moving on. So either adopt the technology today because every new company has moved in. Everyone's moving down the robotic pathway. So if you're talking 5 years later, surgery is going to move that way. So this is how I used to operate laparoscopic. If you see my position, my neck, my body, all were in convoluted positions. And then my assistants, all of varying sizes, used to be there. So you had to adjust depending on how tall one was or how short one was. But look at robotic surgery. This is how I sit, comfortably ensconced without an assistant, without anything, and that's how robotic surgery has moved. So I don't care about who's assisting me at what point of time. Then now I'll tell you the advantages of the XI robo. So I'm going to show you how the sealant moves, right? This is how the instrument docks in. This is how we put it into the arm. Now this is how my hands move. And if you can see, that's how the robo moves inside. I can seal and cut. And if I made a wrong decision and if it's not sealed, the computer kind of tells me that you've not sealed, it will not cut. All right? So it's got that much more precision. That's how it moves inside, and all arm movement. And if you look at this, this is how me doing a gastric bypass. This is how it moves inside. So you seal the vessels very, very easily. There is a noise that comes which tells you when it is completely sealed. So you can never make an inadvertent cut. You will never be able to get bleeding in this kind of a sealant. And if you can see, everything's on your screen. So everything is computer generated. That's how we kind of seal and burn vessels now. And because the arm moves in all directions, which laparoscopic instruments today cannot do, you can enter any kind of space to seal this. This is me doing a gastric bypass. Now this is how stapler moves. Now you look at the range of motion of the stapler, all right? Completely can turn in all directions. Now with conventional staplers, we don't have this range of motions. Even with the motorized staplers, we don't have this range of motion. It can turn 360, it can move up, down, everywhere. And this is it being used in the surgery. Okay, now I need to arrange it, so I will guide it in such a way that it goes down. And just like you would do with conventional laparoscopic surgery, today the robo will tell you, but the advantage with the robotic staplers, which I'll show you in my next slide, is that it calculates at the speed of 1,000 calculations in the computer brain per minute. So it calculates and sees thickness of tissue, whether to cut, whether not to cut, and everything else the robo kind of manages. And then it safely cuts. It tells you what thickness of tissue. Let's say you've taken a blue reload and the tissue is too thin, it will tell you, so you can change to a white reload. If it's too thick, you can change to a black or a green reload. So you can always know what you're doing and what you're not doing, and you can adjust it that way. And then it's a clean cut. You don't see any bleeding or anything of that sort. Now this is, if you see this, this is how a stapler moves inside. That's the white reload. And now you will see how this kind of stapler moves. So if you just keep your mind towards the yellow part, it's calibrating the instrument that I need to put. Then it allows me to go directly to the place where I need to move in. And then it will calculate the thickness of the tissue. Once I've placed it there, it will tell me how much thickness to go in, how much not to go in, once I've reticulated it. Now, once I clamp, I can always unclamp it. I can reclamp it. It gives me a kind of, if you see down, the blue L is for clamping. Once I've clamped it, and then it gives me a sound. And then once I've clamped it, it gives me 3 seconds to fire. I can always stop within 3 seconds. So once I fire, then I leave my hands. Then it stops. There you can see it's pausing for compression. So all the fluid is taken away because of the judgment of the robo as to how it's kind of stapling. And then it moves further. So it's not human derived, it is machine derived thickness of the tissue and taking away the fluid from there. That's how it's unclamped. Now, in terms of range of motions, well, the stapler can move like a human hand, but much, much more. The human hand can only move in certain directions, whereas the robotic stapler can move. Look at this suturing, and this is how we suture. So it becomes so much easier. You can reticulate your arms. That's me completing a gastrojejunostomy. It looks very neat, very clean. You can push tissues. And because your range of motion, so even for those surgeons who are not that gifted with laparoscopic suturing, and we do know it's a difficult art, this becomes very, very easy. So it kind of bridges the gap between very good surgeons and those who are not that gifted in terms of suturing. So now, if a surgeon says he can't do laparoscopic suturing, well, the robo gives him that option of saying, you can do it because this is so much more easier. And it's almost like, because we were deprived from playing enough of video games in our childhood, we can go back to playing these kind of video games in adulthood. Remember that this is all magnified 3D vision that you're seeing through the lens. Today, a lot of hernias, I don't know how many of you all have heard, but a lot of hernias are the new ETEP TAR techniques that we do. And when you have to dissect in the muscular planes, it kind of gives us a great, great option. So with the ETEP and TAR techniques also, robotic suturing has become a very, very good thing to use. You can go backhand, forehand, and suturing becomes that much easier. Now we've got even sutures that kind of stay there, so you don't really need to even take a knot with this kind of technique. I just wanted to keep this on just for you to understand the dexterity with which the stapler moves. And all you're doing is playing with your 2 fingers outside on the console. So you're far removed from the hullabaloo of the operating table and various other things. So you're not fighting with the nurse or your assistant trying to tell him to show. The camera is moved by you, so how far you want to go, how close you want to go is completely controlled by you sitting on the console. Now, another thing, a lot of you would have seen in gallbladders that it's very common to get a CBD injury. And that is not because the surgeon is not skilled or there might be an issue. Some of the newer laparoscopes have got a vision, but you have to inject dye. Now, with the switch of a button in robotics, you can have something called the firefly view. So this is a normal view, if you can see the CBD, and that's the firefly view. All the bile and bile structures get lit up, so it's very difficult to actually go and damage a bile duct in this kind of view. All you have to do is just press that button, you will see the CBD, which lights up in green, so you can actually go and place things very, very difficult. So it's making it more and more difficult for surgeons to make mistakes with the robo. Now, what about the future of robotics? Well, traditional laparoscopy, the surgeon was there with verbal commands. He told the surgeon assistant, idhar dikhao, go close, go far. He had surgical tools which were at his disposal. The tools, of course, have got better with time. And the camera movement was done either by the surgeon, where he gave away one hand, or by his assistant, and therefore every time for someone like me who keeps having fellows to train, it would become difficult if you get a new person who was not really used to laparoscopic surgery, and you have to reteach them how to show the camera. So with the robotic surgery, well, like I said, everything is controlled by you. You don't need an assistant. You can move the camera which way. And what's the future? The future is that when data comes in, and with more and more of these images going and being captured by Da Vinci, there will be autonomous camera coordinated movement. So you won't even have to do that. Everything the machine will kind of do for you. Telesurgery, I don't know how many of you all have heard about the Lindeberg operation. Lindeberg operation was when a gallbladder was operated sitting in Strasbourg in France by a surgeon sitting in America. And that's what's going to happen. As we move, there are challenges and various other things. What's the main utility of the robo? Well, with telesurgery, its ability to overcome the limitations of conventional surgery, which is time and space of where people are, geographical inaccessibility. For example, if you're doing it in the rural area, I can sit in Mumbai and operate someone in rural Maharashtra. It can also help people in various other things. For example, in battlefields where a surgeon has to operate and he himself cannot risk his life being in a battlefield. Or other places like submarines, outposts. With 5G technology coming in, trust me, guys, as soon as the rules come into place properly, in terms of patient data privacy and various other things, you'll have that very, very soon sorted. Then master and slave consoles. Well, you can teach an assistant while sitting there. So your assistant can sit on the slave console and operate. And if you want to take over control, you can actually operate from the next console. So you are not allowing that junior to make any kind of mistakes. This is how I used to teach. This is me teaching in Nair. If you see the number of students around me, around 20, 25 students you see. Now I don't need to go to Nair. If one of my juniors is operating somewhere with this kind of iPad, I can actually tell him, okay, I'll circle a place and say, don't cut there, and I'll tell him, don't. So I don't even have to be physically present to teach someone. And that's what robotic surgery is bringing on the table. I think the way we teach is going to completely change. And then metaverse. We all talk about metaverse. What exactly is metaverse? Well, Intuitive has got into the virtual reality space. And it has tied up with a firm called Iris for augmented reality imaging. So today's sitting, to train people, you can have virtual reality, which can actually teach you. Most new companies, J&J, Medtronic, Stryker, have all partnered with various other things. So how much ever we want it and call it an expensive option or something, it is a technology which is very much here to stay, and the future is only there. Endo-robotics has come in a huge way, and today, sitting on a table, I can actually operate with 2 hands with the Endo-robo, and I think in the next 5 years, you'll probably see notes or nose scar technique actually coming in, and people operating through stomachs and colons. So data and machine learning, whoever's interested in that, we do know that with more and more data coming in, machine learning tools will get better and better, and that will kind of help in the AI that we eventually get in all these processes. Once they are AI-driven processes, well, then sky's the limit, because to me, we move from freehand surgery to minimal invasive surgery, from minimal invasive to robotic assisted surgery, eventually is surgery with full automation. Will that ever be a reality? Well, right now I don't know, but maybe 10 years later I'll look like an old man when I'm talking about robotic and minimal access surgery, when a machine is sitting and doing everything. Well, thank you so much for patient listening.
Thank you, Dr. Lakdawala, for this lucid presentation from history to future of robotics. I think we are obliged to you to giving us this knowledge. Thank you very much.
I request the chairpersons to felicitate Dr. Lakdawala.
I request Dr. Usha Shah to felicitate our chairperson, Dr. Anila Awad and Dr. Vijay Punjabi sir. Sir, you be in the dais. Dr. Punjabi sir.
Arvind Patel.
The winner of the first lucky draw is Dr. Arvind Patel. Is Dr. Arvind Patel here? The second winner is Dr. Yogesh Shah.
Friends, our next speaker is Dr. Rashmi Saraf. She is going to speak on brain attack. What next? To chair the session, I request Dr. Suresh Doshi and Dr. Sudhir Patel to come on the dais. Dr. Suresh Doshi, Dr. Sudhir Patel.
Good evening, everybody. I have a proud privilege to introduce Dr. Rashmi Sharaf. Dr. Rashmi Sharaf is the head of Department of the Interventional Neuroradiology at KEM Hospital and visiting consultant interventional neuroradiologist at SL Raheja, that is Fortis and Wokhart hospitals. She has done MD and DNB in radiology. She is recipient of several gold medals for academic excellence from Banaras Hindu University. She has done observationship in interventional neuroradiology at St. Lucas Hospital, Houston University, USA. She got fellowship training at the prestigious Department of Interventional Neuroradiology, KEM Hospital, Mumbai. And today, she will speak on brain attack. What next?
Thank you very much. Thanks for inviting me today here for the conference and to speak on brain attack. So we have heard this word heart attack so many times, but we have not heard about brain attack. So I want to talk about it today so that it creates an impression on the minds of most of you here when you leave from here that there is something called brain attack, and it's really important that we diagnose it and we treat it on time. So before coming on to the treatment of brain attack, I would just quickly throw some light on
what we do for the treatment and what is our route to treat such patients with brain attack. So I'm an interventional neuroradiologist. I also call it as a minimally invasive surgery or a neurointerventional surgery. So basically, instead of opening the brain, we go from the arteries of the groin here all the way up. Instead of going to the heart, we take our catheters up into the small, fine arteries of the brain, and then we do all our surgeries from there. So it is basically a minimally invasive surgery, and to do these kind of surgeries, we need a high-end cath lab. We should have a DSA, and to do high-end surgeries, we should have something which new softwares within the system like 3Ds or CT scans, which is there in most of the places where I work. So the disease spectrum that we treat through neurointerventional surgery is the most important part of our work is about brain aneurysms and acute stroke therapies, cerebral venous thrombosis, AVMs, intracranial atherosclerosis, and the list just goes on. Basically, all vascular diseases of the brain and spine and paraspinal region and head and neck. So with this background, I will come to this topic today about stroke. So brain attack or stroke is an acute event, though it is very silent because patient doesn't have any pain. Patient just complains of painless weakness of one side of the body, and that is what it's a stroke, but it is painless, so it's silent. So it's our duty to identify it at the right time and treat it. So stroke is any acute neurodeficit that we are going to diagnose and go ahead for the treatment. So just before I move ahead, what is TIA? So to avoid confusion here, all of us should know that there is nothing like TIA in today's scenario. It was a terminology which was used long ago when they used to wait for 24 hours. If symptoms reversed in 24 hours, it was called TIA, transient ischemic attack. Today, every neurological symptom is a stroke. Treat it urgently, diagnose it urgently, and we go ahead. If it reverses, nothing like it. If it does not reverse, we will give the treatment to reverse it if possible. So there are two types of stroke, ischemic and hemorrhagic. Most of us know about it. 80% is ischemic, only 20% is hemorrhagic, but hemorrhagic comes with a bolt. There is headache, there is sudden onset, loss of consciousness, and everyone comes to know about it. Ischemic is so silent, patient just has some, even doctors, we have cases, we have seen a dentist working in the OPD, had some mild slurring and mild weakness. He thought, oh, it must be stress, I have not slept whole night. And after ignoring his symptoms for 4 hours, he came to Wockhardt Hospital when we realized that this is a stroke, and we gave him IV TPA and he improved. So there are symptoms which are mild. Even as doctors, we ignore it. So we have to educate people around us so that we know that these are serious symptoms and they need serious treatment. So today my focus of the talk would be about the hyperacute stroke. That is the stroke which happens and patient presents to us within the golden window period. So I'll talk about the golden window period. So why stroke matters? Because stroke incidence is increasing in our society, even in our Indian society today. Previously, maybe say 10 years down the line, it was not an important cause of disability or death in our system. Today, it is very, very rapidly becoming the second largest cause of morbidity and mortality. 1 in 4 people over the age of 25 will have a stroke in their lifetime. This is the data taken out by the World Stroke Society. And so many people, close to 40,000 people, suffer a stroke in a day. So it's a serious issue. If we have so many people debilitated, we will have a society which will be grossly affected by stroke. So we need to work on it. We need to diagnose, treat, and prevent them. So before continuing on my lecture, I always keep this picture. This is, I think many of you would be knowing him. He's a very, very senior, renowned orthopedician and spine surgeon, Dr. Larry Sir. Because he reached, I say to him that you are our stroke ambassador. He reached in time to hospital. We could do thrombectomy for him, and he's perfectly fine today because he received treatment on time. So with this picture, with this in mind, I would like to say, even as doctors, we have to be very, very careful that we get treated on time. So coming on to the symptoms of stroke or paralysis, it is, most of us know the symptoms, but I would just reiterate here, sudden onset numbness or weakness on any part of the body, that is face, arm, leg, usually one half, but even monoparesis could be there. Drooping of the face or the angle of mouth, drooling of saliva on one side, trouble walking, loss of balance, blurring of vision, double vision is also a sign of stroke. We always consider loss of vision, but even double vision is a sign of posterior circulation stroke. Dizziness, vertigo, difficulty in speaking, difficulty in understanding what others are saying is also a type of stroke, which we miss many a times and should not be leading to confusion. We should image them quickly. Sometimes headache can also be one of the manifestations, especially when there is a dissection of the carotid. So just to remind you again, eye problems, limb weakness, difficulty in speaking or also understanding what others are saying, it's a time to make a phone call. So be fast. As doctors, we have to remember this mnemonic. It is very important. Be fast. Whenever you see a patient with stroke, please be fast and immediately refer the patient to a place where the treatment for the stroke patient is available. So time is brain. This is the key to everything in stroke or acute ischemic stroke. This is the logo of the stroke campaign of 2021, that minutes can save lives. I'll show you cases how minutes can save lives. So learn the signs, say it's a stroke, and quickly refer the patient to a stroke-ready hospital. That is how we can reverse the symptoms of stroke. So coming on to the treatment of stroke, before that, I'll quickly take 3-4 slides through the history of the treatment of stroke. So in 80s, many of you are very senior physicians here, and you would be knowing that there was nothing except aspirin about stroke. So patient has a stroke, patient is on a cot in the house, and we go and see and give aspirin. That was the only treatment. But over time, our minds are intuitive. We keep on thinking of something more, and this came the concept of penumbra. This gray area that you see around the dark area is the penumbra, and this is when any artery of the brain is blocked. This is the area which is salvageable. So if the patient comes within the window period, this area, the black area, is the area which is definitely the dead area, but the light gray area around it is the area which is salvageable. So all our therapies are targeted towards reviving that light gray area. So if you give the treatment on time, that will become a normal brain parenchyma. If you don't treat them, this will become dark black over 6 to 8 hours. All of it will become dark black. So aim is to reduce the size of core and reverse the brain whatever is possible. So on that direction, the work started in the late 90s, and IV-TPA was started. Slowly, within 3 hours, then its time period expanded, and at the same time, there was work on endovascular treatment when people started going intra-arterially, and the same TPA was given locally within the clot. So that saved the amount of dose going in humans' bodies, so reduced the risk related to it, that is hemorrhage. So we kept on working, and there were few landmark years, that is 2014 to 2018, where multiple studies were performed about the use of stents in the brain to pull the clots out of the brain, that is stent retriever techniques. Multiple studies were there, mainly using the penumbra device, the solitaire. Some were also using penumbra and Mercy devices. And with this, in 2015, a clear guideline came, and we only revise on that guideline every year till now. And in 2015, they were clearly mentioning that endovascular therapy has class 1 level of evidence A, that patient can undergo mechanical thrombectomy, that is pulling of the clots from the brain right from the onset of the symptoms. Before that, it could be done only after 3 hours by recommendation. Only after trying IV-TPA or patient present after 3 hours, you can do clot lysis. But with clot retrievers, we can treat them right from the onset of the symptoms if there is a large vessel occlusion. This was a big breakthrough, and this has changed the the scenario in the whole world. Now, acute stroke therapy has become the leading thing in neurointervention because we can reverse the symptoms. The faster we treat them, the better is the neurological outcome. We don't stop here, we keep on working, and now we say that window period is not just 6 hours, it's 24 hours. But again, to repeat for most of you, the golden window period is still 6 hours because the best chance of recovery is in the first 6 hours. But for selected patients, even up till 16 to 24 hours, we can open the artery and we can reverse the symptoms. So up till 24 hours, we should try and refer the patients to a hospital where treatment can be done. After 6 hours, we do imaging and we select the patients who are suitable for endovascular treatment. It's not for all the patients, but yes, we can open the arteries up till 24 hours. So revised guidelines today clearly say that up till 24 hours, the arteries of the brain can be opened. So if you see in 2022, so many things, it's a cluttered slide, but to simplify, if you reach the hospital within window period, we can do thrombectomy if there is a large vessel occlusion, or we can do TPA for almost all the patients if they come within 4.5 hours. So we have the technology, we only need the patients in the right time. So the golden window period is 6 hours, though it can be reversed in selected cases up to 24 hours. So with this background about the history of treatment of stroke, I move to when we diagnose stroke, what do we do next? So as the first physician or the first treating doctor, we should stabilize the patient, look at the blood pressure, don't reduce the blood pressure significantly. We need higher blood pressure to perfuse the brain. Only if it is above 180 or 200, you give something to bring it down. Don't try to bring it normal because that will aggravate the symptoms of stroke and make it even worse. The blood pressure is a reflex mechanism to increase the perfusion of the brain distal to the occluded artery through collaterals. Sugars, if they are high, they need to be controlled. But the priority should be to diagnose the stroke and do the imaging. If you are at a place where a patient cannot go to a stroke-ready hospital, you are shifting to a diagnostic center, please call up the diagnostic center and inform that a stroke patient is coming. Please take it as a priority, and they should not lose the golden time sitting outside in the diagnostic center. So this is a very important thing I would suggest, but if you are referring to a hospital where there is stroke treatment available, let the CT MRI be done there only, because we have more facilities and we can see it ourselves and quickly shift the patient to cath lab if needed. To give or not aspirin is a dubious thing, preferably not to give till a CT scan is done because we have not seen whether there is a bleed or not. So when to refer? Signs and symptoms suggestive of stroke, which we have already discussed. Duration within your 12 to 24 hours, especially first 6 hours are very, very important. We should refer to a stroke-ready hospital able to give TPA and do endovascular treatment. So what is a stroke-ready hospital? These are the two important hospitals where I work. So it should have a casualty with a trained staff and casualty in charge, confirm that it's stroke, and they assess the NIHS score. We have a code wide, they activate, they inform us, and we are all ready by the time patient is sent to CT or MRI. Adjacent imaging facilities, CT and MRI should be next to each other and close to casualty. Neurologists and neurointerventionists should be on board. Facility to give IV TPA should be available. Equipped cath lab for endovascular mechanical thrombectomy and rehabilitation services. So this is a Wokhart cath lab. This is just today's morning we had a case. So we have a CT scan in our cath lab. We have a 3D in our cath lab. And it's a very high-end machine that we have. We have a big screen, a big FD detector, which allows us to analyze the whole case in detail and perform the CT scan on table if needed. So steps followed in a stroke-ready hospital. We diagnose the stroke, it's in window period, we do imaging, IV TPA, large vessel occlusion, shift to DSA lab, mechanical thrombectomy, ICU recovery, and rehab. So now I'll show you a few cases of endovascular treatment that we do for these occluded arteries of the brain. So just before going to actual cases, I'll just quickly show you. These are the normal angiograms that we have. So this is the normal carotid artery. This is the internal carotid artery going into the brain. And these are the arteries of the brain. So these MCA, ACA, and intracranial ICA is anterior circulation. And this basilar is the posterior circulation. So this is the angio that we look at in the anterior circulation and posterior circulation. A word here to add, posterior circulation strokes, they give us little larger window period, 24 to 48 hours, so we have more time to open the artery. We should, because they get little late to diagnose, so we have an opportunity to open them and give them a better life. So we do MRI, we can refer even up till 48 hours for posterior circulation stroke. So to start with the intraarterial therapy, we used to use these fibrinolytic agents, that is urokinase and TPA. This was, I would say now, more or less like a history. We don't use them now. This is one of my first case in fellowship days, almost 15 years back. So this patient had a stroke, young lady came. You can see that big artery on the left hemisphere is missing. We take our catheter, we go there, inject, actylize, and the artery is open. It was very easy, but there was risk of hemorrhagic transformation because you are injecting chemical into it. So gradually there came devices where we could pull out the clot. This was the Penumbra device which was first launched, and we were the first to use them in India. And this patient had a posterior circulation stroke in hospital. She was on pacemaker, admitted in the cardiac ward. We shifted her immediately. You can see this basilar artery is occluded. This device had just come. This is the first generation of Penumbra device. And you can see a catheter is here, and there was a separator would macerate the clot, and at the same time there was a suction pump outside. We would suck the clot. And the artery is open. And for the first time, we had the clot in our hand. Like a surgeon doing embolectomy, the clot was in our hand. So this gave a lot of enthusiasm to pull out the clots from the brain. And there's no look back from here. We had more and more devices. Then came the stent retrievers. There were stents which would trap the clot, and we would pull the stent out. I will show you how we do it. This is all we have already talked about. So we use this aspi retriever technique now. We take an aspiration catheter, and through that we take a retriever. So while retrieving the stent, we also aspirate, and this increases the rate of recanalization and decreased complications. So I'll show you how we actually do it. So you can see there is a clot moving up in the brain. So it's an animation. So we see this clot is going up in the brain. And you can see it goes up and it blocks the arteries of the brain. On angiogram, there is complete cutoff of the MCA here. So we take the stents, which are special devices. This is our catheter and wire. We are crossing the clot. We take our catheter and we deploy the stent through it. I will show you the actual cases also after this. So you see how we have deployed the stent. It is cutting through the clot and engaging the clot in its struts. You can see how it is cutting and engaging the clot. And we allow the brain to get some blood flow in this period. And then we pull out the clot. So before pulling out the clot from the brain, this is the neck area. We inflate a balloon here in the neck so that while we are pulling out the clot, it should not fragment and go into the brain. Even if it fragments, everything comes in the suction. So while the balloon is inflated, outside we are doing the suction and we remove it, and artery is opened and blood flow is restored. This is the concept of stent retriever, and which is the thing that we are using today along with the aspiration catheter. I will show you the catheter here next. So coming on to a case, she is a young lady, pregnant, almost 7 weeks, and she had a stroke in the hospital while doing balloon mitral valvuloplasty, and we quickly shifted her. We did the MRI. You can see very early subtle changes developing in the brain. So we took her quickly to the cath lab. We saw that the MCA was cut off. Big chunk had gone from the heart to the brain. And this is how you can see we took our catheter head, wire is going, catheter is following it. We remove the wire, and we can see these markers are the markers of the stent here. So we deploy the stent, and we allow the blood to perfuse. You can see that fuzziness here is the area where clot is there. We pull the stent out, and as we pull out, so here you can see this is after pulling out the clot, there is the artery has fully opened up. It was occluded here, and it has fully opened up after removing the clot. She became perfectly normal. On table itself, she started moving her limbs, and in 2 days, she was walking in the ward, and she had a normal delivery in the hospital. So this was NIHS at presentation. Any NIHS above 10 is a severe stroke, and it has significant disability. She had 21 at 24 hours, it dropped to 4, and at 15 days it was 1. And we repeat the imaging next day, we see that all the arteries are filling normally. So this is the beauty of treating them on time and giving them a good quality of life. So this is another patient, young male. These were the first 2 cases of solitaire. Actually, I would say they were the first cases of solitaire in India, or first cases of recent river in India around 2009 or something. A young boy having MCA occlusion. This red area that you see is the big area of the brain at risk. So we go inside, we open the artery, and you can see artery is open. Patient recovered, and look at it. We do the perfusion imaging, it's a normal perfusion. If we would not have opened this artery, this whole area would have infarcted. So it is very, very important that we diagnose it, and I'll just finish in 5 minutes. So then came penumbra technology with newer catheters which could be taken into the brain. This is a policeman, came after IVTPA. You can see there's a catheter which has come right here, which is very visible here, which aspirates the clot and artery opens up. Look at the clot, it has come from the artery, and it's exactly matching the trunks from where it has come. He became perfectly normal, and he's back to work. Another guy, this patient deteriorated right in front of our eyes. He came to hospital, he was still talking, but little bit slurring was there, and in front of us, he became unconscious. Young guy with some cardiac problem. You can see that there is a stroke in the cerebellum, and there is something here sitting on the basilar top. They become unresponsive very quickly, and look at it, only one small thrombus here, and patient is bad. Within 5 minutes, we were able to reach there and remove the clot, and the arteries become normal. This patient, who was unconscious just 5 minutes back, was moving his limbs, and to my surprise, I was just asking the anesthetist, in hurry, I forgot the name of the patient. I said, what's the name? I would see how is he. From behind, he was only calling out his name and telling, this is my name. So this is the beauty of doing or treating them on time. So this is another patient. This is MCA occlusion here. Patient had a big area of deficit. We went inside, gave the risk to the relatives.
Madam, time is over.
Sorry? Yeah, I'll just finish to the conclusion. These are last 2 cases. So we opened the artery, and you can see the artery has fully opened up with one pass, and this is no one other than Sir. We opened the artery, it was a big clot there. And the last case today, which I'm going to show, it's just yesterday, we got a call, a young lady came in the unconscious state, and we see that there is a small infarct. We quickly went inside. Within 15 minutes, we opened the artery. And this is the technology of stent retriever, which helps you to open and get the clot on the stent here, which comes out immediately. And immediately on table, she started moving her limbs. Within 15 minutes, the artery was opened up. So the important message here to give is, just medical therapy doesn't work. We have to think about mechanical thrombectomy if there is a large vessel occlusion and if there is a salvageable brain there. We have goals to fulfill. This is just a testimonial. I'll go ahead from here. So to conclude, acute stroke is an emergency. We need to act fast. Appropriate imaging, including MR angio, CT angio, or DSA, has to be chosen to give the right treatment. Select the patients appropriately. The faster we recanalize the artery, the better is the outcome. And the bottom line is, it's a team effort which starts from diagnosing at your level to treating at our level. Thank you so much.
Dr. Rashmi Saraf, ma'am, thanks a lot for a very informative lecture.
Thank you very much.
I request our chairperson
Dr. Sudhir Patil and Dr. Suresh Doshi to felicitate our esteemed speaker, Dr. Rashmi Saraf.
The first winner of the lucky draw is Dr. Aspi Mehta. Dr. Aspi Mehta is there. The second one is Dr. Indira Sahajwala. Dr. Indira Sahajwala. Here, madam. Here, madam.
Thank you all. Our next speaker is Dr. Kapil Salgia. He will be talking on antimicrobial resistance and COVID. To introduce him, myself, Dr. Pragji Vaja and Dr. Rajendra. Friends, sorry, there is a little correction. Our next speaker is, our esteemed speaker is Dr. Anil Boroskar. Can we do something more for our diabetic patient? And to chair the session, I request Dr. Kavan Lakdawala and Dr. Jagdish Kenny to come on the dais.
Thank you. Thank you. Thank you, respected Chair and the people for allowing me and Dr. Salgia to come in between. Now, the reason why I was slightly impatient giving my talk, that what I was seeing in the previous presentation, a sequence of the future and the dream sequences. Every single speaker have given us a fantastic survey of the dishes. Like I would give one example that the previous speakers brought you kebab and biryanis and salads. Name the dishes that are palatable and good. Amongst them, I was feeling shy because मी काय आणले आहे ते सुदाम्याचे पोहे आहेत. It's the simplest homemade recipe for all of you. So therefore, without wasting much time, where is this? Yeah, okay. Now, the global picture of diabetes is not very encouraging. We have, in India, is a diabetic capital of the world. Nothing to be proud of. Sheerly, because of our population, we are more than 70 million diabetics. You will realize the evolution of the epidemic from the hunter and gatherer of the people who are energy expenders. We have become sedentary couch potatoes and energy conservative people. There is an epidemic of affluenza, not influenza, affluenza. And the only way to change it is to change the lifestyle. ICMR, India Diabetes Factors of Diabetes, has come out: age, male sex, urban sedentary, abdominal obesity, the biggest culprit. We are all called as the thin fat Indians. What is the thin fat Indians? Our BMI is about 20, but our waist circumference is 90 centimeters. All our fat tends to be visceral and that is the biggest risk factor. And unless you change that, we are not going to curtail the epidemic of diabetes, heart disease, and even cancers. All these gadgets, what I saw this young lady showing, put it here, put it there, will not need it if you change your lifestyle from the age of 30. Modi ji says this country is a great country because 65% of our population is below the age of 35. Can you imagine this? But what is the idea of having this population suffering from all these diseases and needing stents and this kind of gadgets, and their 50% of income and life is lost in invasive techniques? I have got nothing against these invasive techniques, but the very fact that we can prevent it, and we have done that in many studies. So that is what we have to offer. ICMR India Diet has given us the prevalence of diabetes in urban and rural population in the 4 regional studies: Maharashtra, Tamil Nadu, Jharkhand, and Chandigarh. You'll see that the urban population suffers more. Prevalence of hypertension. I always tell people, if the HbA1c is 7.5 and the systolic pressure is 145, run after this systolic pressure. It's a bigger risk factor. Systolic hypertension is a bigger risk factor, and that is what we have to offer our diabetics. This is, we can control. People don't take hypertension seriously. They take it very lightly. You have to aim at controlling it. India is a home of second largest number of adults living with diabetes worldwide. 69.2 million. And the effects of diabetes are multiple. You all know more than 1 lakh deaths, more than 1157 years of the life lost, and 2,300 disability adjusted life year. It's the greatest cause of disability. It's the greatest cause of man-hour lost, and it is preventable. Approach to the management of hyperglycemia. Patient diabetes feature risk of hypoglycemia, drug adverse effects, disease duration, life expectancy. These are all things matter in our country. Now, prevention of complications of diabetes. This is what we should all aim at, and this is what the patients expect from us. Distinctive features of type 2 diabetes in India. First is genetically we are susceptible. Indians particularly, they are not only screwed up here, they are screwed up everywhere. Particularly if you see our coronary arteries, they are distal segment, long segments, tortuous, and as a rule, Indian coronary arteries have smaller diameters. They get atherosclerotic at a at a 30-35 age. Now this is a genetic. You can't control your genes. But the point is, environmental factors can be certainly controlled. You'll realize that main challenges posed in type 2 diabetes, and this is what all of you should offer. Rising prevalence in urban and also in the rural areas. High prevalence in prediabetes. Now what are the prediabetes? Impaired glucose tolerance, hypertension, gestational diabetes. This is all pre-diabetic. After 5 years, they are going to develop diabetes. Genetic and environmental risk factors, delayed diagnosis. In our country, we diagnose diabetes a decade later. That is the most dangerous thing. And those time when you diagnose diabetes, he already has one complication, at least one microangiopathy, at least something in the nerves. So delay in diagnosis, low disease awareness among public, and a very light-handed approach, which is to be given up. People take it very lightly. Suboptimal diabetic control, limited healthcare and cost disease management, the priority of a household expenses are lowest in terms of prevention. In India, all of us act on the acute care basis. I'll give you one example. People on a replacement therapy for kidney, we have a problem of almost spending 18,000 rupees per month, while a prevention of kidney disease can be achieved by only 180 rupees per month. These are the benefits of your prevention in terms of cost effectiveness. People don't realize that. This is what we have to offer. The rule of 2/3 in diabetes, of dysglycemia and pre-diabetic, of 2/3 of a pre-diabetes convert to diabetes, 2/3 of PWD do not achieve targets, 2/3 of PWD have a dyslipidemia which is not diagnosed, and that is what we have to offer to our patients. We have to chase the lipids, we have to chase the non-HDL cholesterol, we have to hit the triglycerides. Now, A1C complications further deteriorated glycemic control in type 2 diabetes, worsened the retinopathy, and today what we are seeing, there is something known as cardio-renal metabolic syndrome at the age of 35 and 40. We see the kidney, which are seen typically in type 1 diabetic with a microangiopathy. We get a knocked off kidney at the age of 45 in a type 2 diabetes, which is a very big burden on society and hospitals. So this is what glycemic control is poor amongst Indians despite of availability of all the major class of drugs. In the big challenge to have our patients achieve their targets. It's a big challenge. Patients don't achieve the target. They don't monitor. They take it very lightly. Addressing clinical inertia in diabetics key prevent complications of clinical inertia. The goals for management are well defined. Effective therapies are widely available. Despite such advances, healthcare providers often do not initiate the aggressive treatment. That means all of us are responsible. Many patients, when they come to you, they show you a report of 200 fasting and 250%. Don't worry, shakkar mat khao, patala mat khao, thoda idhar udhar kasrat karo, and you will be all right. Because the GP has got 200 patients waiting. He has no time for counseling. I always tell my GP friends that all your diabetics you call on one day, spend a lot of time. Do a complete physical examination. Today what has happened, my young students who are passing MD and DM, they are looking only at the papers. They look at the images. They look at the report and write the treatment. The clinical examination is gone. They don't know how to check the pulse rate. They don't see the systolic and diastolic blood pressure. Now this has to be stopped. Despite such advances, healthcare providers often do not initiate intensified treatment. We define such behavior as a clinical inertia, and that is what we have to offer. For doctors' clinical inertia, there is a guideline G recommending prescription. Doctor is aware of existence of guideline G. The doctor has a resource to prescribe it. Doctors do not practice X to the patient P. This is wrong. And that is the reason why we have to study the patient profile, study the patient's habits, study the patient's character, understand his personality, understand his other issues which deserve the priority. Now, overview of most least daily understood by the patient. Lifestyle management, if you try to check and ask the patient to change, 90% he will change the doctor. 90% you tell him, हे खायचं नाही, हे खायचं नाही, हे नाही, हे करा, ते करा. आम्हाला डॉक्टरच नको. स्वतःला फार शहाणे समजतात. Physicians and patients recall explanation of risk of diagnosis. Now cardiovascular risk, maximum, and there is a saying in Urdu, मरता क्या नहीं करता. एक बार हार्ट का नाम निकाला, other is a cancer. These two conditions, if you tell the patient, they are prepared to do anything. I know it because I'm a chief physician of a cancer hospital and also a diabetologist of Asian Heart. I know how serious people are when they come to these two hospitals. Raheja Hospital is a primary diabetes hospital where the patients are extremely casual. Their main warning signals come when they develop or family member develop some coronary event. And before that they develop, we have to say that the complications are the most devastating for you and your family. Now, what is the conclusion? The principal finding of this survey suggests that impairments in communication are the heart of clinical inertia. Just impairment of your communication skills. Now, communication skills develop over a period of time. The control on the language and control of ability to convince, or in short, people will always talk, patient ko patane ka kaisa? Patane ko means not to go to a good consultant and take some money, not that. But the point is, patane ko to say कि ये खाओ नहीं, ये खाओ और ऐसा जिंदगी जियो तो ही तुम्हारा भला होने वाला है. So, patient-centered collaborative care, diabetes and quality of life. This is the worst disease which affects quality of life of not only of diabetic patient but his family members also. And today we talk about quality of life quite a lot. You'll realize diabetes influences patients' lives. Mere presence of diabetes deteriorates the person's quality of life. The idea that he has got a diabetes, you have to see that the quality of life does not change. Healthy lifestyle to achieve a better quality of life in diabetes. How healthy is life it is today? Look at these two idiots. One fellow is sitting in front of a TV and other fellow look at the smile on his face for eating that deadly bomb of calories and fats is the burger. You know, people have been killed by these burgers and fast food. That has to stop, and that is wrong diets in practice. After giving a lecture with absolutely heart and sweat, which is my mission against fast food, two people came out. Doctor, ये slide जो बताया वो किधर मिलता है खाने को? म्हणजे गाढवा समोर वाचली गीता कालचा गोंधळ. Obesity amongst the Indian children. Now this is again a big issue. Very big issue. Because I practice in Hindu colony from King George School, I got 23 young children below the age of 16 whose abdominal girth is more than 110 centimeters. Babaya, आमचा एकुलता एक, both husband and wife working, feeling guilty. So money is given to eat afternoon food. No poli bhaji, they don't know what is home food. They only know fast food, and it is a major killer of the country. Medical nutrition therapy is the thing. Goals of medical nutrition therapy for adults with diabetes to promote and support healthy body. You should not deprive them of antioxidants, nutrition, proteins. We should optimize the diet and not starve them. So RSSDI clinical practice guideline, nutrition and diet therapy remains the integral part of diabetes. There is no one size fits all. Every diabetes is an individual. Treat individually. And diabetes affecting quality of life, burden of type 2 diabetes has to be reduced. So economic impact of diabetes, the cost is enormous and the cost of illness is still bigger. So diabetes trend in India, there is a currently global epidemic of diabetes. The same trends are seen in India. Lifestyle is the most important thing, and that is all we have to. What is the take-home message? Diabetes is widely prevalent epidemic, steadily increasing. There has been a rapid nutritional transition resulting excessive consumption of calories and simple sugar, which have led to increased obesity and related disease. The main step of prevention of treatment is lifestyle modification, which includes diet, exercise, and behavioral modification. And adherence to diet and exercise guidelines would be help in effective weight loss in the best way of control. I had suggested to the Education Ministry and Fadnavis in the past that include nutritional therapy as a chapter in the syllabus of school. I have seen if you give marks to something very important, people study it seriously, and the children who are well taught on nutrition are the ambassadors going to each house. But this was being considered, and then the government changed. But Fadnavis did one good thing, that he prevented all the fast food restaurants next to the schools. That is a very important step. But nutrition has to be taught to all children and their parents, and that is the take-home message to all of you. Thank you very much for giving me a patient hearing.
Thank you, sir.
Before time, did I finish?
Sir, thank you very much for in very much time, Thank you, thank you. I request our chairperson, Dr. Kavan Lakdawala and Jagdish Khani to felicitate our esteemed speaker, Dr. Anil Boraskar, sir.
Coupon number 235. Namne.
I also request Dr. Usha sir to
235.
felicitate our chairperson.
And second is 230. Anybody? No name. Dr. Ramesh Parmani. Dr. Varun Pandey. Dr. DB.
Our next speaker is Dr. Kapil Salgia.
Dr. DB Dhawan.
Our next speaker is Dr. Kapil Salgia. He will speak on the topic antimicrobial resistance and COVID. I invite Dr.
Dr.
Parag Vaja
Shobha.
and Dr. Rajendra Trivedi on the dais to chair this session. Dr.
Dr.
Parag
Shobha Kaplati.
is the co-chairperson of the Stage Management Committee. And Dr. Rajendra Trivedi is the past president of IMA Mumbai branch, past vice president of IMA Maharashtra State, and chairperson of the Souvenir Committee. I request Dr. Vaja to introduce our esteemed speaker, Dr. Kapil Salgia.
Dr. Kapil Salgia is an eminent chest physician, intensivist and bronchoscopist and consultant for sleep disorders at Bombay Hospital and Medical Research Center. Sir is an alumnus of Grant Medical College, Jeja Hospital. He was a lecturer in the Department of Respiratory Disease at State JS Medical College, KM Hospital. Sir has an experience of over 10 years in clinical practice and in the treatment of asthma, COPD, interstitial lung diseases, MDR and XDR TB, allergies, sleep apnea and many other lung disorders. Sir is actively involved in research in the field of clinical and polysomnographic correlation of obesity with obstructive sleep apnea, hypnopnea syndrome, and the incidence of silicosis in flour mill workers. He has many publications in various journals. Today, sir is going to enlighten us on antimicrobial resistance and COVID. Now, over to sir.
Good evening, everyone, and thank you for inviting me over for this talk today. It's a great experience to be able to do that after almost 2 years, meeting everyone, seeing everyone. So, my topic is about COVID and antimicrobial resistance. So the past 2 years have been only about COVID all the time. And what we realized in this past 2 years, and we have been realizing in our clinical practice as well, that antimicrobial resistance is the biggest challenge that we face in our clinical practice. This antimicrobial resistance is faced by y'all in your clinical OPD practice, where patients who were earlier responding to basic antibiotics now no more respond. Very commonly seen with urinary tract infections, where they are resistant to almost all oral antibiotics. also seen in respiratory tract infections. And in our ICU setups, the antibiotics have gone up from cefoperazone, sulbactam, piperacillin, tazobactam to carbapenems. Now we are using polymyxin, colistin, and we are also getting resistance to the same. So antimicrobial resistance remains a very big issue for all of us as clinicians, and we have to be very careful about the use of antibiotics and prevent further increase in this resistance. So, as per the WHO fact sheet, antimicrobial resistance is rising to a dangerously high levels, and the bugs have their own mechanism to outsmart us and become resistant to basic antibiotics. It is much more commoner in countries like India, where antibiotics can be bought over the counter. You can walk into any pharmacy, tell your symptoms, the chemist himself becomes a doctor and gives you a drug for the same. Also, without standard treatment guidelines, especially regarding the dosages and the duration of therapy, antibiotics are often overused and abused. So, we are leading gradually to an era where again, we may lose our lives to minor infections or a small wound because most of the bugs are going to be resistant to the antibiotics that are available to us. As Dr. Boraskar also spoke about diabetes, there is a lot of talk about strokes, but what we are seeing is by the year 2050, antimicrobial resistance is going to be the leading cause of death across the world. Even combined cancer, diabetes and other lifestyle disorders, AMR is going to be one of the leading cause of deaths all across, especially in the Asian, the Russian subcontinent and Africas. So what happened? In the year 2019, December, COVID was first found in China. The number of cases went on increasing, and by March 2020, it became a global pandemic. All of us were confused about how to treat it. It was a viral infection. We treated it with all supportive care. No one knew. Everyone came out with a different guideline. Everyone tried their own experience. So there was introduction of drugs like azithromycin, hydroxychloroquine, ivermectin for treatment of COVID infection. Over the period of few months, we realized there was an inflammatory response going on, and we started using steroids. No one knew how much of steroids to use, so patients were given a high dose of steroids. Then came the use of drugs such as favipiravir, remdesivir, tocilizumab in a few group of patients. And then with this, as the COVID pandemic went on spreading, the number of cases, of severe cases that got admitted increased. A lot of patients got better of COVID, but they developed secondary infections. That was due to the steroids, the use of tocilizumab. All these things gave rise to secondary infections, secondary bacterial infections and sepsis. And I would not be wrong to say that patients who recovered from COVID infections died later due to secondary complications of steroids, tocilizumab, and hospital-acquired or ventilator-associated infections. And most responsible for that was the high level of antimicrobial resistance that we saw in our ICUs. So, what are the steps that we need to take when we are basically treating patients using antibiotics? So first important, identify what is the infection. If it's a viral infection, do not use an antibiotic. Use antibiotics only to treat a bacterial infection. Assess the severity of the disease, know the diagnosis, you're treating a respiratory tract infection, urinary tract infection, or gastrointestinal tract infection, and use the appropriate antibiotic. The aim of antibiotic therapy should be to eradicate the bacteria rather than reducing the bacterial load. So the right dose of drug for the prescribed period of time. Know your local prevalence of the bugs and their resistance. Very commonly, we can do it in the ICUs where we see our patients. But if you have a group of patients like chronic lung diseases like asthma, COPD, ILD, bronchiectasis, who get recurrent infective exacerbations, try to get a sputum culture done once in a while during their exacerbation to see what is the bug and give an antibiotic appropriately. Also, you need to cycle your antibiotics. You can't be treating the patient every time with the same antibiotic. So if it's a amoxiclav at one time, next time it could be a quinolone. So you have to keep on cycling your antibiotics, especially in patients with chronic lung disorders. Understand the pharmacokinetics and pharmacodynamics of the drugs that you are treating with. Very commonly we see drugs such as amoxicillin, clavulanic acid given in BD dosages where ideally they are recommended in 3 times a day. Levofloxacin ideally needs to be given as a single dose, sometimes we give it 2 times in a day. So all those things need to be taken care of. Azithromycin per se is a drug to be given once in a day because of its high, long half-life. So all that needs to be considered during the patients. When you're giving the antibiotic, be aware of the cost, the quality of the drug that you are giving, and the cost effectiveness of the entire therapy. Patient compliance. Even in doctors, we are the worst compliant with our antibiotic therapy. The moment we start feeling better, in the next 2 to 3 days, we start reducing our doses of drugs, we stop our antibiotics. And that is the perfect recipe for a disaster. So ideally, if you are giving an antibiotic, give it for the ideal prescribed duration of time and ensure that the patients comply with that. Sometimes we may need to prescribe antibiotics empirically, but do it judiciously and intelligently. So what we need to know is COVID-19 is a COVID-19 is a viral infection, and yet widespread and high levels of antibiotics were consistently seen during the past 2 years for treating COVID infections. So this is basically a survey of 213 frontline physicians that was done. So apart from paracetamol, which was the most commonly prescribed drug, antibiotics were basically prescribed in almost 41% of the cases, while antivirals were basically given in less than 10%. So a large population of our patients got an antibiotic where maybe they never required the antibiotic. So how are the antibiotics used in COVID-19 infections? So one of the first antibiotic came up with azithromycin, and every person was taking an azithromycin for treatment of COVID-19 infection. Sometimes it was some other antibiotic was added to treat a respiratory co-infections. When these patients got admitted to the hospital and they received steroids, they developed secondary bacterial infections like a HAP or a VAP, and we reused broad-spectrum antibiotics. With the catheters inside, urinary catheters inside, IV central lines, they basically became the source of infection, and we needed to treat those with antibiotics. And a lot of patients, apart from taking your prescription, spoke to each other and started taking drugs prescribed by their other friends because everyone wanted to self-treat and protect themselves from COVID infection. So I guess you might have seen in your practice. So one patient was consulting almost 5 to 6 people, could be family, friends, and all doctors known to them for COVID infection, and this actually created a lot of mess. So secondary or superadded bacterial infections are common. They are seen in respiratory viral infections, but every patient who has a viral infection doesn't require an antibiotic. So you need to identify the group of patients having a viral infection when you are sure when to add an antibiotic. Suppose if the fever is not settling down, there is increase in the purulence of the symptoms, the WBC count start going up, or there is a fresh new lesion, then maybe there is a role for an antibiotic. But if you are sure it's a viral infection and you are just giving it symptomatic treatment, wait and watch for a certain period of time and don't jump to adding an antibiotic. So this was basically a study done to see the patterns of antibiotic use during COVID-19. 24 studies were included, of which almost 3,400 patients were surveyed. And it was found that only 3.5% of this population had a co-infection at the time of COVID infection, and 14.3% of them developed a secondary infection. But the antibiotics were prescribed for almost 72% of the cases. So this is the gross misuse of antibiotics, and in our country we have no regulation to that, because anyone can prescribe, or anyone can go and buy an antibiotic. So these were the studies which basically showed that there is insufficient evidence of associated bacterial infections, but the use of antibiotics were at a much more higher proportion than required. Also, one point that is most important that we need to realize is just because it is COVID-19 infection, do not use antibiotics just in case. The commonest thing is we need to do something. The patient is taking prescription from us. If we do not write, someone else will write. So I guess it is important that we convey to the patients why we are not writing an antibiotic. We may start an antibiotic if required. And I guess that's the thing that you have to spend some time with them to counsel them and prevent the overuse of antibiotics in COVID-19 infections. So basically, these were for all patients where antibiotics were added with mild COVID infections, severe COVID in the ICUs, associated SARI, sepsis, or associated hospital-acquired infections. So azithromycin, this was one of the most commonly prescribed antibiotic. Anything happened, start an AZI. And I guess every patient has taken azithromycin in the past 2 years. Now, it's a beautiful antibiotic. We use it very regularly for a lot of our infections. It is a drug having a long half-life with a large volume of distribution and commonly used for respiratory tract infections. But azithromycin was just not used. It was combined with hydroxychloroquine, which was the most irrational thing that happened. What we need to understand now is most of the public health organization and drug regulatory agencies do not advise the use of azithromycin to treat COVID-19 because COVID-19 is a viral infection and is not treated with azithromycin. Azithromycin per se is a drug which has a lot of arrhythmogenic potential. It is associated with significant torsades points or polymorphic ventricular tachycardias. And the risk of combining azithromycin with hydroxychloroquine significantly increases the risk of cardiac side effects and arrhythmias. Also, what we have seen, overuse and abuse of azithromycin, why it's available, it's not too expensive, needs to be given for 3 to 5 days, single dose drug. It also has given rise to an increase in the primary resistance to azithromycin in a day-to-day clinical practice. S. pneumoniae is the most common organism for which azithromycin has been used, and now I will be coming forward. There is almost a 26 to 30% resistance to pharyngeal streptococci to azithromycin, which earlier was not seen. So basically, as I already mentioned, the baseline macrolide resistance of pharyngeal streptococci has climbed up to 26 to 30%. And if you do not practice judicious use of azithromycin, and we keep on using azithromycin irresponsibly for treatment of viral infections or COVID-19 infections, we might lose a simple and a very important antibiotic from our antimicrobial armamentarium. So, friends, we need to be very careful about when and where to use this drug. This is basically a survey of antibiotic resistance which was done to see the global azithromycin resistance level. And across all countries, it was found that amoxiclav was found to be much more susceptible in the population compared to the use of azithromycin. Even in India, the sensitivity rate to amoxicillin clavulanic acid is almost 92% compared to azithromycin, which is 66%, cefpodoxime, which is 67%, and levofloxacin, which is 85%. I would not recommend the use of quinolones very regularly because quinolones are one of the most important drugs available for us for treatment of tuberculosis, and our country is endemic for TB. But amoxiclav, what I have noticed is a lot of doctors don't write amoxiclav regularly in their clinical practice. Earlier, maybe it was the cost. Second, there is a lot of scare about the GI intolerance, especially the diarrhea and stomach upset which happens with it. So these are the two commonest things which basically reduce the chances of use of this drug, and the thing that the drug needs to be given 3 times in a day. So to circumvent that, what you can do is, with the first bite of your meal, you can take the amoxiclav 3 times in a day. So with your breakfast, with your lunch and dinner, so that the chances of the GI tolerance significantly goes down. Also, it's a drug which needs to be given ideally 3 times in a day rather than 2 times in a day, which is commonly practiced in our clinical practice. So as per the WHO classification, the antibiotics are classified into 3 groups: access, watch, and reserve. Access is the group of antibiotics which are easily available to all. They are drugs which are more effective and easily available and not too expensive. Drugs like amoxicillin, amoxiclav and amikacin. With amikacin, the problem is nephrotoxicity, and that's why we need to be a little careful. Then watch about the drugs which have a slight antibiotic resistance potential like azithromycin and fluoroquinolones. And the reserve group are the drugs like IV antibiotics like cefoperazone, sulbactam, linezolids, piperacillin, tazobactam. They should only be used when ideally indicated. As per the NICE guidelines for antibiotic stewardship program, don't use antibiotics in mild COVID infections if you are sure that it's a COVID infection and not a bacterial respiratory tract infection. Give antibiotics if the disease is very severe and there are multiple associated comorbidities or associated complications can happen. Once you start an antibiotic, start an empirical antibiotic if there is a suspicion of an associated bacterial infection, review at 24 to 48 hours. If you realize the COVID-19 infection is due to COVID-19 pneumonia, then stop the antibiotics. Review the need for continuation of an antibiotic over the next 4 to 5 days and switch to a narrower spectrum antibiotic, especially if a culture sensitivity is available. After 5 days of antibiotics, stop the antibiotics if it's not really required. So empirical antibiotics which are prescribed for treatment of pneumonias could be doxycycline, amoxiclav combination, clarithromycin. In severe pneumonias, if other options are unsuitable, then levofloxacin. For moderate to severe pneumonias, injectable amoxicillin clavulanic acid with oral clarithromycin, injectable cefuroxime can be used. If the patient gets admitted and has associated comorbidities like diabetes mellitus, or there is suspected organism could be Klebsiella, we can step up the antibiotics to cefoperazone sulbactam or piperacillin tazobactam, and then wait for the culture sensitivity reports to decide regarding step up or step down of therapy. If MRSA is a suspicion, then we can start with oral drugs such as linezolid. In a severely compromised patient who is in the hospital or in the ICU, vancomycin or ticoplanin can be used. So the guidelines basically aim at slowing and stopping transmission of COVID-19 infection, provide optimized care, minimize the impact of epidemic on health system, social services. Widespread use of antibiotics should be avoided because it may lead to higher bacterial resistance. So if it's a mild infection, avoid antibiotics. Moderate antibiotics should only be prescribed if indicated. And if severe infections, then if the patient is on high dose of steroids with multiple tubes in place, if the patient is on NIV or ventilator, then you may require to start on empirical antibiotics and then narrow down the spectrum depending upon the susceptibility patterns. I'll just be concluding in a minute or two. So what is happening with the amount of changes that have occurred in the past 2 years? We have increased focus on hand hygiene, which leads to reduction in the spread of bacterial infections. We have drastically seen, because of the use of masks, the number of cases of asthma and COPD exacerbations have significantly gone down in the past 2 years. We did not have what was anticipated, that our respiratory patients would have a worst cases of COVID, but most of them, because of staying at home, wearing a mask, using their inhalers regularly, actually went scot-free with COVID infection, and if they did have it, it was a very mild infection. Even ILDs that we are suspecting that they would really deteriorate, that did not happen. Also, use of face covering and social distancing has reduced the spread of bacterial infection. Even tuberculosis spread has significantly gone down because most of the patients have started using a mask. Also, there is lesser opportunity for isolation of multi-drug resistant organisms, and hence what happens is there is a potential spread of them. Early discharge of such group of patients can basically prevent the number of patients carrying these infections in the hospital. Using a lot of antibiotics basically predisposes to development of antimicrobial resistance, and at times use of telemedicine. So we are not sure what the patient is. We are not able to examine, I guess. So that's how the overuse of antibiotics did happen. So gut microbiome disruption affects the immune response, the metabolism and physiology. As a result, the opportunistic pathogens are basically get a chance to grow and the normal flora gets affected. So avoiding the use of antibiotics could also avoid this gut dysbiosis.
Sir, 2 more minutes.
Yes. So overuse of disinfectants and sanitizer in the COVID-19 pandemic disrupts the microbiomes in humans, animals and the environment. So I guess in a way there is a little amount of immeasurable collateral damage to the microbiomes which may basically reduce our immunity on the whole and predispose us to secondary infections. So to conclude, antimicrobial resistance is one of the biggest threats to global public health, and that is significantly increased in the past 2 years. Excessive use of antibiotics should be avoided, and you should judiciously use antibiotics in the right dosages for the right period of time. Azithromycin is an important drug in our as an antibiotic and should be judiciously used. Various combinations of antibiotics are available, and drugs such as amoxicillin, clavulanic acid still work very well. And I guess this is, and with this end, I was making a last statement that antibiotics are not needed for all COVID infections. Luckily, the COVID pandemic has almost come to an end, and hopefully we'll be having such more meetings much more commonly. Thank you.
Thank you, Dr. Kapil Salgia. It was good insight on antimicrobial resistance and COVID due to easy availability over the counter and self-medication by the people and indiscriminate use by the doctors. The problem has increased. We should be very careful in prescribing antibiotics.
First,
Thank you,
Dr.
sir.
Vandana Tiwari.
I request our
Dr. Vandana
chairpersons to
Tiwari.
felicitate our speaker, Dr. Kapil Salgia.
Dr. Arif Brijesh.
I
Raise your
also
hand.
request our
Is Dr. Arif
President-elect,
here?
Dr. Anil Awad, to felicitate our
Dr.
chairpersons,
Arif.
Dr. Pragji Vaja and Dr. Rajendra Trivedi.
Dr. Kohli, Datta Kohli. Yeah, he's there. One more. Dr. Jayantilal Shah, please raise your hand.
Friends, our next speaker is Dr. Kirti Punamia, who is going to speak on recent advances in interventional cardiology. To chair the session, I request Dr. Jyoti Kaku Madam and Dr. A.Z. Shanbak to come on the dais. Dr. Jyoti Kaku, Dr. Shanbak. इधर बैठने के लिए हाँ क्या उसको भेज इसको फोन
Good afternoon. Dr. Kirti Punamia is a consultant cardiologist at Bridge Candy Hospital. After doing MBBS from Lokmanya Tilak Medical College, he did his MD in internal medicine and DM in cardiology from University of Mumbai. He did his fellowship in interventional cardiology from University of Michigan. He is a recipient of Dr. Raja Gopalan Award from Best Paper for the best paper in electrocardiology, electrophysiological mechanism of the supraventricular tachycardias. He has special interest in PCI, in a branch point stenosis and the influences of various devices, use of rational atherectomy in calcified lesions and left main stem PCI. He has published many papers in various journals. Today he will speak on recent advances in interventional cardiology. I request doctor to start.
Is that? This is okay. जायला पाहिजे.
Thank you. I thank the Indian Medical Association for inviting me. It's my first time that I'm speaking to an audience like yourself, so pardon me if I have not interacted just the most briefly. There's lots of things which have happened in interventional cardiology over the last 10 years. My job is to just put together a few things which have made an impactful difference in our practice, which have changed the way we look at patients. I'll try to talk about, in this realm of coronary artery disease, the functional assessment. We have moved away from talking about, I think we should do it, to something like, we need to do it because of 1, 2, 3. It's more objective now and not subjective like it used to be in the past. I'll also shade upon intracoronary imaging, which has made a huge impact in improving outcomes. We don't use contrast anymore for angioplasty, and we're moving towards zero contrast angioplasties. We talk about a little view on left mains and multivessel disease, which used to be the realm of cardiac surgery and coronary bypass surgery, and now is moved focus towards interventional cardiology. We'll talk about hemodynamic support, and then I'll conclude by talking a little glimpse about structural heart disease. Talking about functional assessment, we all probably have heard about a terminology called FFR. It's functional, it's a fractional functional flow reserve, which actually enables us to quantify and then to put a number to what is a significant coronary artery stenosis. Everything that looks 70% and above is not always functionally relevant. And to make things functionally relevant, we had to have an objective criteria, and clinical trials showed that this is the way to go in people with stable ischemic heart syndrome. So what's FFR? When you have a narrowing, which is right over there on top, as right there, if the flow is to the left to right, we need to put a wire across, which is a pressure wire. And when we measure the dynamics across this block, in the resting phase where there is no hyperemia, then you call it the RFR, the resting, or the IFR, or the DFR. This is a simple resting assessment of the coronary lesion. And now, if we were to give this patient adenosine and raise the velocity and take the velocity of coronary flow from what is standard as 8 meters per second to 30 meters per second, which is the maximum, then it's called the hyperemic state. And when you measure the same numbers, this is called the FFR. The resting indices of more than 8, 9 are considered not significant. Whereas when we consider FFR, anything more than 0.8 is not significant. So here we now have a number which can be objectively used to decide whether we need to intervene or not in a specific lesion. Typically, in a pragmatic approach, you do anything more than 0.93 in a resting, anything less than 0.85, and it already defines that you are talking about significant or not significant, but there is always a gray zone where you're not sure. It's this gray zone that we use the FFR, and so we use adenosine now in a limited fashion in this gray zone, and therefore it's made the practice a little more rational. Take an example. This is a 50-year-old gentleman, no cardiac symptoms, went for an investigation because he had a very strong family history, had a brother who passed away from acute coronary syndrome. Calcium score was very high. And you see a lot of these people, a lot of these 45 to 55-year-old people who really don't have major symptoms, and they have CT coronaries which have very high calcium scores, and here he had a significant lesion in the LAD. What would I have done a few years ago? 10 years ago, this patient would have had a coronary angioplasty with a stent placement over here. What do you do today? Here we routinely perform an FFR. In this case, the FFR, which is the red line, which shows the aortic pressure, and the green line, which is a pressure which is beyond the stenosis in the coronary artery. You can see that even though there's a gradient of around 17, this gradient comes back, as you pull this wire back, the number spit out is 0.83, which means that a value of more than 0.8 is insignificant. So we just conclude and say that this is medical management, control his LDLC goals to less than 50 and he shall do okay. As against that, this 67-year-old man, again the same boat, strong family history, no cardiac symptoms, had a very high calcium score on a CT with significant coronary artery disease. We brought him to the cath lab, and here we do an FFR, and this FFR is 0.70. Remember, 0.78, 0.89, 0.81, these are all the borders. That means one can make a mistake in these border zones. But when you come significantly lower than that to 7, and when you come to even 6.67s, over here, when we start intervening in these patients, it is appropriate because here there is a mortality advantage of going through this intervention. Otherwise, very few areas in cardiology where you have mortality advantages of a procedure. So, this rather complex lesion, after using a whole sum of technologies for the calcification, was treated with 2 stents, and we've got a great result. Similarly, a 63-year-old patient who referred, and what is she? She's had multiple triple vessel disease, referred to either go for a bypass surgery or multi-vessel angioplasty. That's how she landed onto my desk. What do we do with these patients? These are the 3 lesions. We counsel patients, we take them to the cath lab, and in these moderate-looking lesions, we do not go and jump into a procedure. What we do is we assess them with FFR in all these arteries, and we realize that even though they look significant, none of these significant-looking symptoms were really functionally significant, and this patient deserves to be on medical management. And so she continues to be on medical management, and this is something significant. For example, this one, who was referred to me by a very dear colleague, Dr. Jamshed Dalal, sent him to me from a center to us for a triple vessel angioplasty. When we took him to the cath lab, we realized that when we look at these circumflex lesions, which look moderate, these are FFR negative. That means they're not ischemia generating. And putting in a stent in these arteries, you're only going to give the risk imposition of the procedure rather than benefit of the procedure. So, this LAD, which is very significant and long, when we look at the resting gradients, they're 0.78. And when we give adenosine, they drop to 0.45. We've established in this patient who didn't have any significant chest pain but had shortness of breath, that this LAD is a culprit for his shortness of breath. And therefore, treating it and correcting it is going to be the therapy of choice. There is no subjectivity involved in this. There is a mortality advantage because this is a strongly positive FFR. We correct it with various tools. And the question is not how you correct it. It's not about what devices you use to get this angioplasty right. It's about getting the result right and then demonstrating that the FFR has normalized, because post-PCI, once an angioplasty is done, we can use this technology to also qualify the result. For example, if this FFR post-PCI was 0.82, even though it's not significant for ischemia in a native coronary artery, as a naive coronary artery, post-angioplasty, we cannot accept a 0.81 as a good result. We need to accept something close to 0.89. And after great efforts, we went to 0.87. We further dilated the stents, and we got to 0.89, and that classified a great result, and he does well. This is a class 1 indication in practice. In fact, as I speak today, in stable ischemic heart disease, in a patient on the table with coronary artery disease, which is not critical, non-critical or significant coronary artery disease, probably should be evaluated for significance of FFR before proceeding to an angioplasty. Let's move on to the next topic, which is intracoronary imaging. This has been a passionate topic for me, and around 12 years ago, we made a visible statement where we decided that every patient that goes through the cath lab is going to be imaged, and we're not going to rely on angiographic shadows. What is it? Here is a case example of a 63-year-old gentleman who was referred to me for an anterior wall MI. His creatinine was 4.5. He's not on renal replacement now. And because he's not on a renal replacement like dialysis already, we have to be extremely cautious of the amount of contrast we administer these patients, because very likely they can go into acute renal dysfunctions. So we get the original angiograms, and once we have a brief picture, we stop taking angiograms at this point, because what has happened is the occluded LAD, we've done a thromboaspiration, establish flow, and once we establish flow, we move on to putting in imaging catheters which are going to define the coronary artery. This is how we define the coronary artery. This is a high-resolution, high-definition intravascular ultrasound which uses probes of 60 megahertz, and they define the cross-sections of this coronary artery, as well as I get a complete length of the branches, of what length of stents I would require. It defines the landing zones, which are defined as, I know precisely the length of the stent, the edges of where the length of the stent has to be, and also the diameters of the stent. Once I know these diameters, selection of devices is only a matter of picking it off the shelf. There is no guesswork involved anymore. And then at the end, once you've done the angioplasty, you can also verify your results, because what you aim for is you look at this minimal stent area, or the minimal stent expansion index, as we call it in the interventional context, or a residual plaque burden. And I don't think you need to get into the details of these numbers, but we have defined absolute numbers which are going to classify as a successful angioplasty. For example, if we have not achieved a certain number, then those angioplasties are considered suboptimal, and they have a higher chance of recurrence and failures. Moving on, this patient, we ended up, because of this technology, we ended up doing it in 30 ml of contrast or less. This patient walked away on day 4 without any move or any shift on his creatinine values, which were at 4.5 to start with. So this is the power of these technologies. When we look at the data, acute renal insult from contrast nephropathy is huge, and as the contrast levels used go up, you will see that the AKI incidence goes up. And all these papers talk about 100 ml, 150 ml. What we should be actually targeting, and what I keep telling my colleagues, is we should be using less than 30 ml of contrast for this entire procedure. That's where we need to aim. Now, this is a 92-year-old gentleman with a creatinine of 3.5, multi-vessel disease, and we are able to achieve all this in our cath lab with high-definition ultrasonography. In this patient, the only amount of contrast used was 4 ml. He walked out with a creatinine of 1.5. 2 weeks later, not a touch on his creatinine values, because we had used such limited contrast for these very, very difficult subsets of patients. Is there any other technology? So this is using ultrasonography, and we also use light source as an image for OCT. And in this particular patient, which looks like a garden variety LAD lesion in an anterior wall MI, where most people think, oh, I could just go ahead and put in a stent there. The question is, what advantage does imaging have over the conventional method of doing this angioplasty? And the reason is that when you start looking at these images, I'll go to the next slide. Here we can clearly define a landing zone. That means we know that the blue arrow to the right indicates the proximal end of where the stent needs to lay. This blue indicates a length of the stent distally. And it also tells me that in between, we have so many things which we have to correct, as in lesions have to be prepared so that the stents are going to expand appropriately and correctly. Now, when I look at this when we looked at this angiogram, the angiogram said that we could have put in a stent which is either short or anywhere in this gray zone. But when we look at the gray zone on this OCT, we realize that there was not a single segment in this area where putting an edge of a stent was safe based on these images. And therefore, we defined a 30 millimeter stent, which was longer than what we would have usually taken, but this ensures a better result long-term wise. Why are these imaging technologies important? They're important because they reduce ischemic complications, they reduce recurrences, and they reduce mortality, at least in certain subsets. Also, I get asked very often, how does imaging guidance reduce adverse events? Like, what is it that you're doing different? Here is a case example, a gentleman who underwent an angioplasty to the circumflex branches as the arrows mark. And third day, he developed ischemic syndrome and the artery shut down. You can see there's an acute stent thrombosis. This was treated, and the patient, and the doctor and the physician and the cardiologist thought that this was because of platelet resistance, clopidogrel resistance, which was commonly referred to at that time. And then 6 days after correction, 6 days later, he had chest pain again. This time I was on call. I took this patient up. We had a totally occluded artery. After opening this artery, we ran in an imaging catheter, looked at the IVUS. What happened? We found that there were 4 issues. The stents were underexpanded. They landed in areas which were not appropriate for landing. They had edge dissections on both ends of the stent, and the plaque burden was more than 50%. That means the edges of the stent still had a huge amount of plaque. All this is a recipe for failure. And if we had used intravascular imaging in the primary procedure, this could have been avoided. In fact, let me tell you, over the last 7 years, we've not had a single stent of stent thrombosis in our stable ischemic population at all. And this is, again, it lies up with the data. And the data has time again for the last 15 years told us that when you see these kind of images and if we can correct it, we will have no ischemic complications. This is a garden variety case. Just about every interventional cardiology faces this every day. A simple, straightforward lesion in the mid-LAD. And it was done, this angioplasty was done by a very senior operator of great experience and legendary skill. Immediately post-procedure, you find that there's a huge thrombus. So what went wrong? Was it something to do with pharmacology? Was it something to do with anything else? And when we look at the images, we realize that when we look at these images closely, there are 2 things that stare in our face. One is the image up there to the right, which is right up there. You can see layers, one layer of stent and another layer of stent and none on the other side. So the entire stents are stacked towards one end of the coronary artery. The other side of the circle doesn't have anything. So you have deformed the stent without realizing it. And an edge dissection, a whole flap which is hanging over there with thrombus, not recognized. So if this was image guided, we could have avoided all this. And that's the point. My own example, 2006, I used to be in Bombay Hospital at that time. We spent hours doing this angioplasty. It was difficult, it was post-surgery, and it was an elderly man. And once we got a great result, we saw the last still needs to be done, went and put in the last balloon, ruptured this artery. We lost this patient in 3 minutes. We had actually invested a whole lot of time. And this is what I call the taming of a cowboy, or some wisdom setting in. And I had worked long and hard, and one misjudged step, because we thought we could have done it, made the mistake and we lost everything. Small things make big differences. And for the last 10 years, we've used intravascular imaging. We started with this very primary device, which is the 20 megahertz device in 2010. We've slowly moved in 2017, we changed to 2014, we changed to the 40 megahertz systems. And for the last 2 years, we have these high definition systems, which are incredible. Because you can actually tell I can actually tell you from my vision of what is the nature of the plaque, whether it's fibrous, whether it's lipid, whether it's calcified, and so many other things. It is a class 2A indication at this present time. I believe, gentlemen, this is going to become a class 1 indication as we go forward in the next 1 year or so, based on the data. Very quickly, I'm going to go through some subsets. We have the left main and whatever. We have to make difficult choices in left mains and multivessel disease between bypass surgery and angioplasty. I think one is less invasive, lower 30-day MACE, angina relief is rapid, more spontaneous MIs after long-term periods of 2 years, whereas CABG is more durable, it's less MIs, great revascular, there are less revascularizations, but there are more strokes, and there are more problems related probably to renal injuries. One thing is important, and the only difference that in certain subsets there are no mortality advantages, and the only difference being with angioplasty, one may require a second procedure. But when surgery is not an option in all these scenarios that I have highlighted here, and sometimes with patient reluctance or a recent failed bypass, we have no choice but to jump into certain coronaries which would have otherwise been the realm of a surgeon to go and fix them. But just because they are difficult scenarios which are thrown at us once in a while does not give us an excuse to do them suboptimally. And in the left main context, when the complexity is high, that means they're calcified and they're more involved, the atherosclerosis is extensive, it's a class 1 indication for surgery. But sometimes these patients come and fall into our laps inadvertently, and we have to kind of deal with them. As the experience of the operator increases, that means as you do more number of cases every year for this kind of, you will find that the mortality for those operators go down. So experience counts. Imaging counts in defining whether the lesions are simple or they're complex, because the strategies in these are going to be different. Here you can get away with a single stent.
Sir, 2 more minutes.
Here you need to do crossroad stents. I'm going to run through, and we did these complex procedures in 2008. It took us 3 hours, 500 ml of contrast. In 2020, we're doing the same complexities in an hour, hour and a half. But what has happened? The anatomy hasn't changed. How we approach it has completely changed. I'm going to kind of skip on how we do this to the next, take you to the last maybe 2 slides of this talk. And I'm going to skip some of this over here. What is important is taking you through a real story of the structural heart that we've had. 83-year-old guy came to us to a private hospital with acute pulmonary edema, and you can see the biomarkers are raised, the creatinine is raised, suffered a cardiac arrest, went through 2 CPRs, got an ROC, and intubated ventilator on vasoconstrictors, transferred to Bridge County Hospital at 2 in the morning. This is a chest X-ray. This is a cardiac 2D echo which shows severe aortic stenosis. CT was not possible, so we took this patient into the cath lab, and based on echo and transesophageal echo, as an emergency, went in, looked at the coronary arteries, which are okay, assessed this with an echo, and put in an aortic valve with a transcatheter aortic valve. What happened is just 40 ml of contrast was used during this procedure. This patient came around. The LV function improved. You can see that the heart is beating much better than it was before. Day 1, she intubated. Day 4, extubated. We were able to give her a chance. Similarly, on March 1st, we had an 82-year-old. She came in with symptoms, and we found the same, a severe aortic stenosis with an acute coronary syndrome. On March 2, we went and did a CT on her, identified, pinpointed the problem. On March 4, we went and did an angioplasty at the same time, did an aortic valve replacement in the cath lab. And on March 5, she's walking in the corridors to be discharged a day later. This is the story of what we do in 2022, which is very different from 10 years ago. And to conclude, so much as possible, much has changed. We have constantly evolved with an eye to improving outcomes. It is our responsibility to understand newer technologies and constantly evolve and bring awareness amongst our colleagues and patients. We need to audit our own performances time to time to make sure that we are relevant. Thank you.
Thank you, sir, for giving such informative talk and enlightening us on the recent advances.
Thank you.
Thank you.
I request chairpersons to felicitate the speaker. And Dr. Usha to come up.
Dr. Jagdish Kenny. Dr. Jagdish Kenny. Dr. Bafna. Dr. Bafna. Is he there, Dr. Bafna? Ticket number 35. 35. There is no name. 35.
I request Dr. Kajal Ahuja to felicitate our chairperson, Dr. Shanbag and Dr.
Dr.
Kakumilam.
Shrikant Mandge. Dr. Shrikant Mandge, raise your hand. Huh? 35.
Friends, our next esteemed speaker is Dr. Shashank Joshi for Dr. Ellis Memorial Oration. Sir is going to enlighten us on role and importance of high fiber in diabetes management in India. To chair the session, I request Dr. Kishore Kushale and Dr. Kashyap Dakshini to come on the dais. Dr. Kushale and Dr. Dakshini.
Dr. Shashank Joshi is a senior consultant endocrinologist, diabetologist, and metabolic physician at the HN Reliance Hospital, Leelavati Hospital, Bhatia Hospital, and Joshi Clinic. Dr. Joshi is a member of the Maharashtra government's COVID-19 task force. He has topped all the years of MBBS, MD, and DM with gold medals. He was honored by the Government of India in 2014 by bestowing upon him the Padma Shri, the fourth highest civilian award for his services in the field of medicine. He is the president of the Indian Academy of Diabetes and immediate past president of the Association of Physicians of India. He is the visiting clinician at the Mayo Clinic. Dr. Joshi is a prolific writer of articles on diabetology and endocrinology. He is also the editor of Practical Medicine, a popular undergraduate Indian textbook. He is also the editor emeritus of the Journal of the Association of Physicians of India and the Indian Journal of Obesity, the Indian Journal of Endocrinology and Metabolism, and the Indian Journal of Clinical Pharmacology and Therapeutics. Today, he will deliver Dr. Ellis Memorial Oration on the role and importance of high fiber in diabetes management in India. I invite him on the dais.
Thank you so much.
About Dr. Ellis Memorial Oration. Dr. Dadabhoy Ellis was a very strong supporter and a senior member of IMA. Dr. Naushid Ellis has requested us to have a lecture every year in the loving memory of his uncle, Dr. Dadabhoy K. Ellis.
Thank you so much. So at the onset, I would like to thank the Indian Medical Association, Mumbai branch, for bestowing this Dr. Ellis Memorial Oration, and I'm grateful to them. And I'm also thankful to the office bearers, Dr. Lad and the president, my good friend Dr. Utture and everybody. I can see Dr. Shanbag. And they actually pulled me very fast from Pune, because they said that, Alok is going to be late, so you better come and give the previous talk. And I think, so I had to bunk a couple of functions, but I'm here, but I'm thankful that, at least we are here and we are meeting physically, and we are meeting, hopefully we'll have the end of COVID, and I'm back to my endocrine work after my little sabbatical of public health and health policy. So, today, everybody talks of diabetes, and we have a large problem in India, but we all know that we are fibropenic. That means the food which we eat, and I'm sure the food which is delicious, which you all tasted today afternoon, might have had very little fiber, unfortunately, because when we eat outside, it tends to be fibropenic. So we have heard a concept called sarcopenia. Indians get all these non-communicable diseases because of sarcopenia. We have less muscle mass, so we have less protein. But in the carbs, we eat a lot of carbs. And in the carbs, really, what we see is that the fiber in the carb is gone. It's virtually disappeared. We want to drink juices. Okay, so juices have no fiber. We have thrown away the fruit, And if we have 5 fruits and vegetables, and that's my first take-home message, that if you really want to make a change in dietary habits, have 5 fruits and vegetables per day. It will make a huge change. I do have a duality in conflict of interest. This oration is supported by a grant to the Indian Medical Association from Hindustan Unilever. So diabetes is a huge health problem, and we know type 2 diabetes is the one which is making all the difference. We also know that there's a huge problem of obesity. Today, 6th of March, This meeting was supposed to be held in the first couple of days of January, and the 4th of March was the World Obesity Day. And we have this whole obesity is the mother of all diseases. And what has made the difference is the change in the dietary habits. We have shifted from our grandmother's diets to modern diets, which are very low in fiber. Though they have fibropenia, and they're very calorie dense, and we take and eat too much. So we have excess calories, we have refined food, saturated fats, a lot of sugars, and this is a deadly duo. Hardly any fiber and excess calorie dense food, refined foods, fats, sugars. So fiber is very crucial for type 2 diabetes management and their patients, and the glucose spikes. So what are these fibers? It's important as primary care doctors, which most of you all are here. There are some specialists in the audience. There are two types of fibers, soluble fiber and insoluble fiber. And both are important, both have a role. We all know that there is an important role for fiber. In fact, if we have adequate fiber, we won't get cancer, we won't get non-communicable diseases, we won't get heart disease, as well as diabetes. So the soluble fiber is nothing but a non-cellulose polysaccharide, oligosaccharide, beta-glucan, gums, pectin, inulin, nutriose, fibrosol. So these are all these soluble fibers, They are viscous, they are gel-forming, they are fermentable, and when they go to the colon, they make, these short-chain fatty acids. There was a good old saying in Gujarati that, if you make a good amount of gas and you pass your motion regularly, you will stay healthy, because it actually alters your gut microbiome. So if you really want to live long, the current dictum is that it is not how much money you have in your bank, but how many bacteria you have in your colon and how healthy they are, how symbiotic they are, And where are the sources of soluble fiber? It's the vegetables, it's the berries, it's the fruits which I talked about, because there is pectin from the fruits and vegetables like oranges, the apples, the berries, the carrots, the beans, the lentils, the nuts. Then we have the legumes, and then of course all these imported products have come in. Oats and barley, chias and flax seeds have become the popular foods. And nowadays, our source of information, unfortunately, has become Dr. Google and Dr. WhatsApp. But that's why I'm trying to place some evidence-based nutritional facts. And we also know that soluble fiber delays, slows gastric emptying. Number one. Number two, it improves glucose and glucose spikes. It modulates the LDL cholesterol, so it makes that sticky, chicot cholesterol into large and fluffy cholesterol. It improves gut bacteria. It improves the immune function, so it had a role even in the COVID times. It improves and makes you feel full, so you can keep looking at the food and just keep looking at it, and you feel full about it. Even if somebody makes the agra or tries to push you, it won't go, and it promotes weight loss. So that's really soluble fiber is actually medicinal. And our alternative specialists exploit it a lot, but we need to exploit it too, because we are the ethical allopathic medical specialists. The insoluble fiber has its role as well. The insoluble fiber is cellulose, hemicellulose, lignin. It's non-viscous, non-gel forming. It's moderately fermentable. It has no effects on the short-chain fatty acids. The fruit skins, the cucumbers, the tomatoes, the grain hulls, the brown rice, the legumes, the nuts, the almonds, the whole grain, the barns, they are the ones which are insoluble. They improve the weight of our stool or feces, and they improve the bowel movement, the consistency, they decrease the intestinal transit time. And they are usually useful for preventing and treating constipation. They again promote satiety, make you feel full, and they promote weight loss. So that's the take on soluble and insoluble fiber. I thought I should spend some time on it. So the fiber has an endocrine effect, it has a colonic effect, and it has an intrinsic effect. The endocrine effect is that the fiber improves the lumen viscosity and decreases the rate of gastric emptying, decreases prandial glucose, which swings up, decreases insulin secretion, and decreases the even post-absorptive hypoglycemia. So if you have adequate fiber on board, you won't feel sleepy immediately after food, and you won't get a headache 3-4 hours after food. The sleepiness immediately after food is because the sugar spike is very high. And the little bit of irritability you develop at this point of time, it's around 4:35, 5:30, is because then there is a post-absorptive hypoglycemia. So there's a swing. So that rapid up and rapid down does not happen. Then of course we have intrinsic effects like, the energy density, the palatability. We need to chew our food. We need to really chew our food, and we need to modulate and burn our fat. And fiber is actually a fat burner. People take fat burners pharmaceutically, you don't need that, you just have to have adequate dietary fiber on board. It will promote satiety, make you feel full, and reduce body weight. And finally, it has the colonic impact, soluble and predominantly insoluble. The soluble will improve the short chain fatty acids, and they actually switch off the liver glucose diarrhea. All the diabetes occurs overnight, because at night, our liver is the biggest metabolic organ of our body, and it is pouring out glucose. It's called as hepatic glucose output. And actually fiber, via its various colonic peptides and gut microbiome, actually switches off that hepatic glucose diarrhea and decreases the insulin secretion. So obviously high fiber diet is crucial for better absorption and digestion of carbohydrates, reduction of prandial glucose, promote fullness, weight loss, as well as promote even cardiovascular health. At our national association, I was a past president a couple of years back, whether it's the Indian, the American, the Indian Council of Medical Research, and all these guidelines, many of us have had a role. We need some grammage of fiber. We need at least 25 to 40 grams of fiber per day. And we need to improve our diet with both soluble and insoluble fiber. And we need to fortify our dishes with fiber-rich alternatives. For example, we need to add soluble form of oats in the upma, or improve the quality of Indian flatbreads like roti and chapati by adding the wheat flour with legume with soluble viscous fiber. So some of these modern foods which are coming in, we call them, and I call them as a nickname called functional foods. They all have got a little bit of soluble and insoluble fibers. And the main source, if you ask me, of fibers, again, as I said, my first take-home message, it's fruits, leafy vegetables, nuts, fiber, and whole grains. The patch. Have 5 fruits and vegetables per day, or have a diet rich in fruits, leafy vegetables, nut, fiber, and whole grains. That's the 5 which you really need to remember. So it's 25 to 40 grams of fiber which we need. And there is data that India is fibropenic. This is published data from India. I really don't want to bore you all for brevity of time, and I want to save some time because the hotel will take us out, and I want to have my good friend Alok also to have an adequate time and interaction with you. But we skip breakfast. We snack a lot of low fiber, high calorie foods, and we are having very low fiber content. If you look at rural India, tribal India, their intake can be very poor. But if you look at high income group, middle income group, low income group, male and female, the fiber intake varies. It really varies. It's illustrated in the slide. And if you look at various food sources of dietary fibers, whether it's grains like rice, wheat, because it's rice and wheats. We are not an oat country. Oats is for horses. Even now, oats is not a popular food item. Legumes and pulses, we don't have too much of soy. We have more of peas, which are green, or kidney beans. We love our potatoes without skin. We hardly have bitter gourd or beetroot or ladyfinger. We have a lot of fruits, but we don't eat them. We have more of fruit juices, which are fibropenic again. And the nuts and seeds, peanuts and cashew nuts score above almond. And that's really the tragedy of India. So if you look at the fiber content, again, lot of our food which we consume every day is fibropenic. So we really need to, what has happened in the last 200 years? 2 changes have happened in India. Number 1, these seeds have come. Human beings 200 years back were not in India sitting down on chairs. Sitting on a chair is like equal to smoking. All of you all know that. And the second thing which has happened is, we have got a serialized economy. We have broken that whole grain. We have actually broken that grain. We have polished that grain. We have removed all the good external fiber substance. So all the cereal grains, whether it's wheat, rice, maize, or oats, rye, barley, critical sorghum, millets, all of the grains, minor and major, they all have got polished and the outer covering of fiber has gone. And that's really the one which has led to this cardiometabolic pandemic, as they call it. So remember, really, is there documented benefit of high fiber? Is it really beyond reasonable doubt that fiber works? Yes, it does work. Because we are in an era of evidence-based medicine. So high fiber clearly benefits metabolic health, and fiber-rich fruits are beneficial, very clear data. And the American Diabetic Association says if you have soluble fiber, your glucose will go down, insulin will come down, lipid profile will come down. And the more fiber you have, the thinner you will become. So remember, if you have high fiber, high carb, low GI food, your triglycerides will come down, fatty liver will come down. And one thing is clear cut. A lot of people in India, they say we do a lot of exercise, we sleep well, we are very disciplined, we eat proper normal food on time. But the food is now the modern food. Even though it is home food, it is fiberopenic. And that leads to, if your fiber content every day in your diet is less than 29 grams per day, it will lead to dyslipidemia and a heart attack. So it's very clear data across the world now, including India, that high fiber matters in type 2 diabetes. It clearly matters for cardiovascular disease, and we don't want to see cardiologists. It clearly matters in blood pressure. It clearly matters in albumin, urea, in heart failure, in intermittent claudication. And we know that if you have adequate soluble fiber in our diet, the systolic and blood pressure, diastolic blood pressure will come down. You can try this experiment. Just start having fiber in your food, and if you are taking 3 blood pressure pills, you will end up with taking 1 blood pressure pill after some time. I've actually tried it out in a research study, and we published in British Medical Journal in 2015 the START study, and we have actually shown this in an RCT. And now we are using artificial intelligence to do that. So remember, fiber-rich food can control blood pressure and sugar both. It can also reduce triglycerides very effectively, and also increase and improve the HDL cholesterol. And clearly, it can prevent weight gain. In fact, one of my simplest prescriptions to lose weight is you take any fiber, and it's the most economical fiber is like a simple isabgol husk. Dissolve it in a glass of water, drink it half an hour before lunch and dinner. It is sundar, sasta and majboot. Anybody can afford it. You can just buy simple isabgol husk and try it out. You will make that patient lose weight. The patient will be full. Patient will not have heart disease or diabetes, and if they have, the number of medications will come down. It's a simple take-home tip. So the second take-home tip after 5 fruits and vegetables is just use simple isabgol husk and dissolve it in a glass of water. Drink it half an hour before lunch and dinner. You will see it often in my prescriptions, in my clinical practice and clinical care, because there's very, very good data in obesity or weight loss. It clearly has beneficial effects in the gut axis, whether it is treating constipation, diverticular disease, irritable bowel syndrome, and Crohn's disease. Clear data. And there's documented outcome studies from North America and Europe that it prevents colonic cancer, gallstones, duodenal ulcers, hemorrhoids, and hiatal hernias. Data which is documented beyond reasonable doubt. So obviously, when we look at fiber-rich diabetes nutrition, these are the 4 points in medical nutrition therapy in type 2 diabetes. The first point is carbs. Have less carbs. Try to restrict carbs. Most of us try to take carbs around 70%. Try to make it half. Try to have at least 25 to 40 grams of fiber. And try to have foods which are low in glycemic load or index. Second point is protein. Increase some proteins. Limit red meat. And try to improve your protein content, because we are definitely protein deficient, which is why we are sarcopenic. So in the carbohydrate component, restrict carbohydrates and correct fiberopenia. In the protein component, increase proteins, vegetarian and non-vegetarian both, and try to improve sarcopenia. In the fat, avoid fried foods. Cook in less oil, less than half kg per person per month, and blend oils. Use mixture of 2 oils. Avoid trans fats. avoid hydrogenated fats. That's all you need to do. And in the dietary pattern, have fruits, leafy vegetables, high fiber, nuts, whole grains, pulse legumes, and unsaturated fat. Restrict a little bit of salt, and it's all about fiber-rich diet nutrition, which is a new term which is coming up. So adding lot of fiber can also have challenges, because you can get fiber overload. So don't suddenly add too much of fiber too quickly, because it will cause bloating and flatulence. And all of you all as practitioners know it, and therefore go slow, go gradual, and increase fiber content every 2 weeks. If you have more than 60 grams of fiber per day, it will cause abdominal discomfort, pain, and diarrhea. Some fiber-rich foods like wheat, rye, barley, all these foreign foods I call them, they actually cause allergies sometimes. So we have to promote loco-regional. So prioritize on fresh local seasonal fruits and vegetables of the time and season. If there's a pork season coming from Surat, have it. It's a seasonal, it's a seasonal thing. It will have some amount of fiber. But you fry it, you are going to actually break that fiber out of it. So ensure that you must promote fresh, local, seasonal fruits and vegetables, whole grain cereals, millets, legumes, nuts and seeds. Try to have a large breakfast with a lot of fiber. Because if the cereal has adequate fiber and less sugar, your day will go good. Large breakfast, moderate lunch, light dinner should be the dictum of the day. And that's the way to go. Add a salad at least to every meal per day. Start the meal with a salad or an unstrained soup, because if you strain the soup, the fiber is gone. So the sieve should be thrown out. And type 2 diabetic subjects should choose fiber-rich foods. It's very, very crucial, and have a lot of fluids and water. We have actually also started drinking less water. So we need to have at least 2 liters of water. Of course, I'm not talking of contraindications to avoid constipation. So these are simple things which we need to recognize when we are talking of fibers. Obviously, the eating plan has to be talked with a diet specialist. Customize it. Have to be mindful of healthy speeches. We were talking of FFR in the previous talk, but nowadays a buzzword in nutritional word is FMR and PMR, which is partial meal replacement and full meal replacement. So I have 3 to 4 minutes. I'll try to finish in the next couple of slides. And we need to ensure that if your patient can't listen to you, they say, we just can't do what you say, doctor, then tell them, can you partially or totally replace your heaviest meal of the day? It could be breakfast, lunch or dinner with a supplement like a meal replacement, because that will have everything in it. Micronutrients will be there and there will be sufficient diet. So summarizing in the last thing is, high fiber diet is clearly beneficial for cardiometabolic health. We need to have fiber rich foods, ideally from the nature or from fortification or from cerealized foods which are functional. And therefore, there's a new entity that we need to correct fibropenia in Indians and have fiber-rich diabetes nutrition. Thank you for a patient hearing.
Thank you, Shashank. You have given enlightened a topic which is very important for the whole faculties for their treatment of the patients. And what to eat and what not to eat, just we are remembering. So high fiber diet we have to take. But what is the quantity and all you have told us? I think all the faculties and the GPs, they will treat the patients whatever you treat. Thank you.
Dr. Raj Kishore Tiwari.
We are moving towards the reversal of the diabetes with this topic today. I request now Dr. Jitesh Mehta, our president, to come on the dais to felicitate Dr. Doshi.
Dr. Belose. Dr. Belose. VL. Naringrekar.
Lucky draw number 95.
Dr. VL Naringrekar.
I request Dr. Kajal Ahuja to felicitate our chairperson, Dr. Kishore Kusale, who is a HOD, Department of Anatomy and KM Hospital, and member of Managing Committee. Dr. Kashyap Dakshini, who is a member of IMA CGP, Mumbai Sub-Faculty, and convener Registration Committee.
Hi, hello, how are you?
Our next speaker is Dr. Alok Sharma, who is going to enlighten us on anti-aging integrative therapies. To chair the session, I request, and sir is for Dr. C.L. Javeri oration. And to chair the session, I request Dr. Kishore Gandecha and Dr. Sachin Patharkar on the dais to chair the session. Dr. Sachin Patharkar is a co-chairperson, Stage Management Committee, and Dr. Kishore Gandecha is a past president of IMA Mumbai branch, chairperson of Sports Committee, and chairperson, Press and Publicity Committee. Dr. Sachin.
Good evening, everyone. Dr. Alok Sharma is a professor and head of the Department of Neurosurgery at Sion Hospital. He is the director of Neurogen Brain and Spine Institute, Navi Mumbai, and consultant neurosurgeon at the Fortis Hospital, Mulund. He is the founder president of the Stem Cell Society India. He is the pioneer in the stem cell therapy in neurological disorders in India. He has received numerous awards during his career like the Shushrut Award and Bharat Gaurav Award. He specializes in stem cell treatment for incurable neurological disorders like autism, cerebral palsy, muscular dystrophy, spinal cord injury, and stroke. Today he will deliver Dr. C.L. Javeri oration on anti-aging integrative therapies. I invite him on the dais. Dr. C.L. Javeri oration. Dr. C.L. Javeri was a well-known gynecologist of Mumbai. He was instrumental in starting the Family Welfare Center in IMA Mumbai branch. Sir, over to you.
Thank you so much, Chairman Sir, and a big welcome to all our delegates. It's late in the evening and all of you are still here. I'd like to thank the organizers of the Indian Medical Association, the office bearers, my very dear friends sitting up in front, to invite me to take this oration. It's an honor to take the Dr. C.L. Javeri oration. Most of the lectures you heard today were about patients, about whom you treat. But this lecture is about you. It's about us. It's about our health. And I'm here to give you some information about aging and how it can possibly be reversed. Yes, you heard that correctly. It is possible to reverse the aging process. We all know aging from the external appearances, old people, skin wrinkles, white hair. And we also know aging from the disorders it produces, because the bulk of our medical practice is about disorders that are age-related. But what most of us are not aware of is that aging starts at a cellular and a subcellular level. And, this takes a talk by itself, but I'm going to try to summarize it in one slide. Basically, as we age, we have telomeres, which are the tip of our chromosomes. I'm going to talk about that, which shorten. There's genomic instability. There is loss of proteostasis. There are things that happen with our gut. There are things that are happening to our mitochondria. There's cellular senescence. There's exhaustion of the stem cells. And there is altered intracellular communication. I won't go into the technical details, although these are very interesting. However, I'd like to emphasize on one aspect, and this is my message. First, that today we have a very simple blood test to monitor aging. Just like we monitor our sugar levels, just like we monitor our renal function and our lipid profile, today a simple blood test which can measure your telomere length can tell you how much you are aging. A simple blood test, that's all it takes. And secondly, we have very simple, non-invasive medical technologies which can slow down and reverse aging, for which there are lots of publications, and I will share with you our personal practice as well. So what exactly is the telomere? The telomere is the tip of our chromosomes. And you know, like within our cells, we have these our chromosomes, and the tip of it, as you can see, is the telomere. Now, with age, the telomere keeps on reducing. So if you see, you know, with age, it keeps coming down over a process, and it becomes small. And when the telomeres reach the end, it is time that the cell can't survive anymore, it can't multiply anymore. So basically, telomeres tell us how soon our cells will die, because telomeres protect the chromosomes and keep them stable. The shorter they become, the sooner they die. So today we have a biological test that can very accurately predict your biological age, which is different from your chronological age. Your age by birth is one thing, how your cells are aging is another. So shorter telomere length is associated with premature death, cancers, cardiovascular diseases, obesity, stroke, and a whole lot of other age-related processes. Now, telomeres have shown that it is possible to live up to 120 years. So the maximum age possible is 120 years, and the oldest person living, Jane Calment from France, lived up to 122 years. So when you measure telomeres, but none of us lived till that time, because our lifestyle actually and other factors reduce the maximum expectation. So it's possible to live to 120. Now there are two interesting studies, and it is these studies that actually got me interested in anti-aging. The first is from Dean Ornish, which is from the United States, published in 2013, who looked at how lifestyle changes affect telomeres and aging. So this is the paper which is published. It's a very interesting paper. I think all of us should read it. What he took was, he took patients with cancer prostate and divided them into two groups, an intervention group and a control group. Now the control group continued their lifestyle, whatever they were doing before. The intervention group had this intervention. First, they shifted to a plant-based, whole food, protein, fruits, vegetables, completely in accordance with our previous lecture and our speaker, unrefined grains, legumes, low in fat, moderate aerobic exercises, 30 minutes per day, yoga, meditation for stress management, and once a week, a social support, like a get-together with people. So this is very interesting. Just shifting to a plant-based diet, okay, moderate exercise, yoga, meditation, and once a week social activity. Let's see what it did to the telomeres. This is amazing. The group which continued life as it is, same lifestyle, same diet, the telomere length decreased by a ratio in which it naturally decreases. In all of us, with age, our telomeres decreased. But in the intervention group, it increased significantly and statistically. So for the first time, this paper showed that just by simple lifestyle changes of diet, exercise, yoga, and a social support, you could reverse the aging process. This picture is from the paper which is published, which shows a very dramatic difference in telomere. The control group, it decreases. In the intervention group, it increases. So this is proof, but this was over a 5-year period. Sorry. Then the second paper, which was again very interesting, from Israel, which showed the effect of hyperbaric oxygen on telomeres and aging. Again, a very interesting paper, and in this paper, what they actually again showed, that using, they took 35 individuals, 64 and above, they got 60 sessions of hyperbaric, And they showed graphically that the blue is the baseline, that after 30 sessions, the telomeres increased. After another 20 sessions, there was another increase. So this very clearly showed, and this was in the natural killer cells, the B cells, the T helpers, the T cytotoxics. In all these cells, the telomeres actually increased with 60 sessions of hyperbaric oxygen. Now, there are some other publications. There's this publication that shows yoga actually increases the telomere size. So we all know yoga is helpful, but now it is actually showing that it is affecting our chromosomes. Then in this paper which showed exercise, and in this other paper which showed that, again, a diet of legumes, nuts, seafood, fruits, etc. So all these things actually reverse the telomere decrease. There are some other papers which show a negative effect. So this paper that shows that if you take additional sugar through sodas, there is a reduction, you have shorter telomeres. In this paper which showed alcohol, again, regular alcohol use shortened telomeres. And in this one which showed depression, again shortened telomeres. So basically, in summary, aging can today be measured by a simple blood test, and I personally recommend that all of us should get it done at least once a year to know whether our biological age is matching with our chronological age. And telomeres are very strong predictors of aging. Now, from the published papers, this is not philosophy, this is not general common sense, this is scientific published papers which I just showed you. Yoga, exercise, diet, and hyperbaric oxygen increase telomere length. Sugar, alcohol, and depression decrease telomere length. So here's a study I did on myself. This is my study. I actually first did my telomere measurement, and I'm 60 years old, and I found, to my surprise, my cellular biological age was 85. I've never been so shocked. I looked at that and said, this is crazy. I'm 60 and my cellular age is 85. So based on the Israeli paper, I subjected myself to 40 days of hyperbaric oxygen. That's the hyperbaric oxygen chamber. We have it in our own hospital. We were using it for neurological disorders. I decided to take this myself. And within 40 days, my biological age came down to 70. A 10-year improvement in biological age with 40 sessions of hyperbaric oxygen, exactly what the Israeli paper had shown. They showed exactly the same results. But then the Israeli paper had done 60, so then I did 20 more, and then I found that my biological age came down to 65. And then I stopped the hyperbaric, and then I again repeated after some time, and then it came down to 60, which is what my real age is. So this is very interesting. This is me. From my biological age being 85 when I'm just 60, after 40 days of hyperbaric oxygen, I brought it down to 70. After another 20 days of alternate day hyperbaric, I brought it down to 65. And then with a gap of 40 days without hyperbaric, which meant that the improvement seen was sustained. Between day 80 and day 120, I did not take any hyperbaric, but the improvement continued. So today, my biological age matches my real age. So this is me, my own data. But then 40 days is too long. It took me 120 days to bring my age down, my biological age down. So then we evolved, and by the way, there was no other change. I had exactly the same food I was eating before, the same exercise pattern, everything was the same. Only one intervention, regular sessions of hyperbaric oxygen. And then we did, so then we said, okay, let's see if we can, squeeze this thing into a 1-week program. So we did a study, we studied 12 people between 55 to 85 years old, and we gave them 10 sessions of hyperbaric, but we combined it with ozone therapy, gut cleansing, acupressure, intravenous high-dose vitamins. And this is what we saw within 1 week. Memory improved, anxiety improved, depression improved, sleep issues were resolved, mood swings were better, palpitation was better, muscle pain, joint pain, gut issues, loss of appetite, urinary incontinence, exertion, difficulty in mobilization, skin elasticity, hearing, vision, varicose veins. All of these improved in the following percentages as shown. And of these, the first, what is listed in red, was statistically significant. The others, though better, were not statistically significant. Then the biochemistry. We showed that everything from hemoglobin to fasting to postprandial sugar to ESR, CRP and creat, all of them also improved with a single week of anti-aging treatment. Now here's the interesting part. If you look at this figure, you'll notice these are 12 patients. The first column has the actual age. And you'll notice all the people in this, their biological age was more. So patient 85, which was my mother actually, that's my mother, the first one. Her actual age was 85, her biological age was 89, and after 1 week of treatment, it became 88. A 1 year reduction, but at that age, that's amazing. I could give my mom what is biologically maybe 1 more year of healthy life. And you can see in this graphic, a 59-year-old person whose biological age was 68. It came down by 2 years, and so on and so forth. And some were significant and dramatic. Like an 81-year-old person whose biological age was 96, and after 1 week of therapy, came down to 90. So these are to show you that with a 1 week of treatment, one can actually reverse the aging process. And this is just a graphic representation of the same, 85-year-old person, biological age is 89, and after 1 week therapy, it was brought down. So what can we do medically to slow down and reverse the aging process? The definition of anti-aging medicine, and this is an entire new field now, it's very, very popular in the United States. It's somehow not as popular in India, but I think many of you should develop this. This is a field that is actually practiced by family physicians. You don't have to be an expert to be into you don't have to be a specialist. Any medical practitioner can practice anti-aging. Please read about it, Google about it. There's an anti-aging society in America. They have a lot of courses, and it's very, very interesting because this concerns us. It concerns our families. It concerns our parents and others. So the definition of anti-aging is very interesting. To prevent the preventable and to delay the inevitable. You can prevent a cancer or a heart attack or a stroke. Death you cannot prevent, but maybe you could delay it. So this new field is called integrative medicine, and there's a combination of a whole lot of therapies. I'll run through them fast. The first I said is hyperbaric oxygen. We all are familiar. We know it has been used for non-healing ulcers. What does hyperbaric oxygen do? Normally, when we breathe air at 1 atmosphere pressure, only the hemoglobin in the RBC carries the oxygen. Whereas when you give oxygen under 2 atmospheric pressure, the oxygen goes into the plasma. So your entire blood is carrying oxygen. Right now, only our RBC is carrying oxygen. But when you go into a hyperbaric chamber, the entire plasma is now filled with oxygen. And so that is the reason why there is greater oxygenation. And we know that almost 3 out of every 4 illnesses has hypoxia as an underlying cause. So the overall benefits are huge, from stimulating oxygen, improving metabolism, energy levels, and reducing fatigue. And there are several papers now that actually show that hyperbaric oxygen reduces the various cellular effects of aging and clears the senescent cells. The second therapy is ozone therapy. So oxygen is O2, ozone is O3. What is used is medical grade oxygen is taken, it is run through a machine, and it has very good antioxidant, anti-inflammatory, anticoagulant, and germicide effects. So it reduces inflammation everywhere, it improves the gut health, and it has a lot of anticoagulant effects, improves oxygenation. It can be given by breathing. You can breathe it into your lungs. It can be given through the lungs. There's an ozone sauna, and it can be given IV as well. Now, we did some clinical studies on ozone in COVID-19. Our hospital was converted into a COVID hospital, and this is published in International Immunopharmacology. We did a pilot study to see the use of ozone, IV ozone in COVID, and there were no major adverse events, and there was a lot. You can see the results. The oxygenation was significantly better and improved, and all the inflammatory biomarker levels dropped significantly just by use of ozone. This was the second paper that again published by us. What we did was we took our healthcare workers, and our healthcare workers, before we became COVID, we offered them the option of taking ozone as a preventive. Some people took and some didn't. So 64 received ozone, 171 did not take it, and the results are amazing. Out of the ones that took ozone, only 4.6% became positive, whereas out of the ones who did not take ozone, 14% became positive. So this was a dedicated COVID hospital. Some patients, some of our workers, healthcare workers took ozone. Amongst them, it was only 4.6% positivity, and the ones who did not take was 14. And when we studied that into red zone, orange zone, green zone, everywhere. In fact, the orange zone you can see 4.3% from those who took ozone and 20% from those who did not take ozone. And there's this other study which is now under review for publication. We had a control study, 254 patients, these are COVID patients, who received IV ozone with standard treatment, 300 only standard treatment, and there was a significant difference in the average duration of hospital stay, use of oxygen, ICU stay, recovery, as well as mortality. All were much better in the ozone group. We've published 2 books, and I'm sure many of you have taken a copy of it. This is a book that we have written for family physicians. It's distributed at no cost at all, both hard and soft copies. There's another book we've written on cytokine storm. And there's the book that I've edited along with 2 other authors, which is a summary of all the work done in the municipal corporation hospitals. Gut cleansing is another very important part of the anti-aging process, because the gut is actually referred to as the second brain. And it's got about 100 million neurons, and there is something called meta-inflammation, and there are various causes of meta-inflammation. Cleansing the gut is a very important part of anti-aging. And, there is this therapy called colon hydrotherapy, which is, I'm not sure, many of you have heard about it, but basically, water is sent up the intestines, the large intestine, the colon, and it results in impacted and difficult to excrete things which come out, and this has a tremendously useful effect in the anti-aging process and in boosting immunity. It's a very simple machine. It's not very uncomfortable as it looks, and it's just water that goes and cleanses your intestines. Then there is infrared sauna that is used for anti-aging. There's acupressure that is used. There's cryotherapy that's used. There's micronutrients. This is important because what we do is we evaluate. We don't just give randomly. We actually do blood tests and evaluate which micronutrients are deficient, and then we correct that. And there's a whole lot of correction that can be done.
Sir, 2 more minutes.
Yeah. And then hormone therapy is given in certain cases where there is hormone problems. There's weight management of anti-aging, and there is a dermatological aspect. So all these things go into the anti-aging process, and all of this is available at a dedicated anti-aging hospital that we have set up in Navi Mumbai. This is the 7-day detailed program. I'd just like to roughly run through cellular therapy, which is helpful in age-related disorders. What I spoke about before was not for patients. It's for people to prevent and slow down aging. But aging can cause dementia, and we can use stem cells for that. Stem cells are cells which can convert into any other cell type. They repair, replace, and regenerate. And this is the various ways in which this is used. It can be autologous or allogenic. And what we have found is that in dementia, stroke, and ataxia, so in dementia, you can see here now the results. You can see the scan above. The blue area is hypometabolic in a case of vascular dementia. And post, you can see the brain has recovered function. So there are very good results in dementia using stem cells. And this is a paper that we've published on vascular dementia. It's very useful in brain stroke, people who are hemiplegic and aphasic. Excellent results, 77% showed improvements. This is a published paper of a clinical study. And above you can see the hypometabolic area in a stroke, and below you can see the area which is resolved. Again, all our work is published in peer-reviewed journals. It also helps in motor neuron disease and muscular dystrophy, which is an accelerated form of aging. So I will just run through that. And we also did a clinical trial on stem cells in COVID. It was the first, India's first DCI approved study, which we did at the LTMG hospital. And we saw very good results of it. The data has been sent for publications. You can see there's improved oxygenation after stem cells, and all the inflammatory parameters settled. We've got 103 scientific papers and 12 books, including 2 books for general family physicians, 1 on neurological disorders, 1 on COVID. This is a book which it's been an honor that Prime Minister Shri Narendra Modi has written an introduction for one of my books, and this is me presenting that book to him. So I'd like to thank you for your attention, and I'd just like to conclude by saying aging can be actually measured today. So just like we measure do our lipid profile and our sugar, we should monitor our aging through testing our telomeres. 2, our biological age is more than our real age in everyone. So we should correct it. Then there are long-term and short-term. Long-term, diet, exercise, and yoga can reverse aging. Short-term, medical treatments like hyperbaric oxygen, ozone, intravenous and oral micronutrients can help. And regenerative medicine through cellular therapy can help, playing an important role in reversing damage in diseases caused by aging. So with that, I'd like to thank you for your attention. Thank you very much.
Thank you very much, sir. Excellent information we got how to control the aging by yoga, exercise, diet, and hyperbaric oxygen. Thank you very much, sir.
Thank you. I request our President,
Ticket number
Dr.
56.
Jitesh Mehta,
Ticket number
along
56.
with our chairpersons to felicitate our speaker, Dr. Alok Sharma. I also request Dr. Ramesh Shah, sir, who is a fatherly figure and past president of IMA Mumbai branch.
Dr. Bhushan.
Our source of inspiration.
Dr.
Who
Bhushan.
is Dr. Ramesh Shah is a just 92. He is younger than his age. He is a
Dr.
great
Mahesh
poet,
Shampura.
writer, humble, loving at heart, and very human being. We need to learn secrets of anti-aging from Dr. Ramesh Shah, sir. Thank you all. सुजा वोट ऑफ थैंक्स बाद में वोट ऑफ थैंक्स बाद में हां लास्ट कि जगदीश के को बोला बात नहीं वोट ऑफ
Friends, I request Dr. Rajendra Trivedi and Dr. Hosika Padia to come and declare the Mediquiz gift announcement and the results also. Thank you.
Mediquiz. Hello. For Mediquiz, more than 50-60% had participated. The first prize goes to Sandhya Raghavan, 16 correct.
First prize bola उसने.
16. 16 correct.
First prize or second?
First. Second, Dr. Akash Dhuru. Same 16, तीनों तीन का 16 है. First 3. Third one, Dr. Archana Samir Vinarkar. 16. Fourth, Dr. Pradeep Acharya, 14. And last one, Dr. Sunil B. Jain. He is also on 14. Sunil Jain.
Fifth person is not there, then we keep it that way only. Yeah.
Dr. Sunil Jain.
And now announce the stall prices. The first prize, Hindustan Liver.
Best stall prize. The third prize goes to Franco-Indian Pharma. Someone from Franco-India. Yes.
Oh.
Franco-Indian. Third one. Third one, Franco-Indian. Hello. The second prize goes to Symbiosis Hospital. Symbiosis Hospital. And the first prize goes to Hindustan Unilever.
Now we come to the mega draw. There are 12 mega draw prizes. So everybody be seated. And after that, there's a late bird gift also that is happening. The 12th prize is iron. Let us see who gets it. Dr. Shignapurkar, 075. 075. Dr. Shanta Haridas, 071. 11th one, blender. आप लिए 149 Dr. S.R. Dubey, 149, that is the 10th one, air iron. एक मिनट, let one person come. Please raise your hand, Dr. Dubey. हाँ, he's coming. नहीं, वो अभी आएगा. Dr. Shashikant Kamath, 038, that is a toaster. Toaster. Dr. M.A. Merchant, 212. ये देखो, merchant ही है ना? He gets a juicer. It's a juicer, Maggie company. Oh. Dr. Hemant, 057. क्या है सरनेम क्या है?
हल्दनकर.
He gets a multimedia speaker. He gets a multimedia speaker. Dr. S.G. Shanbag. Dr. Shanbag gets Dr. Shanbag, you get a microwave dinner set 35 piece. Microwave dinner set 35 piece. Dinner set. It is a Borosil this thing dinner set. Dr. Akash Dhuru 142. Dr. Akash Dhuru 142. Even he gets a microwave dinner set 35 piece. Dr. Sanjay Lakshman Kadam, 148. Always please raise your hand. And he gets a mixer grinder Sumit. तुम निकालो, तुमको निकालना है. Dr. Wadekar, 072. If present, then only raise the hand. Dr. Wadekar. Dr. Sudhir Patil, 265. He gets a Wonder Chef set. Wonder Chef set. Wonder Chef set, a 3 set of pans. Wonder Chef set.
Wonder Chef.
Rajnish Singh 041. But you just have to come and go and give your name, mobile number, all that, because you get a 45-liter fridge LG, which will come for home delivery. We will just give you a box just for gift. You'll get a, but you'll have to give, write your name, address, everything, and we'll just, as a demo, we will just give it. You give your name, everything, because address, where you stay? And the first gift goes to Dr. Shrikant Vagawad 090. Please raise your hand. And it is a smartphone MI19 Active 4x64. Smartphone. Dear. Sushil, smartphone. And that is the first prize. So friends, 12 gifts are all over. Now we will be giving the late bird gift. As you go out, you will be collecting. Please do not go out. You will get to collect your gift as a late bird and then leave. And I now request Dr. Jagdish Kenny to give a vote of thanks. Dr. Jagdish Kenny. Where is Dr. Jagdish Kenny? Huh? Huh. Give your vote of thanks. Take it from there. And we thank all the delegates. Please wait for the vote of thanks. Sushil, file में ठेव. Oh, fridge नहीं लगा.
Hello. I have the privilege to propose the vote
All
of
the
thanks on
managing
behalf
committee
of
members, please
51st
come for a
Annual
photo
Conference
session.
Committee of IMA Mumbai branch. Our heartfelt thanks goes to the speakers for sharing their knowledge, experience and expertise, meeting with the expectation of the audience. Our special thanks to all the pharma companies and hospitals for the educational grant for the scientific session, exhibition stalls and souvenir advertisement. We thank our MMC observer, Sachin Patarkar, for his supervising his conference. Our sincere thanks goes to Mr. Anil Gaikwad and his team for providing the multimedia audio visual extravision. Also, as usual, he has provided his unfailing service with photo shoots and deserves a very special mention in our thanksgiving. We thank the management of Hotel St. Regis for providing the venue and ensuring very exciting culinary delights. Last but not the least, the credit for success of today's conference goes to you, delegate, for your enthusiastic and overwhelming participation. Thank you.
Hello, conference committee members, please come on the stage for photo session. All the conference committee members, please come on the stage for photo session.